3,000 patients. Only 3 patients had pneumococcal infection, and all of them above the age of 5 years. And they don't use penicillin prophylaxis. I mean, I'll say from hematology point, and then Dr. Rana should have to answer from ID point. Now, it is risky. Even in our in Bahrain, we have the Indian haplotype, but we do see a lot of infections. If for patients who are non-compliant with the with penicillin prophylaxis, we do see pneumonias, we do see infections recurrent. Like the simplest, we do see a lot of otitis media, a lot of upper respiratory infections despite being vaccinated. So this is why it is mandatory to give the penicillin prophylaxis, even if we have better gene haplotype or haplotype than the African, which is more severe, and they have worse splenic function or dysfunction. Dr. Rana, from your point, please.
Agree, Dr. Najat, and I think to support our talk, I think we need more study in this gene, more study to say that. And this is maybe a good point to make a collaboration in the research in this project.
I agree, yes, but we don't. I think it's not safe to deviate from the standard of care, and we have to continue penicillin prophylaxis. But at the same time, I mean, we have, even if you say it's a must, you'll find at least maybe 20%, 30% of the patients are non-compliant and not using the antibiotics. And of course, a collaboration and study of comparing these non-compliant with the compliant ones, this will give you a good insight of what's going on and which group scores better.
Agree with you, Dr. Najat. Thank you.
Thank you so much, Dr. Rana. And we move to the next speaker. Our next speaker is Dr. Munir Al-Bakshi. Dr. Munir Al-Bakshi is a consultant pediatric hematologist oncologist at Al-Mana General Hospital. He has held key leadership roles within the Saudi Ministry of Health, including director of the Hereditary Blood Disease Center in Al-Hissa, head of pediatric hematology oncology, and head of child protection team at Maternity and Children's Hospital Al-Ihsa. Dr. Al-Bakshi is an active member and a trainer within the Ministry of Health Hereditary Blood Diseases Committee, and serves as director of the multidisciplinary team for bleeding disorders. Welcome, Dr. Munir.
Hello?
Dr. Munir, yes.
I cannot see my desktop to share it. When I put share, Dr. Najat, you are the one who will. Hello?
Hello. I hear you, Doctor.
Hello, Dr. Munir.
I am pressing the share.
Yes.
But my desktop is not there.
You can just open the presentation first and minimize it in taskbar. Then you can press share screen. You will find application windows and the entire screen. From application windows, you can see your presentation.
When I shared, the presentation is open, then the entire screen is there, but there is nothing.
Application windows, you can see this tab.
I can see Zoom, login page, but I cannot see my desktop to share my presentation.
So maybe send the presentation, Dr. Munir.
Yes, I can send it. Which
Send
email?
send. I will share my email to you.
Okay.
On the same email. The same email.
Okay, okay. Okay, دكتورة منير.
Just send your presentation. I will share from my end, and I will give you the control. You can control your presentation from my end.
What is your email? Hello?
It's all right, Dr. Munir. Send it to my email. I'll send it to him. Send
I
it to my
write it to
email.
you in chat box, Dr. Ahmed at Education. You will find it.
Ahmed at Education. I'll send you to Dr. Najat. To send to Najat.
Send it to me. Okay,
Okay.
I still didn't receive it. Dr. Munir, still I didn't receive your email, please.
To send.
Still I didn't. It's يعني بس لي غريبة إنها ما وصلتني.
My problem. See if Dr. Salih Sharafa is ready. Then
Okay, maybe we'll move to Dr. Saleh. I think yes. Maybe it will be a good idea. Dr. Saleh, are you ready? Dr. Saleh.
Yes, I'm ready.
Okay, so can we move to you before Dr. Okay, so our next
Just
speaker is Dr. Saleh.
allow me to
It's
share,
okay.
and I will do.
Okay, Dr. Zin, okay. We'll move to our next speaker, Dr. Saleh Ashurafa. He's a senior consultant in pediatric nephrology with significant leadership roles in regional professional societies. He is a founder and past president of Arab Pediatric Nephrology Association, as well as founder and former president of Saudi Hypertension Management Society. Dr. Ashurafa serves on European, Mediterranean, Middle Eastern, and Asian advisory boards and has authorized numerous publications, contributed chapters to pediatric nephrology textbooks, and acted as the clinical editor of the Saudi Hypertension Management Guidelines. Please, Dr. Saleh.
Thank you, Dr. Najat. Can you hear me?
Yes, yes, I do.
You can see my screen?
I can, but you need maybe to put it on the slideshow.
Yeah, no problem. Can you see it?
Yes, okay, I can see them. Yes, we can see it. Dr.
Okay, now I would like to thank the organizing committee for giving me this opportunity to talk in this important conference. Today, I will try to shed the light. How can I? Okay. Now you can see it viewed
Yes, excellent,
nicely.
Dr. Saleh. Yes.
Thank you. I'm Saleh Al Shurafa from Saudi Arabia. I will share with you today the important rare, ultra-rare disease shared between hematology and nephrology. And there are a lot of shifts in paradigms almost every 5 to 6 years in this devastating disease. Today, I will discuss off-label uses. I have no financial interest, and I have no intention to impose any methodology or approach or treatment. As you all know, hemolytic uremic syndrome was first described by Geiser in 1955 when he described renal failure with anemia. And then the development moved on. It was recognized as one of the most common causes of acute kidney injury in childhood. But nowadays, adults are even more than kids. In our regions, there is no reported cases in the last 10 years. However, in Arab world, there are some reported cases of classic hemolytic uremic syndrome. All our reports in the Gulf are the atypical form or non-shigatoxin form of TMA, hemolytic uremic syndrome. This is a very old slide at the end of 2010 when we changed the definition of hemolytic uremic syndrome from the classic definition, which is thrombocytopenia, microangiopathic hemolytic anemia, and acute kidney injury, to thrombocytopenia or more than 25% reduction of platelet counts, microangiopathic hemolytic anemia with the evidence of these broken cells, schistocytes, Hamlet cells, etc., plus any one of the following, not necessarily, kidney, renal, neurological, cardiovascular, GI, respiratory, and I'm going to show you some of my cases in these, extra renal manifestations. These people are the international group, the ones who defined hemolytic uremic syndrome. I will start with the classic, which, although it is vanished from Gulf countries because of hygiene, improvement in standards of life, but still it is present in elsewhere in the world. And there is now a trend of increase again of, classic hemolytic uremic syndrome. So when we got ingested the classic 0157H7 E. coli, in 3 days, there will be a diarrhea with abdominal pain, vomiting, etc., the classic symptoms. In 2 to 3 days, it will be bloody in 90%. Culture might be positive, but you need to inform the lab that you are suspecting, otherwise they might report normal flora in some parts of the world. And the diarrhea will improve within 7 days. When it improves, there will be spontaneous resolution in 85% to 90%, or it might lead to hemolytic uremic syndrome in 10 to 15%. These actually collected in very old days. Nowadays, there are only scattered cases. Most of the infections due to these, either E. coli. In our area, there was one case with 026 rather than 157. And these are the cases reported in different parts of the world. Until 2011, when we went to Germany because of outbreak of classic hemolytic uremic syndrome. They reported 3,793 cases, diarrhea associated, 104, it's different, and it characterized by delay in symptoms from ingestion to diarrhea 8 days. The classic is 3 days. 22% developed hemolytic uremic syndrome. But look at here, 88% adults. So it is not pediatric disease, it is all ages disease, and there were 53 deaths. And there is European data, 5.5% developed HUS. This is in STIC cases. And the Gulf, I think the last report of classic came from Bahrain in 2003 from Suleimania Medical Complex, HUS associated with Salmonella typhi and myocarditis, but there was no Shiga toxin producing bacteria identified. Adams 13 and those days was not present in the Gulf. No biological therapy at that time, but patient recovered, alhamdulillah, fully with supportive therapy and antibiotics. And this literature highlighted the presence of atypical HUS in the Gulf. This is the recent trend in the world of classic. It vanished. Sorry. Okay. It vanished through the years until 2018. Then it started increasing, and after COVID, it increased too much again. This is the classic global incidence trend. AHUS complement therapy has become maybe the cornerstone of therapy. And in here, there are some cases which is given some of these monoclonal antibodies therapy, and it was effective as well as the dialysis. If you see here in the global, the adults are much more common than pediatrics. You see here. So it's no more pediatric disease, and our colleague should be aware it's not only the TTP, it's all, again, maybe atypical hemolytic uremic syndrome or hemolytic uremic syndrome. These patients are the patients treated. I'm not going, and this is from global registry from France, German, Polish, etc. It's all indicating the same scenarios. This is a summary of what happened after COVID. There are 84 cases reported with AHUS and 86 cases with TTP because of either the infection or the vaccination. It has been observed that with vaccination, you see here, after the vaccination, TTP is more, while after infection, the disease itself, AHUS is more. But when we read all literatures and revise, COVID-19 infection and vaccination is a potential trigger for onset or relapse of AHUS and TTP, which are both TMA, especially in patients who are not on maintenance complement inhibitor or immunosuppression. And we actually have seen 2 cases with COVID, alhamdulillah, luckily treated with eculizumab. So what is the recommended initial evaluation of the classic hemolytic uremic syndrome? Because of infection trigger both typical and atypical HUS. Initial evaluation should encompass both. Testing should include C3 level as well as classic evaluation, which is stool culture, LDH, smear, of course, CBC and chemistry, Adams, the TS13 autoantibody if TTB not rolled out. And please save some plasma for later analysis when you need. Management is very easy. And the typical, it's mainly conservative. And you can transfer to regional center if there is oliguria and urea or complications of STIC HUS. Conservative by fluid balance, sodium, potassium, acid base, hypertension, diuretics if needed, sodium protein restriction. You can transfuse, but with caution, never transfuse platelets. Avoid antibiotics, anti-motility, because that might activate the disease more, or non-steroid anti-inflammatory. This is the classic prognosis factors for HUS. Maybe our colleagues in pediatrics can read it in Nelson. White blood cells more than 20,000, anuria, microangiopathy of greater than 50% in renal biopsies, greater than age 3 years, 70% progress to end-stage renal disease. Atypical HUS should be suspected in aggressive presentation. And this is the, sequelae, 63% will recover completely. Few percent will have proteinuria, hypertension, or reduced GFR, and only 3% might have end-stage renal disease. This is the percentage mainly in the Gulf combined with the world. This is the definition we put in the end of 2010, thrombocytopenia or more than 25% reduction, microangiopathic hemolysis with elevated LDH, decreased haptoglobin, schistocytes, or decreased hemoglobin, plus one or more of these following. These will recall a diagnosis of TMA. So if there is a neurological symptoms or renal involvement or GI or cardiovascular symptoms or pulmonary symptoms or visual, etc., that will recall the complete diagnosis of TMA. And then you evaluate ADAMS, and ADAMS is available in Saudi Arabia, or you can get the help of Alexon company to send out. And Shigatoxin, both are available in our center, alhamdulillah. If ADAMS is very low, 5%, there are 1 or 2 cases between 5 to 10%, but I consider them TTP. If it is more than 10%, usually ADAMS 60, 70, 90 in AHUS. If Shigatoxin is positive, which take less than 30 minutes to get the result, then it is STIC or classic hemolytic uremic syndrome. I just want to clarify the perceptions that if there is a diarrhea, it is STIC HUS or classical. The medical evidence, diarrhea reported in 30% of patients with atypical hemolytic. So diarrhea is a common feature of AHUS also, not only the typical form. So this is the natural, complement pathway, which is always active. And when there is an infection, it's like a fire, which needs some, people with water to cool it down. These are the water to cool it, otherwise it will be activated and it will burn our body as well as the infection, which might lead to these cell lysis, pro-inflammatory platelet activation, leukocyte activation, endothelial activation, which is very important, and prothrombotic phenomena. These are controlled by natural inhibitors like factor HI, MCB, thrombomodulin. You list it, and there are much more nowadays discovered. So if these are not present, this might lead to sequences like hemolysis, inflammation, thrombosis, tissue damage, which is, again, TMA. mainly hemolytic uremic syndrome, whether it is classic or non-classic. So the complement system is always activated. It is a vital component of natural protective immune system. It is capable of powerful and destructive immune reaction. It simply triggers including common infection, cause extensive complement activation, and natural inhibitors of complements are critical to ensure that immune response remain controlled. This is the case actually I learned from. In old days, we received one infant at 1 year of age with fever, chills, diarrhea. In 3 days, his diarrhea is bloody, which is really classic. In desert, in the north of the Saudi Arabia, they have this tendency to cauterize people with convulsion. So he had a cauterization, but he did not improve. He was taken to local hospital. His creatinine 2.3 milligram per deciliter, which is around 135 micromole, and he has anemia. His platelets is 512. I don't know what was the baseline. So because he got more sick, he was referred to us at day 7 when he became oliguric, and he had been admitted in our hospital with more high creatinine and blood urea nitrogen. His platelets here, 512,000, and here 183,000, which is a huge drop. This is enough criteria, one of the criteria, not necessarily thrombocytopenia to diagnose. We did a stick, it was negative, but he has LDH for 1,925 and shoot up during admission. And this is his blood film, which is classic MAHA blood film. By reviewing the family history after their denial, you see they have multiple deaths because of the disease, and they have affected members, and they have only 2 members of the family. And in here, there is one affected member, which might indicate an autosomal dominant disease. But when we go to family, extended family pedigree, some of their uncles they have, and some they don't have, which might indicate different penetrance in this disease. So he became 12 years age at that time. And, because of this, the classic definition, we gave him supportive therapy. He had been dialyzed with peritoneal dialysis, but because of perforation, we shift him to hemodialysis when he was a small child, infant, which is very difficult to do. He had been transfused multiple times, plasma infusion as in old days, antihypertensive and nutrition and TPN. So he had been dialyzed for 34 days with plasma infusion 14 days, and we are able to discharge him after 38 days, but he remained on anticonvulsants, ACE inhibitors, and we kept him on a plasma infusion 5 times per month, like our protocol 15 years back, and bicarb therapy. Unfortunately, in spite of this management, he had a recurrence with more aggressive disease and very evident disease. So he had been on supportive therapy, plasma exchange, peritoneal dialysis, ventilation, require high frequency ventilation, and nitric oxide. Luckily, he improved and we stopped the dialysis, but he remained on these, antihypertensive, plasma, and anticonvulsants. At 10 years, he had a respiratory tract infection, 10 years of age, and he had, again, recurrence. The conclusion is, from this case, that the thrombocytopenia is not a must for diagnosis. The presence of diarrhea does not necessarily a diagnosis of typical HUS. Atypical HUS frequently demonstrated CNS involvement. Not only the TTP diagnosis does not require genetic identification, because in those old days, we don't have genetic mutation. So the perception that the child AHUS and the adult TTP, I think, is wrong, as we have seen from global registry. And here, the evidence, 48% of AHUS cases have neurological dysfunction, so it's not necessarily the TTP. And patient with increased serum creatinine can present with TTP and AHUS. That's Adams is a must to differentiate between both. This is in old days, in spite of aggressive therapy and plasma therapy, 70% of patients, this is collected from all global registry, 70% of patients with AHUS, lead to real complication like death or requiring dialysis or chronic renal insufficiency or end-stage renal disease. So early diagnosis of AHUS is a real challenge because there is no specific signs or symptoms. It's often diagnosed when there is already organ damage, unfortunately. However, they can present with only proteinuria and thrombocytopenia before the symptoms started. We have one case, and historically limited interest to differentiate AHUS from TTP, as no specific management for AHUS. But nowadays, I think it's extremely important because TTP will improve with the plasma therapy. AHUS, you have to block the complement cascade. And the clinical presentation are similar because they are both lead to TMA. It is rare, but sometimes misunderstood. Lack of clinical suspicion is a real problem, often only considered in children, while adults and adolescents can get it. Throughout diagnosis only confirmed by genetic analysis and identified mutation, but keep in mind that good percentage are not having, genetics, and genetics will take very long, maybe months to get, or you might get it negative, or you really, cannot lead to any diagnosis with only suspicion. So it is not really good for an acute management or acute diagnosis, but it is good for chronic diagnosis, especially when you consider transplants. So AHUS is not only, sorry. Okay. AHUS is not only a renal disease. It can lead to cardiovascular. I'm going to show you examples, renal, pulmonary, and of course, the hematology, which is the essential component, CNS, GI, and impaired, and can be triggered by any trigger: stress, surgery, infection, pregnancy, especially in teenage pregnancies, and etc. So it is a chronic active because of deficiency in inhibitors, which result in vital organ. This is the biopsies from all days of patients. We don't do biopsies anymore. So kidney damage may not be the predominant manifestation, but can manifest on either acute or chronic. 7% of children with AHUS present with only proteinuria and hematuria without renal failure. End-stage renal disease occur in majority of patients, regardless of initial manifestation. But nowadays, there is a shift because of monoclonal antibodies therapy. This is from one of the kids with GI, as you all see here, stenosis, perforation, prolapse, which is in 30% of atypical hemolytic uremic syndrome. So gastroenteritis, ischemic colitis, pancolitis, abdominal pain, vomiting, or pancreatic involvement in form of pancreatitis, or diabetes in some cases, hepatitis, and hepatic insufficiency. I'm just going to give you one example. This is 12-year-old girl with atypical HUS, no identified complement gene mutation. She developed generalized edema, oliguria, nausea, vomiting, and abdominal pain with all of these, anemia, thrombocytopenia, cystoside, and she was diagnosed to have hemolytic uremic syndrome. She was started on aggressive plasma exchange and dialysis. 30 days, she was having convulsions, and she arrested 2 times in 50 days, 3 times arrest. So it is really aggressive disease. So in 3 months, she's having persistent TMA, and we were struggling, and bloody diarrhea, etc. And this is extensive ulcerative lesion by endoscopy. Here in 2000 May, before even FDA approval, we were able to bring the eculizumab therapy, and we start eculizumab with the plasma exchange, because at that era we are learning, but we got amazed that TMA resolved completely, and there is no subsequent TMA, and now married with 1 kid. This is another case. As you all see here, there is facial palsy, and you see how the effect on the MRA, and because it is reported in 48% of atypical HUS. So it is not only the TTP, it is AHUS, which might be even more common than TTP in aggressive neurological symptoms, although neurological symptoms more common in TTP. So this can lead to cerebral infarction, coma, seizures, dysarthria, aphasia, facial paralysis, confusion, etc. So CNS complication in AHUS are observed in 48%. It can occur without laboratory signs of complement amplification. Case reports have demonstrated that the eculizumab reversed the CNS complications in patients with AHUS. This is a girl with TMA, AHUS. She was managed by monoclonal antibody therapy, and she left to other region. Unfortunately, the monoclonal antitherapy was stopped to again investigate her. She was having factor B deficiency. She had myocardial infarction, and it lead to malignant hypertension, severe stenosis, and death. Sorry. This is again 12 years. She had AHUS end stage, and she had renal transplant, graft loss with subsequent TMA, especially with calcineurin inhibitors. She had been on this therapy, but she had played with the therapy, so she had a second renal transplant. And then we increased her therapy, and there is no subsequent TMA, and she is doing well till now. This is another child, 4 months old. You see with hemolytic uremic syndrome, and you see here, it's almost loss of the finger. When we block the complement cascade, this is what happened. This is from French literature. And this is our patient, actually, see here. And we were about to amputate. We start the therapy, and alhamdulillah, it was successful. This is from one of our neighborhood country. He was brought with hemolytic uremic syndrome. He has pulmonary embolism and hemorrhage, devastating, aggressive disease. And luckily, we managed, and he improved, but he remained hypertensive. Till now, he is on antihypertensive, and we shift him from eculizumab to ravulizumab because it is long-term therapy and not every 2 weeks therapy because he is from other country. So genetic deficiency in complement regulatory gene, it is caused by chronic uncontrolled complement activation. Complement-mediated TMA leads to systemic organ damage, as you all seen, and maybe sudden death. And despite of plasma therapy, with 1 year of diagnosis, more than 50% of all patients either die, require dialysis, or have permanent renal damage. Diagnosis of early signs and symptoms is critical step to transform the lives of AHUS patients to successful life. So AHUS is not only a pediatric disease that affects all ages. It's a chronic, genetic, and lifelong. It is a systemic disease and affects multiple organs, not only the kidney and blood. It is genetic. Maybe it cannot be identified in many patients. Plasma exchange and infusion, although it is good, but it is not enough therapy. So what is the advances nowadays? The eculizumab remains the first line, but ravulizumab offer longer dosing instead of every 2 weeks. This can be given every 6 weeks, and there are new agents under trial now. And this is the most common 2 agents. However, there is expanded gene spectrum like DGKE or NF2 in addition to CFH, which are non-complement pathways. So I don't think these therapies are effective. These, although the company is claiming that these are effective, I've tried, but I did not see any effect. Autoantibodies to factor H seen in pediatric relapsing AHUS, biomarkers under investigation for disease activity prediction. So there is improvement in diagnostics in HUS, like renal Doppler resistive index. If you look, unfortunately, I did not put the picture, you will find it reverse. Instead of the peak, like this, you will find it like this and slow. Early complement testing to distinguish AHUS from TTP is very important. Adams, TS13, and chigatoxins are recommended. You have to treat the bacteria by vaccination. Better 2 weeks, but if you cannot, you can start your therapy and vaccinate until the vaccination gets its effect. And some people are giving antibiotics during the eculizumab or ravulizumab therapy. Genetic testing is essential before related kidney transplant and not necessarily for every child. The take-home message here is complement plays a primary role in pathogenesis of both HUS and AHUS. AHUS, acute kidney injury, thrombocytopenia, microangiopathic hemolytic anemia with normal ADAM, TS13. Both HUS and AHUS are associated with extrarenal manifestation and diarrhea. Serum and plasma level of complement protein should be measured in all patients with primary AHUS. Genetic analysis is essential in living-related kidney donor transplantation, but not essential in diagnosis. All patients with clinical diagnosis of primary atypical hemolytic uremic syndrome or non-Shiga toxin are eligible for treatment with either eculizumab in acute, rivaroxaban in maintenance therapy. However, treatment duration is controversial, but in some cases, we try to either withdraw or prolong the interval with critical monitoring of patients, and I think we are so far successful, but we need to watch ourselves because medication is very expensive. If access to eculizumab or rivaroxaban is unavailable, stick to plasma exchange therapy. I thank you very much, and I am happy to receive questions.
Thank you so much, Dr. Saleh, for the real excellent presentation and coverage of the HUS, HUS and AHUS in pediatrics. Now we move to Dr. Munir Al-Bakshi. So, Dr. Munir, are you ready? Thank you, Dr. Saleh. Dr. Munir.
Yeah, I am ready, but I
Please.
need.
I will share
the
from my
control
end, doctor.
All right. Bismillah ar-Rahman ar-Rahim. First, I will thank Dr. Anjat and the organizing committee for inviting me for this very extensive conference. How I can get the control now?
You already get the control, doctor. You can control.
Okay. The control. Who's okay?
Munir, you can press the TV bar, the one on your right side, and it will appear full in your screen.
I will put
Which
for
one?
him. Just a second, doctor. I will make slideshow for you.
Yeah, excellent. Please, Dr. Munir, start.
Yeah, I'll talk today about iron deficiency and iron refractoriness, especially in iron refractory iron deficiency anemia in children. Iron is very essential element in our body. You can find it. This is one of it is a trace element, but at the same time, it is one of the biggest trace elements that ever found in our body. We need the iron to be deposited in our body right from the beginning of the pregnancy when we are in utero. So the mothers, they will get and they will consume good amount of iron. Then in the third trimester, in the third trimester, we will find that the mother is loading the iron to the fetus. But there are a lot of noises in the background. And so if the patient is prematurely born, then the iron stores will not be enough for the patient. The stores is usually is good for 5 months of life. Then the introduction of the weaning food, and when it is not rich in iron, or if the baby was not given iron prophylaxis, then the baby usually will end with iron deficiency anemia, which is usually underestimated in all communities, not specifically in our community, but it is worldwide. It is stopped now. It is not working now. the control. You can see here is the iron is mainly in our red blood cells. This is the major site where it is being stored. Then it will be followed by what is in the liver, bone marrow, the bone marrow, and other tissues. But you can see that there is in the reticular endothelial system, when we have got ineffective erythropoiesis, this is the least organ or place where we can utilize our iron from it. What is the function of the iron in our bodies? It is essential part in our hemoglobin, in our myoglobin, especially for gas exchange, for oxygen to be delivered to the tissue, and for the carbon dioxide to be exhaled through our lungs and by another mechanism in the muscles. Plus, it is enzyme, very important catalyzing enzyme, especially in the cytochrome system, and transferrin as a protein, and even in the DNA replication, which is very essential. And if it is affected, then later metabolic disorders might be there. See, so this is the hemoglobin, which is found in the red cells, and you can, you know that almost we have 250 million hemoglobin molecule per each red cell, and you can see the iron is there for ready for the gas exchange from the oxygen and carbon dioxide. So we have good amount of iron. In the myoglobin, it is found in the cytoplasm. It is shifting, if you can see the iron, shifting the oxygen dissociation curve to the left side. That is, they want to preserve oxygen for good function of the muscles. Again, it is a place where we store the oxygen and we use it in buffer and facilitate the oxygen diffusion from the muscle itself. Cytochrome B450, this is super family of enzymes. You can find it for many essential catabolic and metabolic pathways. And it is very, nobody can function or live without the cytochrome B450. And the iron is very essential, as you can see in the ring. It is middle of the ring here. So it is again important. DNA replication is there. What are the types of irons? We have two types of irons. We have the heme, which is animal we get it from iron, the iron from animal, and non-heme iron. This is plant iron form, and we have differences in the absorption and but not in the utilization of them. These are the heme iron sources, and this is non-heme iron source. The iron is very important, as I mentioned early, in our early life. It is very important because we need it for gene in the DNA. We need it in the brain for neurochemistry, neuroanatomy, and the neurometabolism. So it is very important protein profiling agent that will improve the neurophysiologic mechanism, which are the cognitive function, the sensory and motor system, and for the affective and social life. So if this iron will be disturbed early in life, then we can get problems which is manifested clinically by iron deficiency in early life. So we need to pick up these patients and treat them promptly. The iron, what is ingested from the gut as normal, then to be absorbed, then to be utilized. Under these conditions, there are host factors that affecting the absorption, like genetic background, the genetics of the patient, the physiology, the physical activity of the patient, the microbiota in the gut, and the disease status. So chronic inflammation can cause problems. Environmental factors, if there are presence of toxic agent, and socioeconomic status because of poor availability, and cultural things. One of those environmental factors that affect the absorption, the presence of inhibitors. So we need, one of them is some of the behavioral abnormality, like pica, for example, when the baby or the patient ingests abnormal material that interfere with the absorption. And presence of enhancers, or those who are affected negatively. So vitamin C, it will positively affect the absorption, where calcium, caffeine, tea, and coca will affect negatively the absorption of iron. Now for the regulation, because we have two types of iron, so we have non-heme iron, and the enterocytes, we need it to be in the ferrous state, which are combined, entered through the divalent metal transporter, DMTA1. So for this mechanism, then because it will go by protein, and the ferroportin will take this iron inside the plasma, where it will be stored and will be distributed. Whereas the heme, the animal iron, will be absorbed through the heme carrier protein. And you can see this is a thing, it will come through this channel. Then this iron will be transported by the ferroportin again, and it will be utilized. And all this will be under the effect of protein, which is the main regulator is the hepcidin, and we will talk about it at later stages. The difference between the animal and non-animal iron, which is the heme, is the more important for us because it is more readily available for absorption than the non-heme iron. Here you can see that the iron, when it is in our body, then it will be distributed from the gut itself. It will get absorbed. It will be transported. It will go mainly into the bone marrow under the effect of the liver. Why the liver? Because of hepcidin will be produced of the liver. Then it will be recycled, and the uptake of this element, which is very essential, under the influence of this gene product. So now hepcidin, it is, as I mentioned, it is produced by the hepatocyte. It has a central role in the regulation of iron metabolism, whether it is absorption and recycling. And it is under the effect of HAMP gene, which is small peptide, is 84 amino acid. Then the active form, it is the 25 amino acid, which regulate the homeostasis by blocking the iron transport. So the iron will come from the gut inside the enterocyte, but the regulation of being absorbed or released into the bloodstream, it will be the effect of the hepcidin through the degradation of ferroportin. So it is very important to inhibit iron absorption, even from the macrophage, which is the other source of iron metabolism. Hepcidin can be regulated and enhanced by the status of iron, and by which is, if you remember the previous cartoon, I mentioned this gene signaling agent, and the presence of inflammation, they will enhance the hepcidin, which will cause a problem in absorption if it is inappropriately more than the normal range. Then we have hepcidin suppressors. All this is from the erythropoiesis and from stressor organs like the sex hormones and the growth hormones that will be negatively affect the hepcidin regulation. For the iron excretion, we don't have, as a human being, we don't have a mechanism for iron excretion. We have mechanism of preserving iron because it is very important element. But sloughing from the intestinal mucosa during the natural process or because of disease, then it will cause sloughing of the iron itself during menses and women, and exogenous mechanism by either phlebotomy or by iron chelating agents like in beta thalassemia. Or here you can see the controllers, how many controllers that we have of iron in our body. We have a lot of them, and in each gene you will find it is in very different chromosomes. Some of them they are X chromosomes, and many of them they are somatic chromosomes. And if there is any problems in regulation, then there will be a disease manifested as iron deficiency plus minus systemic illnesses. This is another cartoon which is busy, but just I wanted to show you how the iron is important in many organs and under influence of many genes. Now, iron deficiency, it is the commonest anemia in the world. That is 1/3 of the world population, they got iron deficiency anemia. And you can, under the age of 4 years, it is estimated between 46 to 66% in those kids. WHO is recognizing that iron deficiency is affected it is in the 10 leading risk factors for the diseases in the world. And the US, 2.4 million, they are iron deficient. And you can see here, this is from I got it from the WHO. You can find the iron deficiency and the iron deficiency anemia, because it starts as iron deficiency, then the clinical manifestation of iron deficiency. And it is distributed evenly in both sexes and in all ages. In Saudi Arabia, there are several studies. This is from Medina. It shows that 50% of our kids, they have iron deficiency anemia. How iron, the process of iron deficiency. See, the left side is the normal red cells, the normal studies here. You can normal hemoglobin, RBCs indices, iron stores, and bone marrow stores. But when the iron start to be deficient, then what will happen? We will consume what is in the stores first. Then the iron stores will be depleted, ferritin will be low, bone marrow stores will become low. Then the third stage, which is the marginal iron deficiency, that is partly start, the bellar will start. Then iron stores will be more depleted. The erythropoiesis will be affected. It will be low. Transparent saturation will be low, and the hemoglobin borderline normal. But when you get the true iron deficiency anemia, then the iron stores will be exhausted. The hemoglobin, hematocrit indices, all of them will be low in these patients. This is why when we get a clinical, then be careful that this patient was cooking iron deficiency months and months before he become depleted. What is the best diagnosis of iron deficiency? You know, the patients, or even when the kids, they will come into for normal lifestyle like vaccination. These kids need to be checked out, and knowing what is the normal thing for them, their diet, their developmental milestones, to check the presence of Beller, then to check their CBC. And it is one part of the preventive program in Saudi Arabia in the primary health care is the annual checkup about CBC and iron. And this is why when they found it is a lot, then they introduce the iron prophylaxis from the age of 4 months. Serum ferritin is the gold standard for the iron stores estimation in absence of inflammation. So we should get C-reactive protein will be estimated at the same time. If ferritin less than 15, this is iron deficiency. If it is more than 15, it is, but it is less than 50, then there will be iron deficiency. It will go into the clinical status, and very important in this patient. Then now let us talk about ferritin. Ferritin is the main bulk of the stores in our tissue, but some of this ferritin will escape into the bloodstream, and it will be then it will be tested. We can quantify this thing by an immune state. And there is, if the patient without inflammation or infection, then it has very direct relationship between the iron stores and the clinical parameters. And as mentioned, levels below 15 microgram per liter is predict very high likelihood of iron deficiency, and even 30 micrograms is still consistent with iron deficiency, but it is less specific than less than 15. Iron, serum iron is measured. It is very common to be measured, but it is not specific for iron deficiency because it is variable. There are diurnal variation in this thing, and it is best to be measured with the iron binding capacity to get the total binding capacity, so we can measure the transferrin saturation, and the normal up to 70% and above as a ratio. If it is the ratio is less than 15, then it will support the diagnosis of iron deficiency. And this is very excellent evidence-based. Other studies that is, for us, it is like something which are research thing for iron deficiency, which is a soluble transferrin receptor, and zinc protoporphyrin. They are very important, not in the iron deficiency, but in other conditions. Hepcidin is not necessary to be measured, but for other conditions need to be done. You know that we are facing a lot of kids with iron deficiency. Many of them, they don't have good response of iron deficiency. Many of them, because they are using suboptimal therapy, either duration or doses, non-compliance, presence of inhibitor like BICA, or inflammation, or there are inherited diseases like which are causing iron refractoriness. And you can see here there are problems with iron uptake, problems absorption, iron recycling, and defective in the mitochondria, and causing these diseases which are genetically modified or responsible for them. If you can see, this is a beautiful adult study for iron refractoriness during iron deficiency anemia. They found there are autoimmune gastritis, H. pylori, menorrhagia, gastrointestinal lesions, celiac disease. See, celiac, it will cause 100% malabsorption from iron, and the other conditions, they are ranging between 38 to almost 70% of unresponsive to iron therapy in iron deficiency anemia. See, these scenarios for those are suspicious of iron refractoriness and poor iron absorption. When patient be diagnosed with iron deficiency at the age of 15, she was giving iron deficiency, she was regular, there was no pica, even she is old, and there is no abnormal bleeding. H. pylori was negative. See, the patient peripheral film is so deficient, microcytic, MCV is low, serum iron is low, iron saturation or transferrin saturation is low. After 1 month of oral therapy, there is no much change in the hemoglobin or the other indices. After 3 months, the hemoglobin was increased. But when they have introduced the patient to IV iron, the hemoglobin increased with increase in ferritin. Unfortunately, we didn't see the transferrin saturation here. Another case which are suspicious of iron refractoriness, this 15 years old boy who was referred to us with persistent pallor despite iron therapy, and the patient was on good oral therapy. He was challenged with overnight with iron orally. There was no change. Then IV iron was good. Then it didn't increase with time. So these are suspicious of iron refractoriness, iron deficiency anemia, which is first mentioned in the history by Dr. John Buchanan in 1980 about microcytic type of anemia with low iron, and they are not responding to iron sulfate. Then Dr. Brown in 1880, he found there are several members of a family, which is, he was querying if it's inheritable disease. Then Hertman, he found that definitely malabsorption in these kids. Then it was highlighted that it is autosomal recessive pattern in conditions. Then the discovery of the abnormality here, which is Timber SS6 gene mutation, which is causing this condition. So the etiology is a problem. This is the normal, where you can get the timber here, timber SS6, which is normal. Then the iron will be absorbed, and there is the messenger RNA will activate that gene to allow the iron entry and to be responsive of iron. But in IRD, there is abnormality here in the gene. Then there will be abnormally elevated, and the end result, abnormally elevated hepcidin, which is preventing the absorption or the completeness of absorption of iron through the enterocyte. So this is what happened. This is the normal, the enterocyte and the macrophages. When the iron will be available at the end, then it will be get absorbed and it will be attached to the protein absorbers. You can see here. But in iron refractory, iron deficiency anemia, the iron is there. It will come inside the enterocyte, but it will be get blocked because of high elevated hepcidin here. And mutant gene. And again, similarly, inside the tissue macrophages. When you get oral therapy with this condition, again, you will find the same thing. You are just loading iron in the gut, but nothing will happen in the bloodstream. And when you are using parenteral iron, you'll find that you get good amount of iron will be absorbed because you are bypassing this inhibitory condition or inhibitory mechanism. So what are the characteristics? These are patients who are diagnosed as iron deficiency anemia. They are very variable in their response to the iron, poor oral. Many of them, they are shifted. It starts usually in pediatric age group. It improves after adulthood because of many mechanisms. So they have low circulating, as I mentioned, serum iron and transferrin saturation. and those minimum responses. But when you get the hepcidin, here the hepcidin measurement is very important. So in male, you can find this, they are less than 1.6, they are diagnostic of this condition. And in female, less than 1.9. So again, when we are comparing iron deficiency anemia with aridity, and when the patient is having chronic inflammatory process, so we need to know that in iron deficiency, all parameters, they are low, with the transferrin saturation is less than 15%. When you get chronic disease, then again you have the transferrin saturation is low, iron ferritin is low, but it could be borderline or even reached up to 100 because of the inflammatory process. When you have the problem, when you get iron deficiency anemia with chronic inflammation, then you will get more confusion, but you have the soluble receptors to be measured or be high. Again, when you get iron refractory iron deficiency anemia, you'll find the transferrin saturation mainly it is low, definitely low. Serum iron is low. Ferritin could be normal in these patients, and there will be changing in the transferrin saturation with time, and you find that the very poor response to oral iron therapy in the three conditions, except in iron deficiency when it is absolute. And this is a case of iron refractoriness, which is the inherited form, a patient being followed with IV iron, but it is not a regular iron therapy. You find that the hemoglobin is going up from 10, it reached to almost 13, but when the patient is stopping iron, the hemoglobin will come down. And but see here the ferritin and transferrin saturation, it is very variable. You can see the ferritin can reach to 350 in this patient, and with therapy it reached to almost 900 in this patient. But it is not sustainable, so it is coming down. Again, transferrin saturation is critically elevated, then it is coming down to less than 5% in this patient. In another patient, you can find when it is this aridity with chronic inflammatory disease of any systemic disease, then you can find that the hemoglobin is variable, the transferrin saturation and the C-reactive protein is very variable. You see there is good relationship between the dotted area, which is a C-reactive protein, with the hemoglobin, making the response of iron therapy is poor. And this is the red thing is the iron therapy. When you are comparing it with the ferritin, then you will see that this patient, sometimes the ferritin is very, very low, or if it is then with exacerbation of inflammation, it will go up again. With the transferrin saturation, again, is very variable. And then transiently, it will be normal, but it will go back again. So what to do with these patients? Those patients initially diagnosed with iron deficiency anemia, then you make yourself sure that the oral for 3 months it is very compliant, no inhibitors. You test for it. You get the gene which is abnormal. The hepcidin transferrin ratio is diagnostic in these patients. Then what to do? What you should do, and this is the consensus of the expert on iron deficiency anemia, which is just recently published 2 months ago. They are recommended to initiate the IV therapy after the 3 months, as mentioned, and to attempt for personalized medicine here. Check what is the level of hemoglobin that you are targeting, the transferrin saturation that make the the patient activity, the child growth, they are, and the development is normal. So don't treat each one of them at the same with the same levels. So some of them you need the transferrin saturation will be above 20. Some of them you need them 25%, and the use of iron therapy should be with the parenteral optimal therapy, because some of the the IV iron therapy, they are not optimal, like ferric carboxymaltose, and the other the sucrose iron is more suitable, and you can give it the problem that you can give it more frequent than the carboxymaltose. So you can continue with it, and you adjust the therapy, as we mentioned, according to the transferrin saturation. Then we have to treat the patients according to the condition, reduce the inflammation, control the systemic illnesses, treat the celiac diseases, avoid their triggers. Then their recommendation is continue therapy for life, but they mention you will that depending on the literature, the requirement of iron therapy will decrease with life. Is there any other management other than iron? Yes, there are, because we knew that the problem with the hepcidin, it is not being suppressed and elevated levels. Then there are in the pipelines, in the pharma, there are anti-hepcidin antibodies. They can target it. Then the iron absorption will improve, or when there are this medication which antagonize the hepcidin, that is block this, antagonize it, and there are pegylated anti-hepcidin, so you can take it with longer time, and gene therapy, which is in the future. I think this is the summary. This is of what I mentioned, how to treat the iron deficiency, then suspect, diagnose, gene therapy, start the parenteral iron as mentioned. In summary, iron refractory iron deficiency anemia is inappropriately elevated hepcidin and impair the iron availability from the gut. So it is not available for the erythropoiesis and not available in the tissue. It is overlap with other features of iron deficiency anemia and anemia of chronic diseases. So we need to distinguish both of them, or when the patient have comorbidity. Structural approach to those patients with iron deficiency, with oral iron therapy, then label them, check your hepcidin and transferrin saturation ratio, then treat this high hepcidin by bypassing it with IV iron, with the optimal one, then control it according to the patient need. The kids, they need more iron for their growth and their brain development more than the adult. But the daily, day-to-day activity is very important for those patients. And we are lucky in the future to have more and more medications or gene therapy for this rare but very important conditions that we are facing, and we might missing it in our clinics. And thank you very much, Doctor, and for the audience.
Thank you so much, Dr. Munir, for the excellent presentation. You've covered a very common and very important topic, and it's really common in common disease in pediatrics and also in all over the world. So we have two questions for you, or maybe one. In the presence of infection, what level of ferritin is taken as indicative of iron deficiency?
I didn't get you, Doctora.
I mean, the
In the
question is if in the event of infection, so what level of ferritin you would consider it as suggestive of iron deficiency?
first, the clinical picture of iron deficiency, the indices they are low. Transferrin saturation should be very important measurement that is less than 4, less than 15, and again, the serum ferritin is variable. If the patient is anemic, then this is a thing. And C-reactive protein is very important in as indicator inflammation, which will tell us that we should dig more about this patient to treat his chronic disease.
Yes, I mean, يعني ideally we shouldn't do ferritin during infection, but I mean, you have other indices, other things to support iron deficiency. Another question for you, Dr. Munir.
Doctor, I not
The study,
mention there are inflammatory disease like systemic lupus, like any other systemic illnesses. That this is what I meant. Yes.
will elevate, yes, the serum ferritin. Okay, so there another question for you. Studies using liposomal iron. What is the recommendation in iron refractory anemia?
No,
Means would you
see,
recommend the liposomal iron for patients with
so, Doctor, all the parenteral, they are good, but except for those who are not
Dr. Munir?
optimal or those with side effects like carboxymaltose. We get a couple of patients with hypophosphatemia that
No,
the
no,
patients
oral
they
يعني yeah.
oral, no, oral, لا. We cannot get oral in IRIDA. IRIDA is
Okay.
parenteral.
Okay. Yes, okay. I mean, already Dr. Munir answered that the absorption is not good, even if it's liposomal, it will be suboptimal response. Okay, thank you so much, Dr. Munir. And now we will break for prayer and lunch, and we will start sharp at 1 because we have so many speakers for in the afternoon. So thank you so much for our distinguished speakers, and thank you so much for the audience, and looking forward to welcome you back at 1 p.m. So bye for now, and see you at 1 p.m.
Assalamu alaikum. Good afternoon, everyone.
سوري.
السلام عليكم دكتورة نجاة.
هلا هلا، عليكم السلام ورحمة الله وبركاته.
لكم مساء، يعطيكم العافية، جهودكم جبارة.
الله يعافيك. بس تعرف انت الحين you're ready صح؟ لان بس انا بس اقول ويلكم والفيرست سبيكر. اوكي اذا
Yeah,
صار
no,
ساعة واحدة لان عندنا a lot of speakers.
so I can share my screen from my end,
If
correct?
you wish you can. If you wish لان انا بس بقول ويلكم يعني ما في شيء. I will introduce you. So if you wish yes share يعني screen share from now so it will you can start يعني immediately بدل ما يضيع الوقت بعدين على الهادي. Screen share from now it will be good.
You can see my screen, correct?
Yes, Khaled. Excellent. Yes, I can.
Good afternoon. Are you able to hear me?
Yes.
Yes.
Yeah, it's Dr. Valentino. Can you allow me to share my video so that you can see if it's okay?
Yes, if you wish. How you want do you want them to help you? Means to screen share from our side?
Yeah, if you can, because I when I click on video, it
Okay,
says
okay,
I
okay.
can't
But
start
you're
it
the
because the host has disabled it.
sure. Proflan, do you prefer that you يعني you're the last speaker, but in a sense you're here. Is it that you want to present earlier?
No, I can present at the appropriate time, but I just wanted to make sure that my
Sure, sure. I will ask him.
iPad was
Okay, I
working
will ask
correctly.
him to
I'll
definitely,
stop
definitely.
sharing. I'll stop sharing
Okay,
from my side to allow you
okay.
to share.
Excellent. Okay.
Yeah.
So I believe you can share now.
No, I can't start my video. It says you have it disabled. The host has it disabled.
Yes, because Khalid is screen sharing. Khalid, can you stop screen
I
sharing
did.
please عشان بس
Oh, there we
دقيقة.
go. Now it's
I
fine.
did. I did already. Yep.
Okay.
شكرا.
Okay, so it looks like the video works and you can hear me.
Yes,
Okay.
we do.
And then will you be able to project the slides for me?
Yes, if you wish, yes, we can.
That would be perfect. Okay, I'm good. Thank you. Sorry for the interruption.
Thank you so much. Thank you
Yeah,
so
of
much.
course. Thank you.
اوكي خالد بليز الحين هذه شكرا. Welcome back. We'll start now the second session of day 2. Our next speaker is Mr. Khalid Al-Habaib. He's the unit manager of the Pediatric Hematology Oncology Unit at the Tawam Hospital, UAE. He holds a baccalaureate of nursing from the University of Jordan and a Master of Science in Healthcare Administration from University of Atlanta. Currently, he is pursuing a second master degree in Global Child Health at St. Jude Academy, USA. Mr. Khalid is actively involved in hemophilia care, serving as nurses committee for the member for the World Federation of Hemophilia and the General Secretary and Hemophilia Nurse for the UAE Hemophilia Group. Welcome, Mr. Khalid. Please start.
Yes, Assalamu alaikum. Thank you so much, Dr. Najat, for giving me this privilege to be part of the 6th International Pediatric Hematology Conference. And I also extend my deep thanks to you and the organizing committee to a dedicated time in this program for nurses. Yes, my name is Khalid Al-Habaibi. I am a pediatric hematology oncology nurse, and I'm interested in bleeding disorder and hemoglobinopathy. Today, I'm going to speak to you about the nursing holistic impact on the hemophilia care. This is my objectives for today, and this is what I'm trying to speak to you today. So, as we all know that hemophilia care, it's a complex, multi-system, and dynamic, required a comprehensive management. But it faced many critical gaps. This includes challenges such as access to care, access to comprehensive care centers, factors availability, cost, whether this cost is a direct cost or indirect cost, deficiency in support services, and deficiency in support in qualified, competent healthcare provider, specifically nurses. Hemophilia is a specialized field that highly demands on trained nurses to provide a comprehensive care, required specialized knowledge and skills due to the unique challenges associated with hemophilia. Lack of hemophilia nurses contribute to suboptimal care, resulting in increased complication, poor quality of life for hemophilia patients. Despite the growing complexity of care required for hemophilia and for individuals with bleeding disorder, there remains a significant shortage of specialized hemophilia nurses worldwide, not only in our region, but across the high, middle, and low-income countries. This shortage poses major challenges to deliver of comprehensive care. There is strong evidence from the region indicating the severe shortage of hemophilia nurses, which continues to hinder the provision of optimal care for individuals with bleeding disorders. The World Health Organization has long recognized the vital role of nurses in enhancing healthcare outcomes. In acknowledgement of their contribution, the WHO designated the year 2020 as the Year of Nurses. This global recognition highlighted the critical impact nurses have on patients' care, safety, and healthcare and health system resilience. In alignment with that, with this recognition, the World Federation of Hemophilia has been instrumental in advancing nursing practice, particularly in the field of bleeding disorder. WFH actively support the professional development of hemophilia nurses by offering upskilling courses, educational resources in multiple languages, thereby promoting equitable access to knowledge and best practice worldwide. These initiatives empower nurses to expand their clinical role, enhance patients' outcome, and contribute to a comprehensive hemophilia care. Now, as we all know that nurses previously used to do a traditional role, where the nurses treat, the opposite of bleed, replacing a factor, doing kind of triage. But nowadays, the hemophilia nurse role being extremely expanded to a higher level, where we have specialized hemophilia nurses, we have practitioner hemophilia nurses who's running the service alone with the support with other healthcare provider. I don't mean that nurses can replace physicians here, but they can be the right hand of the physician who can really extremely involve in improving the outcome of bleeding disorder and hemophilia patients' care. Now, what's the expanding role that hemophilia nurse taking nowadays? Now, the hemophilia nurse systematically gather details patient's history, include bleeding episodes, family history of a bleed disorder, previous treatment, response to the therapy, accurate documentation, support diagnosis, and ongoing care planning. Also, they take a major role and vital role in educate patients and families in the central role. The nurses teach about hemophilia types, signs of bleeds, the importance of promote treatments. They teach patients on prophylaxis protocol and safe physical activities. Also, their education goes extremely beyond that by teaching some of the patients on self-infusion technique. With having specialized hemophilia nurses, help us to convert, a hospital-based or clinical-based infusion to self-infusion, where patients, they can infuse themselves. Also, the hemophilia nurses participated in treatment decisions as a part of multidisciplinary team. Hemophilia nurses contribute clinically insight to treatment planning. They help to assess the effectiveness of therapy, patients' adherence to treatment, the lifestyle of our patients, thereby influencing the choice of factor replacement, whether it's factor or non-factor therapy. And also, they coordinate the patient's care. Hemophilia care involves various services: hematologists, orthopedics, physiotherapists, psychosocial support. The nurse ensure seamless coordination, arrange referrals, follow-ups, and manage the care plan, and act as the primary point of contact for patients and families. On top of that, they play a major role in collecting data. So nurses are responsible for collecting data related to bleeding episodes, treatment outcome, infusion log sheets, adverse events. This information is essential for a clinical evaluation, national registry, and quality improvements. As well as we participated in a lot of ongoing research in the region and international. The World Federation Hemophilia Nursing Committee recently, we published three papers in the international journal. And nurses, they can conduct their own research in order to improve the bleeding disorder and hemophilia patients' outcome. Despite the growing complexity of hemophilia care, several challenges continue to hinder the optimal delivery of nursing service in this specialty. Now, as a nurses, definitely, we are facing a lot of challenges. These challenges, such as insufficient curriculum, many nursing programs in the universities and college lack a comprehensive content on bleeding disorder, leading to a gap in fundamental knowledge of graduate nurses. The new graduate nurses, they have very limited opportunity to hands-on experience with hemophilia patients. At the same time, we are suffering from the severe shortage of the workforces. The workforce shortage places added pressure on existing staff nurses, affecting the quality and the continuity of care. At the same time, we don't have a specialized education program to occupy our nurses with the knowledge and skills to become a hemophilia nurse. This lack of structured training or certification program in hemophilia nursing limit professional developments. Government prioritization. Unfortunately, hemophilia is a chronic disease, and most of the healthcare system in our region focus on acute disease, and they don't pay full attention to chronic disease such as hemophilia, which left the nurses with insufficient policies supporting their education, their professional growth. Healthcare system limitation. Fragmented system and lack of MDT collaboration hinder comprehensive care provided to patients with hemophilia. And unfortunately, and I believe this is across the region, we have very limited resources, where we have limited fund to sponsor nurses to attend such, for example, this conference, to go for upskilling courses, workshop, and we have severe shortage of protected time. So most of the organization in our region, they don't really provide a protected time for nurses to continue their education and improve their knowledge and skills in order to provide such core group of patients like hemophilia with a comprehensive care that we all aiming to. Now, what are the consequences of shortage in hemophilia nurses? Now, this is going to lead to increase, the patient's nurses ratio. So nurses will feel overburdened and struggle to provide individualized care, which impact the quality and the safety of hemophilia patients. And this is negatively impact on the level of support to patients and families, where limited time for nurses and resources will limit, the time they spend with the family to educate them about their disease, to support them emotionally, and to guide them within the organization. And will increase the risk of complication and delay if you don't have qualified nurses or healthcare provider. This is gonna lead to delay in assessment, at the same time delay in intervention, which may lead to preventable bleed deposits and long-term joint damage. And again, we are facing a delay in treatment initiation. Insufficient staffing can result in lower administration of factor replacement, especially at emergency setting, where we are expecting that our colleague on emergency, whether physician, nurses, they are familiar with bleeding disorder and how to treat the bleed. But in fact, because of lack of education for them, they are not really familiar like specialized people. Now, in order to close this gap, we propose strategy. And this strategy is six-step strategy. The first step is to communicate with the higher educations department, like university, nursing college, to integrate and incorporate hematology content to their nursing program, and to give more exposure to the new graduate nurses to hemophilia and bleeding disorder. Again, in order to have specialized people, we need to have a specialized program. Here, we need to create a hemophilia nursing education program, a comprehensive, specialized, accredited program where graduate nurses from this program will be occupied with the knowledge and the skills, allow them to be specialized in hemophilia and bleeding disorder care. Again, we need to emphasize and advocate for a policy to support the ongoing education for nurses by providing them with adequate support, whether it's financial support, protected time, and to help them to advance their career, to become specialized in certain field, like hemophilia. Now, again, we need to emphasize more in creating a full time of hemophilia nurse. This hemophilia nurse who's going to take and lead the hemophilia and bleeding disorder service within the organization. Most of the organization in our region, they don't really recognize the importance of having a specialized nurse in hemophilia. We have a very strong evidence that having such a specialized nurse will improve the outcome, increase patients' family satisfaction, and decrease the treatment cost, whether for organization or patients and families. Now, nurses do not work in a silo. We are working collaboratively close with the key stakeholder, including physician, physiotherapist, pharmacist, social worker, patients advocacy group, and policymaker. We work together to enhance the clinical practice and ensure a comprehensive patient-centered care. This MDT approach, strengthening the outcome and support continuous professional developments in hemophilia nursing. I always give an example here, and as you can see from the picture, myself and Mr. Mahmoud Abu Riyash, back in 2003, I was working closely with Mr. Mahmoud Abu Riyash, and he is he's the first hemophilia nurse in our region. He was sitting in a very tiny, small office with a lot of education material about bleeding disorder, hemophilia, Van Willebrand, Glanzmann disease. I was working as a nurse navigator for brain tumor. So I have no doubt what this is about. But in 2006, when I joined Tawang Hospital, I had more exposure to bleeding disorder and hemophilia patients, and they appointed me to be the hemophilia nurse and to improve the service provided to this community. With no knowledge and no skills with this specialized field, I went back to Mr. Mahmoud Abu Riyash because I know he is the only expert person from nursing perspective in the region. With his guidance, education, and support, I become one of the international hemophilia nurses who's roaming the wards, teaching nurses about hemophilia care. So allow me to send a special thanks to Mr. Mahmoud Abu Riyash for his great efforts with me. And nowadays, represented the Middle East and North Africa in the World Federation of Hemophilia Nursing Committee. Moving towards, I would like to conclude that addressing the shortage of hemophilia nurses is critical to improving the patient's outcome. We need to enhance the education, implement support policies, and foster stakeholder engagement are essential step forward having specialized nurses to improve the outcome. And also we need to work very closely with the governments, healthcare institutions, and educational bodies to work collaboratively and strengthen the hemophilia nursing workforce and ensure better outcome for patients living with a bleeding disorder. So with this, I would like to thank you again for giving me these opportunities, and I would love to answer your question. So please.
Thank you so much, Khalid, for your very interesting presentation. And I agree with you that the nurse is very important part of the multidisciplinary team for hemophilia and actually for even thalassemia and in other diseases as well. As I don't see questions, so we move to the next speaker. Our next speaker is Dr. Miriam Pereira. Dr. Miriam Pereira is a distinguished dental surgeon with extensive experience in managing patients with hemophilia and bleeding disorders. She earned her dental degree from Buenos University in 1984 and completed her dental surgery training in 1997. Since 1985, she has specialized in hemophilia care, currently leading the dental service at the Foundation of Hemophilia. Dr. Pereira has been a professor of dental surgery at Buenos University since 2004. She holds a leadership role as vice chair of the World Federation of Hemophilia Dental Committee. Welcome, Professor Pereira.
Good afternoon, everyone. I am going to share my screen to begin my Can you see my screen?
You were okay, Dr. Pereira. Before you were okay, and your screen share was fine. Now,
Okay.
yeah, now, but you put now on a slideshow. Yeah, excellent.
Okay. Well, on behalf of the Dental Committee of the World Federation of Hemophilia, I would like to thank the opportunity to participate in this conference. I am Miriam Pereira. I am a dental surgeon and work at the Foundation of Hemophilia in Argentina as head of the dentistry service. As all we know, dental treatment in patients with bleeding disorders has been widely discussed with the objective of developing a protocol of common procedures. Then, the aim of this presentation is to share our strategies for treating these kind of patients with the minimal risk of bleeding. As a way of introduction, let us make a little background. In October 26, 1944, the Foundation of Hemophilia of Argentine was created with the purpose of bringing economics and social help to the patient with hemophilia around the country. In June 25, 1963, the World Federation of Hemophilia was founded with the goal of improving treatment and care for individuals with hemophilia worldwide. During the 60s, systemic treatment was made with cryoprecipitates, which is plasma derivate rich in fibrinogen and other procoagulant factors such as factor VIII and factor von Willebrand. This treatment made possible to realize to make surgical treatment with systemic replacement therapy plus local hemostasia. The beginning of the modern treatment in hemophilia is referred to the 70s, where cryoprecipitates were replaced by systemic treatment with factor VIII and factor IX concentrates. This innovation revolutions hemophilia care with the availability of freeze-dried plasma concentrates containing factor VIII and factor IX, and it made possible to infuse these products at home. And finally, from 2017, and always intended of improving the quality of life of patients with hemophilia, emicizumab has contributed in a major way because of the subcutaneous administration, which enhances adherence with the treatment. Then, we can see here the different types of treatments. Prevention of dental problems is an essential component of oral care. If we can implement a good protocol, we can reduce the need of treatment and should reduce the number of emergency visits. It depends on different factors. For example, brushing teeth twice daily with a fluoride toothpaste. The use of fluoride toothpaste depends on the fluoride concentration in the water supply, as well as the use of additional fluoride supplements. The toothbrush should have medium texture bristles because hard bristles can cause abrasion of the teeth, and soft bristles are inadequate to remove bacterial plaque. The use of floss and interdental brushes also are recommended. The consumption of foods and drinks with a high sugar or acid content should be limited to meal times. 3 exposures per day is the recommended maximum. Then finally, regular dental visits, usually every 6 months, will help identify problems early. Also, it's essential to prevent accidental damage to the oral mucosa when carrying out any procedure in the mouth. Injury can be avoided by the careful use of saliva ejectors and the use of rubber dam during restorative treatment. This is our protocol. As you can see, first of all, we need to imply a clinical radiographic assessment. After that, we consult with the hematologist, and both design the systemic protocol. And after that, we need to choose the type of anesthesia. we can use two types of anesthesia, local infiltration, or in the case of the mandibular, we need to apply the inferior alveolar nerve block. The infiltration technique consists of blocking small terminal nerves with endings in the area of the dental treatment. In the case of inferior alveolar nerve block, we need to remember that in the case of need to use inferior dental block, we require a systemic replacement with factor concentrates before the procedure because of the risk of bleeding into the muscles along potential airway compromise due to a hematoma in the retromolar or pterygoid space. Endodontic therapy is considered low risk in patients with inherited bleeding disorders. Routine endodontic techniques should be undertaken, including the use of rubber dam. It's important to ascertain the working length of the canal and keep instrumentation within the canal space as a way to prevent bleeding in the periapical tissues. Fixed and removable orthodontics appliance may be used along with regular preventive advice and hygiene therapy. Special care should be taken when treating patients with a severe bleeding disorder to ensure that the gingiva is not damaged when fitting the appliance. Maintenance of good oral hygiene during all the orthodontics treatment is essential. And finally, let's address the surgical strategy. As we have been talking about, the first part of its strategy is the same as the other dental treatments. The difference consists in the design of the surgical protocol, considering the type of incision, the necessity or not to make ostectomy or tooth section as a way to simplify the procedure, and the choice of the local hemostatic agent, and finally, the number of stitches that we are going to give. Talking about the systemic protocol, this protocol is implemented by the hematologist. We need to increase factor 8 or factor 9 levels to upper 50% 10 minutes before the procedure. To repeat the factor transfusions 24 to 48 hours as a way to maintain factors level over or equal 30%. And during the third molar surgeries and also multiply surgeries should be considered to extend replacement therapy 4 or 5 years more with antifibrinolytic therapy. As a special chapters, emicizumab belongs to use, which is a B-specific antibody that mimics factor 8 of subcutaneous use. Is useful in patients with hemophilia A with or without inhibitors. Its half-life is 27 days. And if you need to use in dental surgery, it's not necessary the addition of factor 8 replacement. Now, we are talking about the local hemostatic agents. And at the beginning, we can ask ourselves that what is the ideal local hemostatic agents condition? We need to have excellent hemostatic agents with low cost, easy management, resolvable, and so important, no risk of cross-infection. Then we can divide in different ways. I am going to share with you one way that we classify in our country. For example, we can have chemical products like 30% trichloroacetic acid, which is a caustic agent which promotes the precipitation of plasma proteins, and it's used in superficial bleedings. After that, we can use bismuth sulfgallate. It's a bright yellow, tasteless, odorless, and amorphous powder that is stable in the air but sensitive to the light. It's soluble in water and alcohol and has been used in tonsillectomies for its astringent hemostatic properties. This powder has been shown to activate the intrinsic clotting cascade by activating factor 12 or Hageman factor. The chemical structure bears some relationship with lactic acid, which is a clot-promoting agent that initiates thrombin generation. Now we can share some cases. This is the use of 30% trichloroacetic acid. As you can see, we use it in superficial bleedings. Now, this is bismuth sulfgallate. As you can see, it's a bright yellow powder. Now you can see the powder put in the wound. And we use this powder with epinephrine, which is a potent vasoconstrictor, and it used in concentration of 1 in a 1,000 or 1 in a 10,000 as a topical hemostatic on bleeding surfaces. In addition to decreasing blood flow, epinephrine may stimulate platelet aggregation. This is fibrin glue, and is a product which mimics the natural blood clotting process. It's a two-component system made of fibrinogen and thrombin. Now you can see we are putting it in the wound. And finally, microfibrillar collagen is a local hemostatic agent which helps control bleeding by promoting platelet aggregation at the site of injury. Now, I am going to share with you some cases. This is a case of a simple extraction. This is the tissue dissection. Another view. The use of an elevator to avoid the roof. The wound cleaning. And finally, the bismuth sulfgallate with 1 stitch in this case. Another case, a wisdom teeth surgery. We need to use an incision as a way to go to the wisdom teeth. We use, in this case, ostectomy and also tooth section. The use of an elevator. We put inside the wound a bismuth sulfgallate plus epinephrine, 1 stitch. And you can see here the tooth section of the teeth. And finally, a case with the use of fibrin sealant. It's the simple case of the dental extraction of a root. And you can see the white halo as in this picture when the clotting process is done. And finally, we can say that all the treatments in patients with bleeding disorders can be performed. We need to take care of soft tissues because it's so significant. We need also to work in a multidisciplinary team because it's very important. And finally, we can share all this treatment with the mixing of systemic therapy with local hemostatic treatment because it's the key of our success. Thank you all for your attention. I am here for some questions.
Thank you so much, Professor Pereira. It was very informative and very important aspect of hemophilia care. I agree with you that systemic and local measures are very effective in controlling bleeding after dental work. Now, as no questions, thank you so much, Professor Pereira. And we move to the next speaker. Our next speaker is Dr. Derek Gabio. Dr. Derek Gabio is a pediatric hematologist oncologist with expertise in sickle cell disease and hemoglobinopathies. He serves as the hematology section lead at Raleigh Children's Health and is dedicated to improving equitable healthcare and reproductive services for patients with sickle cell disease. Dr. Gabio has co-developed a multidisciplinary clinic focused on adolescent and young adult care, enhancing the comprehensive management for this population. Welcome, Dr. Gabio.
All right. Hopefully everybody can see my screen this morning. I say this morning, it's morning for me, I guess, afternoon for you. But thank you all for having me. Thank you, Planning Committee, and it truly is an honor to join you from Indiana over here across the Atlantic Ocean in the United States. Today, we're going to talk a little bit about the evolving landscape in sickle cell disease. So without further ado, we'll go ahead and dive on in. So outline, we're going to talk a little bit about our disease-modifying therapies, at least three of the main players, that being hydroxyurea, crizanlizumab, voxelotor. We'll talk a little bit about our curative or transformative therapies, focusing on haploidentical stem cell transplant, and then talk briefly on gene therapy, not spending a whole lot of time due to a lecture later today on that. I think as we talk about the evolving nature of the disease, we got to know where we started. And I think that really highlights with the first reported case of sickle cell disease. And we're going back a little over 100 years to this being reported in 1910. Peculiar elongated sickle-shaped red cells. The case is unusual. Really didn't understand what was going on at this time. We know those of us that care for this population know this case well and know the specific patient well, and that's Walter Clement Noel. Was a 20-year-old dental student from Grenada, immigrated to the United States to pursue, again, dental school. While he was there, he sought care by Dr. Herrick and his intern, Dr. Irons, and received that care while he was in dental school, returned to his home country where unfortunately he passed away in 1916 from what appears to be an acute chest syndrome episode. Sickle cell disease itself, the term was coined in 1922, so nearly 100 years ago. So again, I think we set that stage of where we started and to be able to talk about where we are now and hopefully to highlight how much further growth within this disease and caring for these patients and families we need to yet to achieve. So discussing our disease-modifying therapies, again, talking about where we started and to get to where we are currently. So first, we're going to highlight the MESH study, which was published about 30 years ago. This was a phase 3 double-blinded study, simply looking at hydroxyurea efficacy in reducing pain episodes. when looking at the time to first pain episode, second pain episode, considerably longer time to those episodes when on hydroxyurea compared to placebo groups. Lower incidence of acute chest syndrome, lower incidence of transfusions. So again, a great start to work on this medication. Fast forwarding a little bit, going into the late 90s, this was one of the bigger initial pediatric studies looking phase 1, phase 2 multi-center trial starting lower dose hydroxyurea, escalating up based on lab-based toxicity, determining the safety and efficacy in the pediatric population on this medication. We know it's efficacious. We know it's safe in adults. What about in pediatrics? Similar overall findings to the adult studies in terms of increase of the hemoglobin F concentration, increase of hemoglobin itself, increase in the MCV. No major hematologic or other toxicities. The most common ones were neutropenia, thrombocytopenia. The thrombocytopenia itself that resolved with holding of the medication. The neutropenia was very mild with absolute neutrophil counts around 1,500 to 2,000. So pretty mild to maybe even not neutropenic at all in current standards. One of the other big concerns with utilizing this medication was it going to be detrimental to the growth of the child? Thankfully, it showed the opposite, and that there was actually an increase in the height and weight throughout the study for these patients. Females achieved menarche while on hydroxyurea. Again, question on how this would impact the reproductive health system. Baby Hug trial looked a little bit younger pediatric population, a lot for the same reasons, right? Is it efficacious? Is it safe? Primary endpoints really didn't meet those primary endpoints. They were utilizing technetium-based scans from a spleen and a renal function. However, looking at secondary measures of spleen and renal function, as highlighted here, both suggested considerable benefit, particularly when we're looking at the average age of patient on this study was about 14 months of age. And we know already by that time, as it's highlighted here, the majority of them are going to already have splenic dysfunction by that age when we're talking about sickle cell anemia population. Some of the secondary endpoints, pain, dactylitis, acute chest syndrome, very clearly showed a considerable benefit in this population for hydroxyurea use. And again, safe medication to be used. Looking at data out of a very robust and quite long observation study, a cohort study out of Europe, the ESCORT-HU trial, enrolled patients 2 years of age and older with symptomatic sickle cell disease over an 18-year period. Started lower dose hydroxyurea. Beyond that, there was no systematic approach to increasing or maximizing the dose of the hydroxyurea. It was more based on symptomatology. This was strictly a follow-up observation with nearly 2,000 patients, 7,000 patient years. So again, a very robust cohort. When they look specifically at the pain episodes in the year leading into hydroxyurea initiation compared to the year following, considerable decrease, a significant decrease in the number of pain episodes lasting greater than 48 hours, the number of acute chest syndrome episodes, hospitalizations, transfusions. No new toxicities were identified on this study, which was great. Again, the common hematologic ones that we would expect. So neutropenia, thrombocytopenia were being noted. However, again, how many of those neutropenia might actually be more Duffy null associated neutropenia? So really not a medication-induced side effect, more just their own genes and DNA. Again, speaking to the potential impact on reproductive health, there were 125 pregnancies in approximately 100 women on this study, as well as male partners fathering children as well. So again, potential and concerns for negative impact on reproductive health, seeing that women can get pregnant, men can father children. Up to this point, the approach, particularly the dosing approach when we come to hydroxyurea, has been more to start at a lower dose, a general dose, and then slowly escalate from there based off, again, hematologic parameters, trying to get as close as we can to an individualized approach, taking a general approach and trying to make it individualized. A little over 5 years ago, the TREAT trial was published. This was the first, one of the first attempts to look at more individual-driven dosing for hydroxyurea, utilizing pharmacokinetic guided dosing. So this looked at pediatric age patients with hydroxyurea being initiated. The patient achieved a single dose of 20 milligrams per kilogram. From there, they underwent some testing over the next hour, I think actually up to about 3 hours, PK sampling, how that individual was processing hydroxyurea in the moment. From there, they were able to determine the best or most optimal dose for that patient to be started on. Primary endpoint was time to maximum tolerated dose. This was achieved in a little under 5 months for these patients, achieving a higher hemoglobin F level as compared to those starting hydroxyurea and slowly increasing based off traditional dosing. Despite a higher dose being achieved, there was not an excess in hematologic toxicities noted or seen. The TREAT trial set the stage for a study that just recently completed enrollment and we're waiting formal publication, but had data presented about 6 months ago at the annual American Society of Hematology meeting in San Diego. And this was the HOP study, the Hydroxyurea Optimization through Precision study. Again, work done by Dr. McGann and group. This was a double-blinded follow-up study to compare the pharmacokinetic-driven dosing to standard hydroxyurea dosing with escalation. Primary outcome measure was hemoglobin F percent at 6 months of treatment. When we look at PK-driven dosing, that starting dose, again, how to get to that starting dose was the same for TREAT as it was for the HOP study. The starting dose was considerably higher, pushing 30% higher in the PK-driven group as compared to the weight-based group. And the increase in hemoglobin F at 6 months of treatment, not quite double, but nearly double again for the PK-driven dosing compared to the weight-based dosing and typical escalation. 75% of the patients had a hemoglobin F percentage greater than 30% or 75% achieved greater than 30% on the study, which we know, and again, I'm not going to take time, but we know 30% hydroxyurea or hemoglobin F level, we know associates with significant decrease in complications, acute chest pain, and things like that. 31% had a hemoglobin F of 40% at 6 months on the study. We compare this to about 46% were at 30% prior to study, and only 13% at 40% before treatment initiation. I think these numbers are typically much higher, even the starting hemoglobin F levels for patients compared to what we typically see across the realm of pediatrics. Pediatric age patients with sickle cell disease starting hydroxyurea. I will say, being a center for this study and seeing these patients firsthand, a lot of them were starting this medication at 6, 7, 8 months. So the full transition from hemoglobin F to hemoglobin S, we were still in the middle of that. So we were able to start dosing and kind of, as I say, kind of catch them before their F completely fell off to be able to maintain that level much higher. Despite a lot of these patients having high hemoglobin F at baseline prior to initiation, we know that hydroxyurea can still be beneficial, in some of the data that was presented at the ASH meeting highlighted this. We know that that pushing that hemoglobin F level even higher, it improves the hemoglobin level and improves the anemia seen in these patients, and it improves the cellular distribution of hemoglobin F, higher F distribution, the just overall improvement in health of those cells. So looking back through, again, 30, 40 years of hydroxyurea utilization in this population, we're coming to the point where we're really starting to be able to get to individualized dosing. hopefully in the years to come, we're going to have more clear guidelines and clear pathways on how to achieve that PK-guided dosing for all patients. For the study, obviously, they had a centralized lab that were helping with all of this, but how can this be done more across centers across not only our country, but across the world? Shifting over to crizanlizumab, first looking at its phase 2 study that led to its approval here in the United States in 2019. So it was a multi-center, double-blinded, randomized placebo-controlled trial. The primary endpoint was the annual rate of sickle cell-related pain crises. Secondary endpoints included days hospitalized, time to first and second pain crisis, rate of uncomplicated crisis, acute chest syndrome, things like that. So looking at that primary endpoint, the annual rate, so nearly 50%, so 45% reduction in pain crises on the treatment arm as compared to the placebo arm. So a considerable drop in pain crisis. Looking at some of those secondary endpoints, the time to first and second crisis, 2 to 3 times longer in both of those on the study arm as compared to the placebo arm. This study allowed patients to be on hydroxyurea or not. They just had to be on a stable dose leading into the study. This provided similar benefits or provided benefits irregardless of hydroxyurea utilization, with a higher reduction in pain with those not on hydroxyurea at initiation. So the dual therapy certainly proved beneficial, or solo therapy as well proved quite beneficial for this population. Follow-up study was published earlier this year. Data on this study was released last year, and that came from the STAND trial, the crizanlizumab with or without hydroxyurea in patients with sickle cell disease. This was the phase 3 follow-up to the phase 2. Again, double-blinded, randomized, placebo-controlled, multi-center study. Primary endpoint was annualized rate of VOCs or VOEs leading to healthcare visit over the first year post-randomization. They looked at 2 different dosing and compared that to placebo. As you can see here, the annualized rate were pretty similar, unfortunately, across the 3 groups. The ratio of adjusted annualized rate of VOC leading to healthcare visits, 1.1 for the 5 milligram per kilogram versus placebo, 0.89 for the 7.5 milligram per kilogram versus placebo. So again, unfortunately, it didn't show the benefits or the impact that the phase 2 study showed in decreasing pain episode. Really showed no difference in pain. It did show a very similar safety profile compared to the first study, similar across all 3 groups. A little bit higher rates, or I should say a little bit lower rates of grade 3 and higher adverse events in the placebos compared to the treatment arms. So this study, the interpretation of it is a safe, it's effective, it's a tolerable medication, similar to what we saw in the previous study. However, there was no significant difference in the overall efficacy from a pain reduction standpoint. The fallout, and I can speak specifically to my center and talking to a couple close friends at other centers. This was a medication we utilized in the pediatric setting. It was approved 16 years of age and older, so certainly on the higher end of the age group that we care for. So we didn't have a lot of patients on it. I think we were optimistic for this to be dropped in age, to be able to utilize it to a greater extent. But I would say at this point, I think we have 1 patient that still remains on this medication. We've obviously reviewed the data, showed them the data. They have seen benefit with the medication, so choose to continue with it at this time. With that being said, I don't believe it's on the market in other countries across the world. United States, again, it hasn't been pulled, but certainly is not being utilized very significantly. Voxelotor was another medication, or Oxbryta, that was approved in 2019. This was the phase 3 study that led to that approval. There was a couple different doses that were compared to placebo. Primary endpoint was the percent of patients achieving a rise in hemoglobin of 1 gram per deciliter at week 24 of therapy. The higher dose, 1,500 milligrams, showed the most impact and benefit with a similar safety profile. So this is the dose that that got approval. It showed over 50% of patients experienced greater than 1 gram increase. And when we look at that data a little bit closer and look at the patients that followed actually per protocol, that followed completely through the study, that 50%, nearly 50% were achieving 1.5 gram per increase. So a pretty significant increase in their hemoglobin. The reduction in hemolysis markers, things like indirect bilirubin, absolute or percent reticulocyte count, LDH, all these things were seen to a greater degree in the treatment arm as compared to the placebo. The changes were pretty quick. We know hydroxyurea can take quite some time to exert its full impact. With this medication, the first labs were being checked about 2 weeks after therapy initiation, and they're already noting considerable hematologic changes. Adverse events, pretty similar as well across the 3 groups. One big thing in terms of the adverse events to call attention to was the VOC data that they saw. We know in the sickle cell population, when they receive transfusions, there's an increase in their blood viscosity acutely around that time, which can be a trigger for an acute pain episode, particularly if it's a simple transfusion. That same question was a concern for this medication. We're seeing a pretty quick and considerable rise in the hemoglobin. Are we increasing the viscosity? Therefore, are we going to trigger pain crises or other complications? Thankfully, this was not the case in the study, at least in this phase 3 study. Again, approved in 2019 for 12 and older. From an FDA standpoint, age dropped down to 4 years and older a couple of years later in 2021. Then this past fall hit, and this release was put out by Pfizer. As you know, I won't read the report, but this obviously sent shockwaves through the sickle cell community and us providers caring for this population. This release was one that was not, in my opinion, released well to the provider level, to the frontline level for us. This was something I had a colleague, or it was a good friend of mine who is not a hematologist, let alone a pediatric hematologist. Saw this on their newsfeed and sent me a message in the middle of the day and said, "Hey, what is this? What's going on?" And I instantly, picked up the phone and got a couple of my colleagues here at Riley on the phone, and we were talking about it. So, pretty quickly, we get this notice that this medication is being withdrawn from therapy. In the days to weeks to come, we get a little bit more information on what this is. The full report on both of these studies is yet to be released. So what has been released, first off, the Hope Kids 2 study. This was a study that looked at voxelotor oxybryta's impact on transcranial Doppler ultrasound velocities for those with conditional grade velocities. They recruited over 200 children across the world into the study. There were 8 deaths noted in the voxelotor group compared to 2 in the group without voxelotor. Looking at the Resolve study, which looked at voxelotor and standard of care versus and its impact on leg ulcer healing. 88 patients, 12 years of age and older, enrolled across the 3 countries listed there, 8 deaths on the voxelotor group. If we look at the release from the European Medicine Agency, not only were there high rates of mortality in the voxelotor as compared to the placebo, there was just overall higher number of deaths than anticipated, as well as since that initial publication in 2019, some registry studies showing considerably higher rates of VOE in the voxelotor group. looking at these two medications that were approved, that were studied, that were developed solely with sickle cell in mind, to have such negative fallout of them within a few short years following their approval or them being brought to market, it was quite impactful and continues to be quite impactful for this population. We certainly have a number of phenomenal medications in development, in studies, here and across the world that hopefully will be able to follow a different path than these medications will be able to bring significant, considerable change to this disease and improvement in the overall life for these patients and families. But certainly those studies are and will continue to be met with continued hesitancy from these patients for reasons like this, and the continued build of distrust of this population, of the medical community. We certainly need to do better, push ourselves, and again, hopefully, working with the leaders in their communities, we can show that this is not the path for all medications, and we truly believe in some of these ones that are in studies and coming to market, and they will make they'll make considerable change for the better for their either themselves or their children. Flipping into the next part of the study, we're going to talk a little bit about the curative therapy, transformative therapy piece. We're going to talk a little bit about stem cell transplant. Again, before we get to haplo, we've got to talk about the history and how we get to there. And that's going to start with the first documented transplant in someone with sickle cell disease. That occurred back in 1982, so over 40 years ago. There was a young child that was diagnosed with AML, also had sickle cell disease. Per her treatment arm, she underwent a bone marrow transplant in addition to the chemotherapy. Her donor was a matched sibling donor. Her brother had sickle cell trait. Great outcomes for that specific patient. Survived for many decades following that. And yeah, so again, we show that it can be effective. This collection of studies that was put together by Batia and group, published about 10 years ago, again looked at outcomes in patients undergoing matched sibling donors from a sickle cell standpoint. What does that look like? What are outcomes? Graft rejection, event-free survival, transplant related mortality. Overall, quite acceptable, and showing again, not only is this possible, it is a great opportunity to cure individuals of sickle cell disease. And when we look at needing to cure someone from sickle cell disease and looking at the criteria that we would consider undergoing this type of procedure, the number of patients with sickle cell anemia that would meet that criteria is quite large, pushing a third of the population. If we're looking at more broad criteria, things like strokes or silent infarcts, recurrent chest episodes, recurrent pain episodes that are requiring hospitalizations. They have underlying impaired neurological function with abnormal MRIs. Do they have sickle cell related lung disease, sickle retinopathy, nephropathy? The pool, the need of patients, the pool of patients needing this therapy is quite large. How can we expand the potential donor pool for this patient? Because we know that the ability to find that matched sibling donor is quite limited. Less than 15% of children with sickle cell disease have a matched sibling donor. So looking at MUDs, or match unrelated donor, certainly improves the possibility. However, it is still limited, less than 20%, 15 to 18% chance of African American individual with sickle cell disease of finding a match. Again, it is quite a great opportunity to achieve cure. Reduced intensity conditioning regimens, certainly more favorable toxicity profile as we would expect. but certainly the fallout of that or the trade is higher rates of rejection. Thankfully, CAMPATH has been helpful for that. And has allowed, again, not only matched sibling donor, but matched unrelated donor of real realities for a cure for this population. From a sickle cell standpoint in general, we're improving care in the pediatric population. Morbidity, mortality still exists. Over 90% of children survive into adulthood, specifically here in the United States. The options of therapy are limited, as we just highlighted, from disease-modifying therapy, and that's where stem cell transplant is a great option. It is a great option, but again, it doesn't come without barriers. We kind of highlighted the barriers of just simply access to it in terms of finding suitable donors. But there's certainly a long list of barriers beyond just that. When we talk to the families and patients, there's considerable barriers that exist for them. We look at information, that was put out in a publication recently from a group from the University of Alabama, where that first point, limited access to information, is at the forefront. Less than 60% of patients that they assessed knew about cure as an option for their sickle cell disease. Less than 60%. So these patients aren't getting information from their care team, from their providers. The perception of high risk. When the same population was asked in the study of a 5% chance of death, this was the largest deterrent by far to stem cell transplant. This doesn't even begin to talk about financial barriers that exist, as well as the piece that we talked about a couple slides ago, and that was the lack of trust of the healthcare system. So again, significant, considerable barriers exist. Plenty of work to do as we move forward to address these. Addressing one of the big barriers, and again, that is improving the donor pool for these patients and looking at alternative methods for donors, and that comes in the form of a haploidentical donor. Information that was publication that was just published earlier this year. This is a phase 2 open-label multi-center trial. You can see there 42 of the 54 eligible patients received transplant with the non-myeloablative conditioning as outlined there. The 2-year event-free survival, overall survival, quite favorable at 88 and 95% respectively. There were a few deaths, 2 of which were very early and related to infectious complications, which weren't out of the realm of expectation. The event-free survival, overall survival, graft failure, similar to matched sibling donor in the pediatric age patients. So for haplo to meet those numbers in a matched sibling is quite great and quite phenomenal, and especially doing so without non-myeloablative conditioning. Graft failure historically was one of the biggest barriers to haplo transplant in the sickle cell population. Previous studies published 15-ish years ago. In one study, there was 5 of 10 patients underwent haplo. 5 of those had rejection. Another one that was suspended due to high incidence of graft rejection. Another one published in 2012, 6 of 14 with graft failure. So graft failure, high concern when we deal with haplo. This study seemed to address it to a much greater extent, than ever seen before. This was all adults that was published. The pediatric study is ongoing and hopefully with data to be released within the next year or so. Gene therapy. I'm going to, again, kind of keep this brief. There's going to be a great presentation later today, I think within the next hour, by Dr. Al-Zarani on CRISPR rewriting the code of life for sickle cell disease. So I'm going to talk a little bit about this. Again, I feel like it needs to be discussed when we're talking about the evolving landscape of sickle cell disease, but going to leave a lot of the more sciencey stuff for that talk. So late fall into winter of 23, we get these reports come out. The one from the FDA, this came out the first day of the American Society of Hematology meeting. So quite a great deal of buzz circling around this international collection of hematologists. What does this look like? What are approved? We're going to talk briefly about the two different products that are on the market. The first one, Lovocell. This is a Bluebird Bio product, Lyfgenia. So they utilize modified stem cells to produce this new hemoglobin A, this new gene therapy-derived hemoglobin. It functions similar to hemoglobin A, utilizes a lentiviral vector to integrate this hemoglobin into the patient's hematopoietic stem cells. Looking at a publication from Dr. Cantor and group from a few years ago, this was an preliminary report or an interim analysis report of the sickle cell arm or group of the study, which included about 35 patients. Of those with sufficient follow-up, 25 met 25 of the 25 that met that criteria for sufficient follow-up were VOC free at 6 months. There were 3 adverse events attributed to lentiglobin infusion. There's grade 2 leukopenia, grade 2 febrile neutropenia, grade 1 decrease in diastolic blood pressure. There was 1 death on the study. This patient had cardiopulmonary disease at baseline, pulmonary hypertension, and unfortunately passed away about 20 months post the therapy. Of note, that individual had no VOCs in that 20-month time period from infusion to the time of their passing. Casgevy or XCell, it's a Vertex product. This is an ex vivo editing by CRISPR to reduce the BCL11A expression, leading to an increase in the hemoglobin F protein production. Report published last year included 44 patients enrolled in this phase 3 single group study, 30 of which had sufficient follow-up. 29 of those 30 were free from pain crises or pain episodes for 12 months. All 30 of those with sufficient follow-up, free from hospitalizations from a VOC standpoint. So phenomenal data there and outcomes from that treatment. Safety profile consistent to that of myeloablative busulfan conditioning and auto transplant. So nothing out of the realm of what they kind of expected going in. Gene therapy again is I think is going to be a considerable player in terms of therapies for patients. Again, I can speak to here in the United States. I think one of the very considerable barriers is going to be financial. The products carry in the ballpark of $2 to $3 million price tag simply for the modified cells. That does not include the conditioning that's needed for these individuals, transfusions leading up to the infusion of cells, the post-hospital care following the infusion, and all of that. So quite the financial lift for this, but hopefully pretty quickly healthcare providers, healthcare systems, insurance companies, federal government can find a way to again bring this therapy to the patients and families that need and deserve it. So with that, I'm going to pause and be happy to take any questions that anybody may have. Again, I truly appreciate the invitation to be here today. The picture on the slide here.
Thank you so much, Dr. Lo, for this excellent. Yeah. Thank you so much for this excellent, very impressive presentation. I mean, it's, like you said, it's really sad that 2 new medications were withdrawn from the market, and we were happy to have them, and some patients really benefited from them. We're hoping now the CRISPR and gene therapy to be a real hope for the patients with sickle cell disease.
Yeah.
There is no questions, so move to the next speaker. Thank you so much, Dr. Gabriel.
Thank you.
Our next speaker is Dr. Abu Bakr Imam. He is an experienced pediatric nephrologist with distinguished international career. He graduated from University of Khartoum in 1991 and completed his pediatric residency and nephrology fellowship in New York. Dr. Imam has held prominent leadership roles, including Director of Renal Transplantation at Children's Hospital of Michigan, Chief of Nephrology at Akron Children's Hospital, and Head of Pediatric Nephrology at King Fahd Medical City, Saudi Arabia. From 2012 to 2018, he served as Head of Pediatric Nephrology at Hamad Medical Corporation in Qatar. Welcome, Dr.
Thank you very much, Dr. Najat. I am so privileged and so happy to be here with you. And thank you for the invitation to talk about a very important topic that
Dr. Abu Bakr.
Yes. Can you hear me? I'm okay. Hello? Can you hear me?
Yes, we do.
Yeah. So thank you very much for the invitation, Dr. Najat, and for the introduction, the kind introduction. The topic is very important, and I think the audience would like also to hear other side of the story when it comes to the effect of certain diseases on other organs. So my title is Tiny Filters but however big challenges, renal manifestation of sickle cell disease. The presentation earlier today kind of sets the stage for my current presentation. I have no conflict of interest related to this.
Can you enlarge the slide, please, Dr. Abu Bakr?
It's not moving?
It's you can put it on a slideshow. It's very small, maybe.
So slideshow?
Not yet, no.
Is it now?
Not yet. Yeah, it was before. It was on a slideshow, but I don't know why suddenly you changed.
I did not change it, but I'll stop share and share again. Is it okay now? Is it okay? Is it good?
Still small, Doctor.
Okay.
It's okay. You can start. It's okay. Start, Dr. Abu Bakr.
So it's a slideshow.
slideshow؟
Yeah.
بس صغيرة شوي.
Yeah. All right. So can I continue?
Please, yes.
So I have no conflict of interest related to this presentation. I'm going to start my talk about the kidney in health and disease, just as a background to the talk for us we're doing. We know that when we deal with the kidney, we deal with it from early on intrauterine, and as we go in life, newborn, infant, all the way through until we go into adult life. Now, we know that certain factors can be playing roles when we talk about how much nephrons we have, how many filtering units we have in each kidney, and that's related to a lot of factors that related to intrauterine, as well as what are the life contributing factors, challenges that we see as we go in life. But importantly, we know that certain congenital diseases that we deal with since birth, or intrauterine going all the way through, or inherited disorder can have a certain significant negative effect on the kidney. And we know that each person is not in isolation of acquired kidney diseases. So this acquired kidney disease can also play a role in our kidney function as well as kidney survival. This is an important introduction when we talk about sickle cell disease, because all we know that sickle cell disease is a systemic problem. You are aware of what can go wrong in other organs. I'm going to focus on the kidney and what the kidney can do in a disease like sickle cell disease, and what is the sickle cell disease itself? What can it do to the kidney? Presentations can vary from proteinuria to less of concentration of the urine to hematuria to changes in the glomerulus, the filtering unit, to renal tubular acidosis, and symptoms later on contributing to chronic kidney disease and end-stage kidney disease, as we see. What happens in the kidney is important. We know statistically that kidney disease is one of the common complications that we see in sickle cell disease. And it's been reported around 30% of those patients with sickle cell disease develop some sort of chronic kidney disease in different stages. And that is could be stage 1 all the way to stage 5 and then end-stage kidney disease. Children tend to be a little bit less than those numbers. The reason behind that, because the effect of sickle cell disease on the kidney is cumulative, and it happens, it can start in early life and it progress as the person progress in life. But the data from adults and are telling us that around 15% of patients progress to end-stage kidney disease. And this is important because any factors that affect end-stage kidney disease, especially certain diseases, if we can modify their outcome, it might improve end-stage kidney disease. Patients with end-stage kidney disease end up on dialysis and require kidney transplantation down the road in their lives. Now, if you look at the involvement, it's more severe in homozygous diseases, sickle cell S as well as beta thal. So it is those in the homozygous disease tend to be more. Those with trait tend to be less. However, they can still have some renal manifestation. The sickle cell nephropathy, as we refer to, is a progressive disease that begins early in childhood and will continue early on throughout the lives, with a clinical manifestation of proteinuria that can be early on to be small amount of protein, what we refer to as microalbuminuria. And the reason behind this is we see that there is some sort of glomerular hyperfiltration that is related to the hemodynamic changes that happens in the kidney at the glomerular level, ending in it to be bigger and evident by the function to be higher filtration. That higher filtration, although it indicates a good function in one way or another, however, it might injure the glomerulus itself. And I'm going to show you certain pictures for that. Now, the end result of the kidney involvement is what we're concerned about is the loss of the kidney function and chronic kidney disease, because we know that sometimes when you start the process of chronic kidney disease, it progresses, and any factors that affect that are important. So before I take you into the journey of the effect of sickle cell disease on the kidney, I'm going to share with you the beautiful picture of the kidney, which is, as we all know, blood comes to us through the renal artery from the aorta and goes out in the renal veins. But what happens in the kidney is highly sophisticated, well-organized mechanism of filtration as well as reabsorption. The renal cortex tend to be where most of the responsibility of the units over there, the glomerulus I refer to, are to filter as much as possible from the blood into the filtrate that goes down into the tubules. Now, onto the tubules, the next role is the role of the medulla, which is to fine-tune this filtrate, take back what is actually we need, and let certain things go, and sometimes excrete certain materials. When the kidney does this job, it does it in a very fine way with the help of the pyramids, which is
where actually the concentration takes place, because you have to concentrate the amount of urine, as well as the blood vessels around these units, and the arcuate artery, interlobular arteries. There's very clear vasorectal mechanism of filtration, reabsorption that takes place in it. The ultimate product is urine coming into the calcial system, and ultimately goes down into the urine. Anything that affects the perfusion of these vessels at the level of the arterial or obstruction of the veins, it will result in malfunction of the kidney with the loss of its ability to work properly. Just to highlight the importance of the cortex and the medulla, the responsibility of the cortical glomerulus, this is a proximal convoluted tubule, which we call a proximal tubule. This responsibility here is a reabsorption of every important material. Here, we're talking about the reabsorption of sodium, reabsorption of phosphate, and any defect in the proximal tubule can give you significant, what we ultimately know as Fanconi syndrome. As we go in the loops or loop of Henle, distal tubule, and then finally go all the way to the collecting ducts. As we come diving into the inner medulla, we start to see that the role here become predominantly of the tubules to do the job. The glomerular did the job by the filtrate, now the tubular reabsorption. These tubules are sitting in a milieu of a parenchyma, renal parenchyma, that allows this transport of fluids and salts in it. It's important because you could see that in a high magnification in the electron microscopy, you could see that the slit diaphragm where the filtrate takes place and the ciliary cells, and this is the epithelial cells, what we refer to as podocytes, the filtrate goes through. Anything affecting this barrier will definitely going to result in either glomerular damage or tubular damage. Now, if it's glomerular damage, it's evident by proteinuria. If tubular damage, is evident by electrolyte disturbances, acidosis, and that way. Now, what happened in sickle cell disease? The paradox in the sickle cell disease that in the cortical area, there is a hyperperfusion effect because of the disease, and in the medullary area, there is hypoperfusion. That could be a physiological effect. However, in patients with sickle cell disease, this is becoming a problem for those patients. Why? Because the medulla is the milieu enhance the sickling process that happens with it. In the proximal part, which is the glomerular part of the cortical area, now the hyperfiltration result in excessive filtrate, while in the medulla, there is compensatory release of certain nitric oxide, resulting in heme deposition, resulted in oxygen radicals being there, a milieu of an inflammatory process, rather than just a normal red blood cells going through the filtration barrier. However, this occlusive crisis results in the end perfusing area will be affected. So there is an injury to that area, as we're going to see in the papillae of the kidney. This is important because there is a significant hypoxia. Why that happens? Because of the hypoxia that happens in the renal medulla. And this hypoxia is a physiological hypoxia. However, in a disease such as sickle cell disease, become an area that where the sickling takes place. The oxygen diffusion, as well as in the cortex and the outer medulla, as you could see, as you go in the inner medulla, your oxygen saturation drops significantly with the tissue. Oxygen become very much less, around 5 to 10 or so in the lower part of it. And then the consumption goes up here also. So this area, why these vessels are needed this way? These vessels actually surround the tubules, and the exchange happened between the tubules and this vasorector. In the kidney, a state of sickling in the intravascular can also lead to hemolysis, as we know. It could be a physiological, structural obstruction, or it could be a chemical induced from the heme, from the iron, from all the liquid or free hemoglobin, results in an area of pathophysiology changes from a normal physiology to pathophysiology, with a release, an inflammatory process right now in the tubules and in the milieu of the whole parenchyma, will increase in the blood vessels of the endothelians, and nitric oxide viability become less, oxygen stress there, and there is a lot of inflammation that become, all of a sudden the kidney become an inflamed organ because of this. In addition to the chemical effect, the physical effect of a thrombus sitting in there can be there. So an ischemia, reperfusion injury can also happen afterwards. When we start treating those patients and we start to have to decrease the sickling effect on them, we hydrate them. Now the ischemia, reperfusion comes in. The ultimate effect, as I mentioned, could be hematuria, could be just because of the red blood cells passing through the glomerular barrier, or proteinuria, because there is an effect of the let go of the injury because of the hyperfiltration that happens, or due to decreasing the ability of the concentration, because the concentrating ability of the kidney to concentrate the urine, to make sure that we secrete less amount of urine as depending on our status of hydration, is taking place in the medullary area. And since the medullary area is the mainstay of the problems that we see in sickle cell disease, that tend to be where the problem that takes place. The medulla, the papillary of the pyramids tend to be sometimes infarcted. And when they infarct, they tend to lose the function. And the end result is even the glomerulus can be affected with a glomerulopathy that we're going to see that can happen on those patients. If you look at the direct effect of it histologically, you will see that you could see in the glomerular capillary loop are included in the with congested sickle cell, and that can be seen histologically very clearly in this figure. In the next one, you could see red blood cells congestion. That is just its presence in there affect, and this can cause an obstructive element to the tubules also. You could see marked sickling in the vasorecta, big vessels, that's showing this with the end result of obstruction to the vessels. And you could see an iron, now the effect of the iron being there, released, so deposit in the glomerular area. And you can see also hemosiderin deposition as seen in the stains. These changes, I would like to highlight that we see it in patients with sickle cell disease. However, by no means that patients with sickle cell disease, they require a kidney biopsy for diagnosis of sickle cell nephropathy. Sickle cell nephropathy by itself, it can be a big spectrum of just minor proteinuria. We know what the kidney is facing when it comes to sickle cell disease. These are findings that has been picked up. There are certain indications for us as nephrologists to indicate a kidney biopsy for patients with sickle cell disease. However, by the virtue of having sickle cell disease itself, it is not what is actually we go ahead and do it and standard as a standard of care. No. So the effect is not only as I show it histologically or pathophysiology in the histopathology, but the effect can also be, this is if in older age group, in the third and fourth decades of life, you could see, even in a patient with sickle cell trait, in the gray bar and the black one as SS, you could see that microalbumin can be a significant presentation of those patients and how many percentage of them. The higher bars are also seen in the patients with sickle cell disease SS. Now, in the macroalbuminuria, or we refer to as frank proteinuria, which is a significant proteinuria that will affect your serum albumin, that the ability of the kidney to retain albumin, because albumin in general is big molecule, should not pass what I just showed you earlier, the slit diaphragm. You could also see that macroalbuminuria as you go in age can also be a manifestation. Also, I mentioned the effect of it on the tubules, and I can tell you in the tubules, the function of the tubules, the proximal tubule can be dysfunctional. What we know that in the proximal tubule, because of the hyperfiltration that happens, the responsibility of the tubules to work fast and hard in these patients, the so absorption of phosphate and all that might have hyperphosphatemia. However, the distal part of the nephron start to see a defect in the hydrogen ion excretion. So the end result is a state of hyperkalemia, as well as sometimes acidosis. That's what that can happen in the distal part of the nephron. If you look at those patients in general with those who are not sickle cell disease, those with certain disease, the bicarbonate level tend to be normal here, a little bit not affected that much in hemoglobin SC. However, is significantly affected hemoglobin SS again in these patients, representing a defect in the function of the distal part of the nephron. So now you can see an effect of a disease that affects your filtration, glomerulus, affects your proximal tubule, affects your medulla, that the concentrating ability of the urine, affecting your distal part of the nephron, causing hyperacidosis and hyperkalemia. That effect is massive, and that results in, it's almost like a vicious circle that we go into. How? The sickle cell disease itself, because of the loss of the ability to concentrate, any condition that makes these patients unable to drink enough, they end up being dehydrated. And their dehydration status is underestimated a lot. And people sometimes look at their creatinine as an indicator of their kidney function. We tend to have a problem sometimes with the creatinine because, as I mentioned, there's the execution of creatinine in the proximal tubule when it comes to sickle cell can be exaggerated. So those patients might have low to start with serum creatinine, and that's their normal. Okay? So now, if they become normal, that means the creatinine might be even higher than was actually. Same thing when we say that the state of hydration in sickle cell disease is not, you don't need one maintenance, you need maybe more than one maintenance for that child to be euvolemic. So a state of acute kidney injury can happen because of the dehydration, vaso-occlusive crisis, volume depletion. And what do we use when we have pain? A lot of times in patients with sickle cell disease, we use non-steroidal anti-inflammatory medication. Those non-inflammatory and anti-inflammatory medications tend to have a deleterious effect on the kidney. Why? Because they block the prostaglandin, and those prostaglandins are needed in a state of dehydration, so to perfuse the glomerulus properly. So a state of acute kidney injury, vaso-occlusive crisis, progressing factor, the hyperfiltration that's already happening in the kidney, interstitial fibrosis, albuminuria, will give you the full-blown picture of sickle cell nephropathy and chronic kidney disease. Yet, you have a re-injury that always happens with acute kidney injury. So if you put this into a mechanistic way, you will find that you cannot tell where did it start and happen. You have a status of chronic kidney disease, sickle cell nephropathy, progressed by factors, hyperfiltration, interstitial fibrosis, and in a state of vaso-occlusive crisis. So this vicious circle put the patient at a higher risk of sickle cell nephropathy and chronic kidney disease down the road. In pediatrics, sometimes we don't see the full-blown effect of it, as we see it more toward the teenage type of presentation. Now, if you put all this together in at least on a slide, you're going to find that if you look at the proximal part of the nephron, there is supranormal proximal convoluted tubule function. All right, that proximal hyperfunction or supernormal will give you an increased phospholipid absorption, give you hyperphosphatemia. So if you see hyperphosphatemia in a sickle cell disease patient, you know why it happens. Now, increased creatinine secretion, and that results in increased creatinine clearance. So these patients tend to have low serum creatinine, and that is because of their proximal tubular function. The hyperfiltration, it can also lead to almost an injury and a full-blown presentation of focal segmental glomerulosclerosis or membranoperipheral glomerulonephritis can be a presentation of sickle cell disease. And these require different treatments, as I'm going to come to you in a bit. Now, when you come to the medullary area, the sickling within the vasa recta that happens, it can give you papillary necrosis, and it will end up in having hematuria. And some believe that in adults, mainly in adult, not in pediatrics, medullary carcinoma can take place down there. Now, the loss of the gradients give you as I mentioned earlier, the hydrogen and potassium secretion get affected in the distal part of the nephron, and the end result is hyperkalemia, free water, loss of ability to concentrate the urine, and hypothermia is the presentation of decreased urine capability. Now, these medullary conditions result in sickling unfavorable condition, as I mentioned, red blood cell sickling aftermath, the worse medullary hypoxia, because now the injury becomes more effect on the inability to concentrate the urine. Modifying factors that plays a role in this disease is aminoglycoside. How often we use aminoglycoside on those patients? They're asplenic, they're coming with fever. We all the time tend to use certain strong antibiotics, specifically the aminoglycosides for these patients. So we try to make sure that when we use them, we follow the levels very carefully. Non-steroidal, if we can avoid use them or use them in with cautious, understanding what's happening for those patients with advanced sickle or bad sickle disease control. Now, the effect of the ion chelators on the tubules is very well recognized and reported in the literature very clearly that it does cause certain, some of them can cause significant full-blown picture of Fanconi syndrome. And I've seen some patients that we just have to stop it for a while and resume it afterwards the less dose. Then the patient, the Fanconi is transient Fanconi, it's not permanent Fanconi. IV contrast on those patients coming in for concern about acute abdomen, you need IV contrast, CT scan, be careful about that. There is enough data for us to tell us that not everybody behaves the same. There's certain genotypes with APOL1, for example, presentation gene, have a different reaction to the sickle cell disease condition when it comes to sickle cell nephropathy. APOL1 and certain other genes, disease-related factors, low hemoglobin F, and coexisting hypertension. And in that, I would like to say that patients with sickle cell disease tend to be on the hypotensive side of the spectrum. And the reason for that is prostaglandin is released because of the whole effect of the kidney as well as the blood vessels. So the effect is when you see a hypertensive sickle, this is significant hypertension for this child. So pay attention. This is not the usual curve that we try to, it's okay, normal reading. They tend to be lower. And dehydration and management of dehydration is critical on these patients. So now, this is a disease. This is what it does for the kidney. How can we pick it up early? People are trying to look at, can we pick up the microalbumin effect is early? Can we affect the GFR? And the factors at the age of biomarkers, TGF-beta appeared as one of the factors that can be dealt with. If you look at the effect of sickle cell in patients and you compare to the controls, you'll see that some sickle cell patients tend to have high TGF-beta significantly compared to the other ones. And you could see that the effect of sickle cell disease on the GFR is higher, and those patients tend to have a higher protein compared to the controls we have. Other biomarkers rose in the horizon. KIM1, kidney injury molecule 1, has been shown that it's early detection of sickle cell disease, and it, the damage, what happened into the tubule, is a tubular marker for damage. And other proteins has also been MCP1, and part of the proximal tubule defect that happens can be detected. There a lot of data have shown that we can detect the effect of it of this injury to the tubules earlier on, and it can be to the function or the chemical effect, or it is the physical effect of it there. The cation channels effect in the nephrin, and as well as endothelial injury, and AT1 has been attributed. So yeah, ET1 has been known that it can be affected. So it is stress, hypoxia, decreased nitrogen oxide, at that level, thrombosis, free oxygen, or free heme, and the other chemokines, cytokines, milieu. The end result is glomerulopathy and effect of it in the other vessels. And people have thought about endothelin inhibitors in sickle cell disease with certain response. However, it's not standard of care yet. So if I were to put things together, renal vasculopathy takes place in sickle cell disease, perfusion paradox, proximal tubule versus the distal tubule, and the effect of the medullary hyperperfusion and the kidney hyperperfusion, and the apparent renal vascular response on the stress and the vasoconstricting effect. These are the manifestations put all together, from altered hemodynamics to glomerular enlargement, glomerulopathy, tubular deposits, and then increased susceptibility to acute kidney injury. So what do we do for these patients? Surveillance, blood pressure monitoring, urine analysis, microscopy, detect the effect of it early on, urine microalbumin, do metabolic profile, look at the acidosis, look at the kidney function of this patient, and understand that certain conditions such as hypohydroxyurea can also affect your measurement. If you use a specific in your lab ISTAT measurement of creatinine, it can be affected. If you find any abnormality, then go for further workup. Ultrasound to look at the obstruction. Kidney biopsy, sometimes we do in macroalbuminuria or significant proteinuria, low serum albumin, nephrotic range proteinuria. We can see double contour MPGN, FSGS, and sometimes thrombotic microangiopathy itself. The management, well, whatever you can do for nephrotoxic medications, radio contrast, ion chelators, you use them with cautious when you're using them. Patient with transfusions, iron load on those patients, hydroxyurea is the mainstay as currently. Data telling us that decrease the level of sickling and the degree of sickling, you will get less sickle cell nephropathy. Hydration, aggressive hydration of those patients, and an MDT requirement of these patient pediatric nephrologists. When do we use ACE inhibitor or renal angiotensin system inhibition is whenever we start to see that the early changes happening at the kidney, and sometimes, as I mentioned earlier, we need to use a biopsy. In summary, sickle cell disease, we know, alters the structure of the function of the kidney. It causes the kidney and the red blood cells to sickle in the medulla of the kidney because it's hypotonic, hypoxic, acidotic, and hyperesmolar condition. And the complication is vast and can cause a big vast of presentation. It's common and under-recognized. We have to do certain surveillance on those patients more, especially in children, because we tend not to see the effect of it until late, but we need to start early on that. It's usually more severe in homozygous and progressive disease. It begins in childhood, and biomarkers intervention management is critical for the good outcome. Our hope in the therapies that modifying the rate of sickling and gene therapy and bone marrow stem cell transplants on those patients. With that, I will thank you and be happy to answer any questions you have.
Thank you so much, Dr. Abu Bakr, for this excellent and very impressive presentation. As you said, it's the renal impairment is underdiagnosed in sickle cell disease. Sometimes, I mean, despite we in pediatrics, we do take a lot of care. We do routine follow-up. We do like ultrasound, renal ultrasound every 6 months, and we do renal function maybe 3-4 times per year. But when the patients move to the adult, they are not really well looked after, and some of them suddenly they present with renal failure or end stage renal failure, which means very distressing for the patient and bad for the system. Thank you so much. Now we move to the next speaker. Our next speaker is Dr. Mohsen Al-Zahrani. Dr. Mohsen Al-Zahrani is a consultant in hematology and stem cell transplant, King Abdulaziz Medical City, Riyadh. He earned his medical degree from King Abdulaziz University in 2000 and completed the Saudi Board Internal Medicine in 2005. He finished his hematology residency at Dalhousie University, Canada in 2009, followed by a 2-year fellowship in hematopoietic stem cell transplant and lymphoma at Dalhousie University and University of Toronto. Dr. Al-Zahrani currently leads the Division of Adult Stem Cell Transplant and Cellular Therapy at King Abdulaziz Medical City. Welcome, Dr. Mohsen.
Assalamu alaikum. Thank you,
عليكم
Dr.
السلام
Noor.
ورحمة الله
Thank you for the
وبركاته. Hello.
introduction. I'm not sure, do you see my slides?
Yes, we do.
Okay. Okay, thank you for the invitation to be part of this presentations in this excellent meeting. And my task is to talk about gene therapy for sickle cell disease. And this will go in line with the previous presentation as a curative treatment for patients to prevent complications such as chronic kidney disease and other complications. These are my disclosures. So sickle cell disease is a common disease in Saudi Arabia. More than 80,000 patients have the homozygous disease, and with the whole population percentage 4.2%, sickle cell trait and sickle cell disease 0.26%. The sickle cell disease in some region like Eastern region is 2.6%. There was a study to estimate how many patients need curative treatment. Around 10,000 patients with indications like stroke, recurrent acute chest syndrome, recurrent VOCs, refractory to hydroxyurea need transplant. So the demand for curative options are very high. As mentioned by previous presentations, sickle cell disease is a multisystemic disease. It affects different organs, multiple organs, and in each organ it presents with a variety of presentations. We just learn from Dr. Abu Bakr how a patient would present with different manifestation of kidney involvement. The same thing can happen in different organs. So this will lead to poor quality of life for these patients. And in a study in USA, a survey distributed to children and adults to assess their quality of life, and they rank their quality of life almost close to cancer patient and to those patients with end organ disease like kidney, chronic renal failure or liver failure. Also, it leads to increased mortality, and the median survival currently is even in like developed countries in USA, Europe, for patients with severe disease is 48 years, for those with severe disease, and those with mild disease is 54 disease. This resulting in significant lower survival of sickle cell disease compared to normal healthy people. The cost of the treatment is also very expensive. The lifetime cost for one patient in a study in USA is 1.7 million. Or 1.6 million in average lifetime cost for supportive therapies. For transplant, the cost is $300,000. And for the current gene therapies, the cost is 2.2 to 3.3 million. Yes, both transplant and gene therapy, they are expensive, but they are one-time treatment that can provide cure, and maybe in the future will be cost effective when we apply it for larger number of patients. The current available therapies include symptomatic treatment, just to control the symptoms, and preventive treatment or disease-modifying agent, hydroxyurea and glutamine. They are the only approved agents, and the curative option, gene therapy and stem cell transplant. The first transplant for sickle cell disease happened in 1984 for a child who developed acute leukemia, and the team in USA planned to do transplant to cure the AML, and the donor was a sister who is a sickle cell trait. Fortunately, the patient was cured from both leukemia and sickle cell disease, and this opened the door for more investigation doing allogeneic stem cell transplant to cure sickle cell disease. And over the years, there are increasing number of transplant cases reported for patients with sickle cell disease. This is the European Boomer Transplant Database. As you see, the trend of hematopoietic stem cell transplant cases for sickle cell disease is increasing year by year. And currently, the outcome for transplant for sickle cell disease is excellent. In pediatric studies, the overall survival is more than 94%, and the disease-free survival, meaning the cure of the disease, is more than 90%. And in some studies, like in our center, Dr. Sultan reported overall survival and event-free survival 100% using myeloablative conditioning regimen, thiotibab, busulfan, and fludarabine. So in pediatric group, there is a very high chance of cure of the disease by doing allogeneic transplant from match-related donor with low toxicity, such as GVHD was very low, 4.1%. However, this come at the expense of increasing long-term toxicities such as premature gonadal failure and infertility. In adult, in our center, we use this protocol non-myeloablative regimen, and we have reported the 3-year event-free survival 88.2% and 3-year overall survival 94%. So using reduced intensity or non-myeloablative regimen is the way to go for adult patients, because we know adult patients with sickle cell disease, they develop multi-organ complications, and they are less tolerable to myeloablative regimen. And this also was reported in other group. This is from a group in Amsterdam. As you see, 96% of the patient achieved long-term survival and event-free survival and cure from the disease. So the outcome of transplant is improved a lot for these patients, especially when the donor is HLA match-related donor. However, not in every time we will find a donor for a patient. In Europe and North America, studies showed that on less than 20% of patients with sickle cell disease, they will find a match sibling donor or match-related donor. So this will limit the options of these patients to undergo a curative allogeneic stem cell transplant. So we should look for alternative therapies. In our experience in Saudi Arabia, as you know, the family size is larger than what is in Europe and North America. Also because of high consanguinity, we screen the patients who are referred to our center to undergo transplant, 633 patients. We found 65% was the chance of finding match-related donor for sickle cell disease patients. I think this is applicable also to other Gulf and Middle East countries. So if you don't have match-related donor, what are the other options? Now we have good alternative options. The first option is to go alternative donors like haploidentical donor, cord blood donor, and match unrelated donor. But with the current approved gene therapies, those above 12 years of age can be eligible for gene therapy. So there are two methods for gene therapy in sickle cell disease. There is gene addition and gene editing process. Basically, it is autologous type of transplant where we collect the stem cells from the patient and we send the cells to the manufacturing facility. They will do either gene addition or gene editing, and then the cells will come back after a few months, and then we will give the patient myeloablative conditioning chemotherapy to ablate the bone marrow. Then we infuse the modified stem cells, and then there will be autologous engraftment of the new cells and hopefully cure of the patient. The gene addition approach is by using the lentiviral vector, where we transfer a piece of genome or DNA that will produce a new hemoglobin molecule, such as this hemoglobin ATH7Q, and this hemoglobin has anti-sickling features. And if the cells engraft, the cells, red blood cells, will not undergo sickling, and this will reduce the manifestations of the disease. The other method is gene editing. Why gene editing? Gene editing is more precise. The gene addition, the addition of the genome by the lentivirus can be random anywhere in the genome, and this can introduce a hit that unwanted. But in the gene editing, it is very precise by using a certain technology that direct the editing to certain genes, and this will cause the correction, addition, or deletion of certain genes, such as by use of the CRISPR-Cas technology, which is a new technology that was discovered in the last decade. And the two scientists who discovered this technology win the Nobel Prize for Science. So basically, there is endonuclease connected with single guide RNA, and the single guide RNA will direct the endonuclease to the target gene, and the endonuclease will do the gene editing, either deletion, addition, or modifications. There is a protective effect of fetal hemoglobin. So this is a long study, maybe 30 years ago, and they studied the patient with sickle cell disease, and they found those patients who has high hemoglobin F, more than 8.6%, they have better survival in a condition called hereditary resistance of fetal hemoglobin. And we know therapeutic interventions to raise the hemoglobin F will reduce the manifestation and complication of sickle cell disease. Once you hit 30% hemoglobin F, the patient will be asymptomatic. And similar thing in beta thalassemia, once you have high hemoglobin F, then the transfusion requirement will be reduced. So hemoglobin F, as we know, it gets suppressed by at time of the birth, because it is the predominant type of hemoglobin in the fetal life. So, but once the baby born, there will be switch from hemoglobin F to hemoglobin A by a gene called BCL11A, which inhibits the gamma globulin production. So this BCL11A become an interesting gene for addition. And this is what has been discovered and done by certain labs. They use the CRISPR-Cas9 to edit the BCL11A. We know the BCL11A inhibit the gamma globulin production. So if we delete or suppress the production of BCL11A, this will release the suppression of gamma globulin and increase production of hemoglobin F, as shown in this figure. And this will result in less production of red blood cells with high content of hemoglobin F, and this will have less less production of sickling. The first study that used this technique was this study. Excuse me.
Thank you.
Climb a sickle cell disease 121, which is phase 2 multi-center open label study. Sorry, it was phase 3. They enrolled 44 patients aged 12 to 35 with severe sickle disease. And the primary endpoint was free from severe VOCs for more than 12 months, and secondary endpoint was free from hospitalization more than 12 months. So in stage 1, there will be screening. Stage 2, the stem cells will be collected by Blerixafor, and then the cells will be sent to central manufacturing facility where CRISPR-Cas9 editing will happen. Then the cells will undergo quality check for 6 to 8 months. Then cells will be frozen and release testing. Then cells will be retained to the hospital for use. At that time, we'll admit the patient and we'll give him conditioning chemotherapy with bisulfan, then injection of the excess cell, and then for the neutrophil engraftment and platelet engraftment will take around 1 month in stage 4. After that, the patient will be discharged, and there is mandated follow-up for 15 years of this patient to see if there is any long-term effect. So there was 46 patient recruited in this trial, and the neutrophil engraftment median was 27 days, and the median platelet engraftment was 34 days. The duration of median follow-up was 33 months for the whole group. This swimmer plot curve or figure showed that, as you see, each line will represent one patient, and in the middle there is the red bars where the infusion happened. To the left of that red color figures, you'll see a lot of diamond blue dots that represent the VOCs. So after the infusion of excess cell, as you see, many patients doesn't have any new events, with around 88% of the patient achieve the primary endpoint free from VOCs for 12 months, and with 2 additional patients achieved this outcome, reaching 93% achieved the primary endpoint, which is free from VOCs for 12 months. And the secondary endpoint, which is free from hospitalization for 12 months, was achieved in 95%. And this is the figures showing the level of hemoglobin, with the baseline hemoglobin around 9 gram per liter, but after the infusion, it reached to up to more than between 12 to 14 gram, with the steady state in the follow-up for most of these patients. And hemoglobin F is raised up to 40 to 50 or 60% in these patients and maintained over the study period. The distribution of hemoglobin F is pancellular. More than 93% of red cells, they express the fetal hemoglobin. And the percentage of edited cells was maintained by studying the bone marrow and peripheral blood over time. And the markers of hemolysis, as you see in these 4 figures for lactate dehydrogenase, reticulocyte haptoglobin, and indacylglobin, was normalized and maintained within normal range over the time. The adverse events for this study was mainly related to the bisulfan, high-dose bisulfan, which usually in the first 30 days post-treatment, mainly nausea, vomiting, mucositis, fever, neutropenia, but there is no long-term toxicities after the engraftment. There was 1 death in this study what was related to COVID-19 infection. And they measured the patient-reported outcomes with different metrics, and it showed that there is improvement in quality of life post-infusion of excess cell for these patients in adult and pediatric patients. So I will show you our experience here in Riyadh National Guard Hospital. So the excess cell or Cas9 was the first gene therapy approved was in Britain on 16th of November 2023. CRISPR-Cas9 excess cell was approved for patients with severe sickle cell disease and TDT after the result of this randomized study. After the result of the study, sorry. And the second country to approve the drug was actually in Bahrain, and congratulations to our colleagues in Bahrain to be the second country in the 2nd of December 2023. Then USA on 8th of December, approved 2 gene therapies for sickle cell disease, Casgevy, using CRISPR-Cas9, exa-cel for patients with age 12 to 35 years, produced by Vertex, and the other gene therapy is Lyfgenia, which is gene addition technology by using lentiviral vector, and the eligible patient is 12 to 50 years of age, and it's a product of Bluebird. Then Saudi Arabia, FDA approved the drug on 8th of January 2024 for patient age 12 to 35. So in our center, we launched the gene therapy at National Guard Hospital, and we prepare ourselves and had approval, and we prepared our program, and we underwent site certification by the company, and we start enrolling patients. Our first thalassemia patient underwent collection was in 19 February 2024, and the first sickle cell patient underwent collection was in 4th of March 2024. And the first infusion was in July 2024, and this was the first patient treated with gene therapy globally outside clinical trials. These are the inclusion and exclusion criteria that we adopted in our center. Basically, those patients with severe sickle cell disease manifested by recurrent VOCs or recurrent acute chest syndrome, 2 events per year for the last 2 years, despite inappropriate dose of hydroxyurea, with good performance status and eligible to undergo autologous transplant. And the main exclusion criteria is availability of match-related donor, prior transplant, or having other organ dysfunctions. So the mobilization and collection protocols, we hold hydroxyurea for 8 weeks before the collection. The collection of cells from sickle cell disease patient is very challenging. So it's recommended to hold hydroxyurea 8 weeks before the first cycle of collection, and to maintain the hemoglobin 9 to 11 gram per deciliter, and hemoglobin S less than 30%. We do exchange transfusion every 2 to 3 weeks during this period, and the collection usually by plerixafor, which is given for 3 days, and 3 hours after each dose, the patient will undergo apheresis with measures to prevent crisis and acute chest syndrome, and we give aspirin and anticoagulation prophylaxis. Expected 2 to 6 cycles of apheresis are required, and between each cycle and the next cycle is 6 to 8 weeks. This is the roadmap for the mobilization regimen. We use plerixafor. As I mentioned, we give 3 days in first cycle and 2 days for subsequent cycle, and the apheresis start 3 hours after the plerixafor dose. And the chemotherapy we use bisulfan, myeloablative dose, 0.8 milligram per kg every 6 hours for 4 days, with the supportive therapies and antimicrobials. So in our center, National Guard Hospital, we enrolled 21 patients. 14 patients underwent stem cell collection. 10 achieved the target of collection, and 3 patients received the infusion already. 7 patients are planned to be infused. 1 patient failed to collect after 2 cycles, so he was removed and deemed ineligible, and he's undergoing a haplotransplant. 2 still did not reach the target. They will require more cycles of collection, 1 awaiting the result after the first collection. There are 7 patients scheduled to do the first cycle of collection. So the age median was 14.5, with the youngest 12 and the oldest was 31 years. The diagnosis: 12 patients sickle cell disease and 9 patients TDT. Our first patient, as I mentioned before, was enrolled, and his cells collected in February 2024. And after he was successfully managed to be collected with 1 cycle only. And he received the gene editing in July 14, 2024. As you see, there is like 5 or 6 months between collection and the cells coming back, because the cells, once manufactured, it will undergo a quality check and test for 6 months in the manufacturing facility. And he recovered in August and discharged from the hospital. This is the journey of the patient. As I shown previously, different phases: stage 1 screening, stage 2 collection and manufacturing, stage 3, which is the infusion and the admission for chemotherapy and the infusion, and stage 4, which is the recovery. Pre-engraftment, the patient developed neutropenia, which is expected after basal 5 ml ablative dose, thrombocytopenia, mucositis grade 2 to 3, and he developed mild VOD, veno-occlusive disease, managed with supportive care and fibrotide. Engraftment, he engrafted neutrophil day 25, platelet day 32, platelet day 39, and discharged from the hospital in day 37. And the last transfusion was received on day 25, and now he almost completed 10 months without a need for transfusions. His hemoglobin maintained above 11, above 13.4, and hemoglobin F 90%. As you see, his main hemoglobin is hemoglobin F. Central line removed at day 60. He returned quickly to his school 2 months or 3 months post, and he is undergoing phlebotomy to treat iron overload, and his ferritin is going down from 13,000 to 3,000. Still, he is needing a long-term follow-up. The other 2 patients that we infused, the second patient is 7 months post-infusion. He's 16-year-old male with TDT, transfusion-dependent thalassemia. He received a dose of CD34, 6.8 million. He developed refractory thrombocytopenia and febrile neutropenia, neutrophil engrafted day plus 30. We give him GCSF 14 days and recovered platelet day plus 49. He received TBO agent and HLA match platelet administration. The last hemoglobin is 15 gram per deciliter, and his hemoglobin F is 99.4%, and he's transfusion independent for the last 7 months. The third patient, he's now 5 months post, 13-year-old male, TDT, CD34 dose 8.1 million. He developed myositis, but otherwise a smooth course, neutrophil engraftment day plus 31, and platelet engraftment day plus 38. His last hemoglobin is 13 gram per deciliter, hemoglobin F 99.2%, and he's transfusion independent. As I mentioned, there are other patients, 7 patients, the cells manufacturers, and they are lined to receive the infusion. So in conclusion, allogenic transplant and gene editing therapy are changing the natural history of sickle cell disease and DTT. We cure these patients, and many of them, they normalized their organ functions. And some patients with end organ damage, they undergo allogenic stem cell transplant, non-myeloablative, and they recover, and they can undergo other procedures. Gene editing therapy has the potential to overcome many limitations of allogenic transplant, such as lack of suitable donor, GVHD, need of immune suppression, potential for graft failure. Very promising experience with 3 patients we did, and learning more about mobilization, collection, conditioning, infusion, engraftment, and follow-up. Limitation of gene edited therapy studies, small number of patients treated so far, relatively short follow-up, and cost of the treatment. I would like to thank our team, the stem cell transplant, apheresis, cell therapy lab, our hospital administration, and our patient and their families. Thank you very much.
Thank you so much, Dr. Zahrani. It was for a very excellent presentation and impressive result for your CRISPR transplant. And we hope that we see more advancement and more encouraging results for this CRISPR, as it is really, and it will be a hope for the patients as the therapeutic, like medications, we have 2 medications which were approved and then withdrawn from the market. So probably the only thing or will be the hope for the patients is the CRISPR and gene therapy.
Yeah, and congratulations, in Bahrain, they infused the first sickle cell patient globally. And I think last month.
And also we had 1 patient which was successful CRISPR transplant.
He was infused, yeah.
Thank you so much, Dr. Zahrani. We move to the next speaker. Professor Leonard, do you mind if you start now? Because Dr. Glenn still did not log in. Professor Leonard. Professor Lan. Our next speaker is Ms. Imelda Kili. Ms. Imelda is a clinical nurse specialist specializing in hemophilia at Children's Health Ireland, Kremlin. She plays a vital role in delivering multidisciplinary care for children with bleeding disorders, focusing on clinical support, patient education, and care coordination. Imelda is actively included in family education and community outreach through the Irish Hemophilia Society. She also contributes to research aimed at enhancing pediatric hemophilia care and improving patient outcomes. Please, Imelda.
So good afternoon, everybody. My name is Imelda Kelly, and I'm a clinical nurse specialist in haemophilia and allied bleeding disorders in CHI at Crumlin. So today I'm going to talk about how the role of the haemophilia nurse has evolved beyond administering treatment to become a critical advocate and provider of holistic care. So what I'm going to talk about, I suppose by the end of this session, you should be able to understand how nurses contribute holistically to haemophilia care across the regions. I've just outlined here what I'm going to discuss, so understanding inherited bleeding disorders, understanding the evolution of nursing in haemophilia care, identify current nursing roles beyond infusion, explore the global challenges and solutions, highlight innovations and regional adaptations, and inspire advocacy and leadership in nursing. So understanding haemophilia and inherited bleeding disorders. So inherited bleeding disorders, or IBDs, are a group of rare genetic conditions causing a deficiency or dysfunction of clotting factors or platelets, resulting in prolonged, continuous or uncontrolled bleeding. The World Federation of Haemophilia defines bleeding disorders as a broad range of medical problems that lead to poor blood clotting, resulting in prolonged, continuous or uncontrolled bleeding. So our classical haemophilia, which is our factor 8 and factor 9, which we all know, but we also have von Willebrand's disease, rarer bleeding disorders and platelet function defect. So whilst classic haemophilia is our factor 8 and factor 9, inherited bleeding disorders occur when a genetic mutation causes an absolute or partial deficiency of any clotting factor or platelets. The clinical severity can be mild, moderate or severe, depending on the type and the plasma level of factor affected. So these disorders, impose a heavy medical and economic burden on individual patients and society in general, and require specialised care. So the treatment of inherited bleeding disorders, well, you have your prophylactic factor replacement therapy, your extended half-life products, non-factor therapies, gene therapy and comprehensive care. Comprehensive care is a coordinated, patient-centred approach that addresses the medical, psychosocial, educational and functional needs of individuals with haemophilia and other inherited bleeding disorders. It is delivered by a multidisciplinary team in a haemophilia treatment centre or a comprehensive care centre, with the goals of improving long-term health, independence and quality of life. So let's look, I suppose, at the high income versus the low income countries. I suppose let's contrast nursing practices in high income settings versus the low income settings, noting gaps and adaptations, meaning that they receive regular infusions to prevent bleeding episodes rather than treating them reactively. So many patients rely on on-demand treatment, meaning that they receive clotting factor infusions after a bleeding episode occurs, leading to long-term joint damage and disability. So I suppose in the high-income countries, there's comprehensive care, prophylactic treatment is readily available, and also availability of the novel therapies. In the low-income countries, basic medical care, there's only on-demand treatment, and there's limited access to the novel therapies. The World Federation of Haemophilia emphasises that shared decision-making is essential regardless of healthcare settings, even in low-resourced countries. In such contexts, nurses often take on a greater responsibility for shared decision-making due to limited physician access. Empowering nurses with training in communication, health education and cultural sensitivity is a World Federation of Haemophilia priority. So the impact of inherited bleeding disorders, well, there is a medical and physical impact. So recurrent joint and muscle bleeds can lead to pain and swelling, limited mobility or early joint damage, missed school days due to bleeds, hospital visits or fatigue. So early infusion routines may feel intrusive or frightening. Physical activity may be restricted or require adaptations. So it leads to frustration or feeling of being different. In severe cases, children may fear spontaneous bleeds even without injury. There also is an emotional and psychosocial impact on families. There's parental guilt, I suppose particularly in mothers who are carriers, fear and anxiety over accidental injury. They have the learning of infusion techniques and I suppose the pressure that puts on parents, making the right treatment decision, emotional toll of consistent vigilance. Siblings may feel overlooked or confused about the condition. Parents of a child with severe haemophilia have said you never stop watching. Even when they're sleeping, you wonder if they'll wake up with a bleed. The financial and practical strain Okay, so time off work for infusion, hospital visits or emergencies. The cost of care if outside a publicly funded system. Travel to treatment centres, families may relocate to be closer to a specialist centre. The education and social challenges. School staff may lack awareness and leading to overprotection or even exclusion from activities. Inconsistent response to bleeding episodes, social stigma or isolation. I suppose peer misunderstanding, he's always missing school. Why is he not in school today? Bullying or child feeling self-conscious about visible bruises or limitations. Need for individual, I suppose, healthcare plans and nursing advocacy at school. So I think that is so important to be able to communicate with the school, with the teachers when they're starting. I suppose to alleviate that fear that teachers have about haemophilia, to go and visit the school, to, you know, explain that, you know, the contact or who they will contact if something happens. The impact on family dynamics. Parents may disagree about how strict or relaxed to be. Single parent families may feel particularly overwhelmed. Strain on relationships due to constant emotional and logistic demands. Need for, I suppose, family-wide support, not just the child. And resilience and growth. So despite the challenges, families often report strong family bonds, increased health literacy and advocacy skills. Children with haemophilia often develop resilience, high self-awareness, maturity, empathy for others with chronic illness. So the role of the haemophilia nurse. The nurse is often the most accessible healthcare provider in many haemophilia programs and is vital in delivering comprehensive, culturally appropriate care. And that's from the World Federation of Haemophilia guidelines. So a haemophilia nurse specialist is a highly trained nurse with expertise in bleeding disorders, responsible for coordinating and delivering individualized, evidence-based care across patients' lifespan. They are often the first point of contact for patients and their families and serve as a bridge between medical care, psychosocial support, and community resources. They are central to both advocacy efforts and the holistic model of care. So the evolution of haemophilia nurses. Well, if you look pre-1970, nurses primarily provided inpatient care, administering the fresh frozen plasma or cryoprecipitate and supporting physicians in acute setting. So I suppose initially nurses were infusion specialists. And the introduction, I suppose, of home therapy transformed their role into educators and facilitators. So I suppose pre-1970s, a child would have been hospitalized and the nurses primarily provided inpatient care, and that was by administering the treatment, whether it be fresh frozen plasma or cryoprecipitate. There was limited patient education or long-term planning. So then I suppose the introduction of factor infusions in the 1970s, 80s. So the emergence of a specialist nurse. So training in the home, infusion techniques, providing early forms of education and counselling, acting as case managers, and coordinating care across the hospital and at home. And then in the 1990s to the 2000s, nurses assumed broader responsibilities, patient education, clinical assessment, psychosocial screening and referrals, monitoring compliance. So the evolution of haemophilia nurses, haemophilia nursing, I should say. So pre-1970, I suppose the nurses were infusion specialists. The introduction of home therapy transformed their role into educators and facilitators. So I suppose pre-1970, haemophilia care was limited and it was hospital-based. Treatment was focused on reactive care, so treating bleeds as they occurred. And nurses primarily provided inpatient care, so administering fresh frozen plasma or the cryoprecipitate. There was limited patient education and long-term planning. I suppose then you come into the 1970s and the 1980s, emergence of specialist nursing, training in home infusion technique, providing early forms of education and counselling, acting as case managers, and coordinating care across hospitals and the home. And I suppose at this time, you know, we'll say because you had factor concentrates that were available, you know, training in home infusions probably started then. When you move on to the 1990s and the noughties, nurses assumed broader responsibilities, patient education, clinical assessment, psychosocial screening and referrals, monitoring compliance, and documentation and outcome tracking. I suppose now you look at the modern haemophilia nurse, and wow, how the role has just evolved and takes in so many areas. So emergence of nurse-led services, clinical expert, educator, case manager, the advocate, researcher and leader, expand scope to include all inherited bleeding disorders and carriers, which are so important. So the nursing role in holistic care, well, so coordinates multidisciplinary input, hematology, physiotherapy, psychology, social work, educates the parents and children on self-management and safe practice, supports transition milestones, so school entry, independence, which is so important, and adolescence, monitors emotional well-being and facilitates referrals for psychosocial support, advocates within schools, daycare and community organisations, creates individual care plans that are practical, age-appropriate and family-friendly. So holistic care. So treat the person, not just the bleed. So if you look here, it's the physical, psychological, social, cultural and developmental. And in it is not just the mother and father and the child or the children. It is the grandparents, the siblings. And I suppose I do feel sometimes that siblings get overlooked. And I think we have to be mindful that, especially if there is a sister, that she potentially is the carrier of haemophilia, and she now, when she moves on to have her own children, that what will she bring forward to them? So I think it's very, very important. So holistic care for children and families is an approach that addresses the physical, the emotional, social and spiritual needs of both the child and their families. It recognises that a child's well-being is deeply connected to their environment and relationships, especially with the caregivers. This model of care individualises support, cultural sensitivity and active family involvement in decision-making. Nurses play a key role by fostering trust, providing education and coordinating care that nurtures the whole child. Holistic care not only promotes healing and resilience, but also strengthens the family unit, leading to better long-term health outcomes. So children with inherited bleeding disorders face challenges that extend beyond bleeds and infusions. So a whole child approach. Treat the child and family, not just the disorder. So there's the medical care, which is the prophylaxis, the bleed prevention and joint health monitoring. The emotional care, building confidence, managing fear and peer relationships. Developmental care, encouraging age-appropriate activity and school engagement. The social care, inclusion in school and sports and family life. And the family-centred care, educating and empowering the caregivers. So the benefits of holistic and advocacy-based paediatric care. So for the child, well, they have fewer bleeds and less joint damage, which is really what we aim for. Increased independence and confidence, positive relationships with peers and adults, improved school attendance and performance, resilience to life's changes, reduced health anxiety. For the family, so they reduce the fear and caregiver burden, clear plans for emergency and routine care, empowerment through knowledge and partnership, and support during emotional or practical crisis. So supporting holistic care. In the home, we teach infusion, involve siblings, promote confidence and reduce anxiety. In the school, we liaise with the staff, create bleed plans, train teachers, and support inclusion. In the hospital, prevent treatment trauma, like needle phobia, ensure child-friendly care. Community, ensure access to safe sports, camps, and social activities. And I suppose by policy, so we can campaign for paediatric treatment access, home therapy, and education support. So I'd like to kind of move on now, and I'm going to focus on two key areas that I feel are very important in providing haemophilia care. Independence, okay? So why independence matters. So promoting independence is not a single step, it's a lifelong journey. It begins in early childhood and evolves as the child gains physical, cognitive, and emotional maturity. Promoting independence in a child is essential for their overall development and well-being. It helps build self-confidence, resilience, and a sense of responsibility, allowing children to trust their own abilities and make decisions. So promoting independence helps children and young people with haemophilia, okay? So it's very, very important. So when children are encouraged to do things themselves, such as solving problems, managing tasks, or making choices, they develop critical thinking and life skills that prepare them for future challenges. Independence also fosters a sense of achievement and boosts self-esteem, which are key to emotional and social growth. Ultimately, nurturing independence empowers children to become capable, confident, and self-reliant individuals. So key areas of independence, so treatment management, health literacy, shared decision-making, emotional and social skills, navigating the challenges of inherited bleeding disorder. Nurses are key enablers, I should say, of independence. Their roles include an educator, teaching age-appropriate skills and knowledge, coach, encouraging problem-solving, decision-making, and self-care. Advocate, ensuring safe environment that fosters independence, like areas like school. Supporter, providing reassurance and scaffolding until the child is ready. And a coordinator, leading transition programs and linking to the adult services. I think it's also important to mention here about self-management. So self-management in haemophilia refers to a person's ability and confidence to manage the daily challenges of living with a bleeding disorder. It includes the medical tasks, emotional regulation, lifestyle choices, and navigating healthcare systems, often in partnership with healthcare professionals, especially nurses. I'm now going to move on to shared decision-making. So the World Federation of Haemophilia guidelines for the management of haemophilia explicitly endorse shared decision-making as a core component of comprehensive care, underscoring its relevance in improving patient autonomy, adherence, and outcomes. Shared decision-making is a collaborative, person-centered approach in which the patient, families, and the healthcare professionals jointly make healthcare decisions, especially when there is more than one reasonable pathway forward. Children should be invited to participate in decisions that affect their health, identity, and independence from an early age, in an age-appropriate manner. Empowering children to participate in shared decision-making has been shown to improve treatment adherence, build health literacy, support self-confidence and independence, whilst reducing fear and health anxiety, and lays the foundations for effective self-management in adolescence and adulthood. Outcomes of shared decision-making. So research aligned with the World Federation of Haemophilia principles show that shared decision-making leads to greater patient satisfaction, improves treatment adherence and bleed control, reduction in decisional conflict and regret, enhances quality of life and treatment engagement, and more personalised and sustainable care plans. So who are the enablers of effective shared decision-making? The multidisciplinary team, I suppose integration with clear communication pathways, access to decision aids and visual teaching tools, nurse-led education sessions before key decision points, digital apps for treatment, tracking and personalised goal setting, and ongoing clinical reviews to adjust plans collaboratively. So the role of the haemophilia nurse in shared decision making. So the World Federation of Haemophilia recognises that haemophilia nurses as a pivotal facilitator of shared decision making, translates medical terminology into accessible, patient-friendly language, builds long-term trust and rapport that allows for open dialogue, explores emotional, social and psychological barriers to decision making, helps patients and families weigh up options and express values, uses visual tools, educational resources and teach-back methods to support understanding. So nurse-led techniques in shared decision making. So I suppose developmentally appropriate communication, use age-specific language, metaphors, cartoons or role play. Use teach-back to confirm understanding. Offer honest yet gentle information about risks or procedures. Offer realistic choices. Let them choose between options within, I suppose, safe limits. Would you like your infusion in the morning or in the afternoon? Help them weigh up the pros and cons in a simple format, and this is where visual aids really are very important. Promote confidence through skill building, so encourage participation in self-infusion practice. Let them track their treatment using apps or stickers. Celebrate milestones like their first solo infusion. Validate emotions and preferences. Listen without correction. And I suppose that's very hard for us, but I think it's so important. Encourage expression of fear, anger, or confusion. Validate their roles as an expert in their own experience. Include children in the MDT discussion when appropriate. So invite older children to sit in part of clinic reviews. Let them present how they feel, what's working, what's not working. Including parents and families. So empowerment doesn't exclude parents. It reframes the triad of care as the child, parent, nurse. Nurses play a vital role in coaching parents to gradually transfer the responsibility, encouraging family discussion about preferences and planning, preventing overprotection and anxiety from dominating decisions. I suppose the benefits of empowering children. Oh, sorry. So can you, hello? Okay, so the benefits of empowering children in shared decision making. So it increases engagement and treatment ownership, reduces procedural trauma and needle phobia, better long-term psychosocial outcomes, and strong trust in the healthcare team. So what are the tools for paediatric empowerment? Well, you can use storybooks and cartoons about haemophilia, digital apps with child-friendly treatment logs, shared care passports with sections written by children, infusion dolls and simulated training kits, workshops or peer groups for children and teens. So shared decision-making is not a one-time conversation. It's a continuous process that is integrated across various touch points in care. So the clinical area, choosing between traditional factor replacement, extended half-life or non-factor therapies, venous access options, weighing risk supports versus peripheral access, especially in younger children. Surgical interventions, planning pre-post-op factor cover, physiotherapy and recovery goals, transition to adult care, establishing independence, reviewing treatment preferences, lifestyle planning, lifestyle and psychosocial decisions, so sport, travel, education, career and fertility, balancing risks with life goals. Home treatment plans, the timing, when does it suit best to take your prophylaxis, the frequency, administration method, storage. So shared decision-making leads to greater personalised and sustainable care plans, improves bleed control and treatment, engagement, there is a reduction in health anxiety, decisional conflict and regret, which contributes to enhanced patient satisfaction and quality of life. So now I'm going to talk about health anxiety. So if the child and family are not involved in shared decision making, this can lead to health anxiety and can have a very negative impact on their haemophilia journey. Health anxiety is known to be transgenerational and one of the most significant barriers to lifelong independence. Strategies to prevent health anxiety should be implemented from diagnosis, as a parent's response shapes their child's response. So, health anxiety refers to excessive worry about having or developing a serious illness, even when medical reassurance is available. In haemophilia, this can manifest as hypervigilance over minor bruising or joint pain, avoidance of activity due to fear of bleeds, parental overprotection in children, emotional distress around treatment routines. So health anxiety can also lead to overuse or misuse of treatment products, avoidance of normal activity, like in school, in play, in sport, poor treatment adherence due to fear of needles or mistrust, and family conflict or breakdown of care routines, increased use of emergency services. So how do we prevent health anxiety? So in children, developmentally appropriate education to reduce fear, play therapy and visual aids to normalize treatment routines, building trust to consistency and empathy, helping children identify and describe symptoms accurately versus catastrophizing them. In parents, coaching to avoid overprotective behaviours, support during diagnosis, first bleed and treatment initiation, psychoeducation around risk versus safety in everyday life, empowering parents with clear action plans and communication tools, and in the adolescents, encouraging ownership of care, reducing learned helplessness, addressing anxiety about sport, dating, school or career, and promoting peer support and transition readiness. So nurse-led initiatives, they can facilitate a family workshop, increase awareness of needle-related anxiety in children with bleeding disorders, developing a training program for school nurses on supporting children with haemophilia, to advocate to integrate anxiety screening into routine care. I think that is so important. Contributing to guidelines on psychosocial care in haemophilia. So now I have just a case example of, so this example shows how nurse-led home therapy leads to significant improvement outcomes. So a 10-year-old boy in rural area with severe factor VIII deficiency, his venous access was good. He was attending the hospital twice weekly for prophylactic coagulation factor concentrate. Haemophilia nurse trains family to administer intravenous coagulation factor concentrate and initiates home treatment. Telemedical follow-up and support. So telehealth allows nurses to extend care beyond the clinic, especially in underserved areas. Compliance monitoring using scanning devices. And what were the results? Well, fewer bleeds, better school attendance, and improved quality of life for the whole family. That is the end of my talk, and these are just my references that I used. And I would like to say thank you, and I hope you enjoyed this presentation.
Thank you so much, Imelda, for the excellent presentation. And as there's no questions, we'll move to the next speaker. Our next speaker is Dr. Glenn Pierce. Dr. Glenn has more than 35 years of experience in bench-to-bedside research and development with several public and private biopharmaceutical companies, including Biogen and Bayer. Dr. Pierce currently serves as Vice President Medical with the with the World Federation of Hemophilia, WFH. He serves on the U.S. Medical and Scientific Advisory Council, MASAC, and previously served on the Board of Directors and as Board President of the National Bleeding Disorder Foundation. Please, Dr. Glenn.
Thank you very much for that nice introduction. and it's a pleasure to be here for this second day to talk about gene therapy. Can you see the slides correctly?
Yes, we do.
They're large enough?
Yes.
Okay, very good. So yesterday I talked about a variety of new technologies for the treatment of hemophilia, largely involving new proteins, as well as other molecules such as RNA. Today, I'm going to focus on gene therapy. A major difference is that the gene therapy to date has only been available for adults. But toward the end of the talk, I will discuss what the path looks like for moving toward children. My disclosures, I work with a number of different gene therapy companies, actually, that are focused on both hemophilia as well as other diseases. So we've had some dramatic changes in the therapeutic landscape that I discussed yesterday. In 2014, all we had really were plasma-derived clotting factors and recombinant clotting factors. However, since 2014, we have had a number of other factors that have allowed us to move toward goals of 0 bleeds per year and allowing patients to function at their desired physical activity levels. This is a concept that Cedric Hermans and I have talked about as a hemophilia-free mind, moving in that direction, and eventually moving in the direction of a functional cure. So these are all of the other products that have come along, mostly since the last 11 years. And my focus will be on the bottom today, which is gene therapy, both AAV gene therapy as well as lentivirus gene therapy. So with all of these modalities, where does gene therapy fit? It's been amazing. Modalities that have been developed have permitted treatment changes that have enabled a much greater quality of life for patients with hemophilia and much more freedom from bleeding over the course of these years. So that's important to consider in context, because when the factor IX gene therapy that's on the market, etranacogene dezaparvovec, and the factor VIII gene therapy that's on the market, valoctocogene roxaparvovec, were conceived 11, 12, 13 years ago, we didn't have all of these other modalities. And our goals really at the beginning of this effort were to get to 5 to 10% factor activity levels. But with the AAV5 factor VIII trial, the valoctocogene roxaparvovec, we saw 100% factor VIII levels in patients using the one-stage assay at 1 year. And so that really changed everyone's thinking about what was possible with gene therapy, and that included sustained normalization and the concept of a cure. However, there are benefits and risks with gene therapy, and so in that sense, it's a different modality because it is not understood as well as the other therapies that are being administered. A study that came from Yasim Dargood and her colleagues in Lyon really looked at a number of patients who had gene therapy and began to describe what some of their considerations were. I won't go through all of this now, but suffice to say that it's been life-changing for many of these patients. And so on the left side are the positives, such as no concern about bleeding, less need for medication, no infusion schedule required. On the other side, gene therapy, of course, in adults can't improve existing arthropathy that's already occurred. And the hemophilia does remain transmissible, and that's important for patients to understand. And then there are other various concerns, such as the concern about loss of efficacy of the gene therapy. So we're at another crossroads for gene therapy. We've been at many crossroads since 1990, when the first gene therapy was done in a human being. But in 2025, as we look at a tremendous amount of work from a lot of people, a lot of companies, and literally billions of dollars having been spent, where are we? Well, the phase 3 results for the factor VIII shows that it does not give the same kind of results as factor IX gives. That's one point. And then in the factor IX side, the two phase 3 studies for factor IX, one showed clear benefits over the other. And so that brings us to that kind of a crossroads. Specifically, Pfizer, which had factor VIII and factor IX programs, halted the development and marketing of both of those programs in the last several months, and pulled the factor IX actually from the market, where it had been approved for about 10 months. Spark, now part of Roche, halted their phase 3 study before it ever enrolled a patient, and are seeking to develop a phase 3 study with an improved factor VIII transgene. And as I mentioned yesterday, this non-gene therapy therapeutic armamentarium has given us a tremendous number of new products that can be of benefit to people with hemophilia. And so that provides competition for decision making. As we heard from Imelda on the last talk, shared decision making has to consider all options for patients that are available to them. So what has enabled factor IX curative therapy in many of the individuals treated with gene therapy for factor IX? One major finding that has enabled factor IX gene therapy got started in the late 1990s with Darrell Stafford at the University of North Carolina, Chapel Hill. And he was doing random mutations on the factor IX amino acids, and he found that arginine 338 turned into alanine gave 2 to 3-fold increase factor IX activity over and above the native factor IX. That was an important finding, but nothing happened from that finding until serendipity entered, and two brothers in Padua had hyperactive factor IX activity. One brother did have thromboses, and the other also showed 7 to 8-fold increase. It was at the same amino acid that Darrell Stafford had worked on, but this time substituting arginine for lysine in these boys gave the huge increase in factor IX activity. It wasn't long before scientists recognized that this could enable factor IX gene therapy, which had been giving inadequate results in human clinical trials. So this increased specific activity, one amino acid, 2 nucleotide changes, was enabling for the subsequent studies. This is work on etranacogene dezaparvovec, and it's the phase 3 study. And what I'd like to call your attention to is the factor IX activity on the y-axis as a function of time. And this is going over 18 months, but they've generated 3-year data that shows, number one, stability, number two, activity in the 35-36% range for these patients on average, and very few patients at the low ends. 2 patients did resume prophylaxis. There were valid reasons for that. One patient had an anaphylactoid reaction after about 10% of the dose was infused, and the second patient had a high AAV antibody titer that precluded the ability of the AAV to get to the cell. It got neutralized. In addition, about 17% of these patients had transient ALT elevations and required steroids, a relatively low number compared to the factor VIII trials that I'll tell you about. And then the second phase 3 study for factor IX, for hemophilia B, fidenacogene elaparvovec, had results that were about 10% lower than the etranacogene dezaparvovec results, 25 to 27% over time. Nonetheless, they appear relatively stable. And in this graph, where they're showing the factor levels over time with different colors, so looking at the lowest levels at the top, one can see that there's been a small increase in the number of patients that are at the lowest level, and there is a relative stability of patients that are at the highest level of factor. And so 6 of these patients resumed prophylaxis, and 18% of the patients had factor IX levels under 5%, which does put them at risk for breakthrough bleeding. About half had increased ALT elevations, and those individuals were on steroids for transient periods of time to control their ALT elevations. And so if one concludes the factor IX gene therapy, the first product, the etranacogene, had about a 40% higher factor IX activity relative to fidenacogene. And about half of the etranacogene patients were at 40% or above. Proportion of ALT elevations and steroid requirements was much lower for etranacogene, and in addition, the levels of etranacogene do appear to be stable at least through 3 years. And in fact, if we look at all of the factor IX studies that have been done, most of them do show stable factor IX activity over time. And then, as I mentioned, the fidenacogene was pulled from the market after 10 months and no sales. So if we move on to factor VIII, this is a study I was heavily involved in, valoctocogene roxaparvovec, and this is the phase 1/2 result. And the big surprise for us at that time was that using the one-stage assay, these patients got into the normal range. Actually, they got to close to 100%. The chromogenic assay, which is probably more accurate, is less, but it shows that the majority of these patients were in the normal range, which is the shaded area here, with a mean of about 56%, a median of about 46% at the end of a year. So this was a huge surprise. We were expecting 5 to 10%. And so it really reset everyone's thinking about what was possible with gene therapy. Unfortunately, surprise number 2 was a loss of activity over time. And so over these first few years, this is study weeks that are shown here, the factor VIII activity decreased. These are individual patient curves that are being shown here, 7 patients. And so you can see they've decreased. They appear to be stabilizing in years 5, 6, and 7 in this study. But there had been a very steep drop, and the stabilization is occurring really at levels well under 20%. And so it's a median of about 5.1% at years 5 to 7. And so that was very disappointing. Nonetheless, this wasn't known when the phase 3 trial was developed, and so it was developed using the same dose. And what one can see here, looking over nearly 5 years of data, is that the characteristic early rise within the first year, and then it stabilizes, but that it did continue to come down at year 2, year 3, and then it appeared to stabilize from year 3 onward, but at lower levels than had been planned. So you can see the medians here are in the 7 to 8 range for these patients. And this is a substantial number of patients, over 130 patients through 4 years. And so it's probably important to point out that these patients did have good success with bleeding. They had very little bleeding and had very little requirement for exogenous factor VIII. This graph looks at the data in a similar way as the factor IX graph did for fidenacogene, and it looks over a period of 4 years, about 130 patients. And what you can see is that at the top level, which is greater than 40%, the patients start off with a relatively high amount, and then it decreases over the period of 4 years down to about 8%. And then if we look at the bottom where they're under 5%, you can see that the orange and the purple continue to go up over time. And so these patients do appear to be gradually losing activity, which does necessitate going back onto prophylaxis. So 24% or 24 participants or 18% did go back on prophylaxis. Nonetheless, for the patients who didn't go back on prophylaxis, they did have good results even as they lost some of their factor VIII activity. They still remained largely in the mild range. So what's going on here? And what the valoctocogene trial clearly elucidated is that there probably are many things that are going on, but what we can observe phenomenologically is a lack of predictability on a per patient basis, high variability among all of the patients in the trial, ranging from no response to supernormal responses. A lack of durability, as I've shown you for the factor VIII, the inability with AAV to do any top-off dosing or any additional dosing, given the very high antibody titers to AAV that are made when quadrillions of AAV particles are infused into a patient. And it points to the fact that we're human bioreactors, our livers are human bioreactors, not 15,000 liter stainless steel tanks. And we don't have good control over that the way we would a 15,000 liter stainless steel tank making a protein. And so you can dissect out where some of the problems may be. AAV manufacturing is still in its very early stages. The quality control used to determine batch-to-batch variability is poor. And so batches that appear to be similar do give different results in human clinical trials at the same doses. So clearly there is more work to do there. I just mentioned the gene therapy recipient variabilities, the variability of the bioreactors. Patients have different degrees of metabolic associated steatotic liver disease. Patients can use liver toxins that can affect the results of the gene therapy. And of course, their genetics and their epigenetics all come into play. And then the ranges of response to therapy, as I've shown you on the previous couple of slides, range from success with good therapeutic levels of gene therapy that really give the patient the equivalent of a hemophilia-free mind, down to gradual loss of transgene expression with the restart of bleeding. And the associated liver toxicity from the AAV therapy that can last weeks, months, or even be recurrent, as in the valoctocogene trial, over a period of years. So part of our problem is that we're dealing with two complex life forms, one far more complex than the other, humans, but even the virus is really quite complex, and we don't understand the interactions of the virus or the viral vector with the human host cells, such as the hepatocytes. We don't understand how the virus actually gets into the cell. We don't understand how it escapes from the endosome, how some of it makes its way into the nucleus while the rest of it gets destroyed and is presented on the cell surface to attract cytotoxic CD8 positive T cells. And then once it's in the nucleus, we don't understand the processes of capsid uncoating and the process of the DNA, the cassette, forming circular double-stranded DNAs as episomes and then concatemers as well. So there's a lot that's not understood. And the key thing here is that we don't need to understand if we have good results, but if we don't have good results, it's important to understand where the problems are in this kind of a mechanism of viral entry into protein production, and then look for interventions that can improve any one of those steps, which is what some people are doing, but not enough progress has been made on that. I would also point out that everybody talks about how efficient AAV is, but what we're really delivering in a dose is about 100,000 AAV genomes per one hepatocyte. So it's more efficient than lipid nanoparticles and naked DNA, but I might question how efficient that really is. So what are some of these contributors that have been identified to date? Well, early on, we had done work to identify that the AAV capsid peptides were expressed on the surface of the cell in the context of MHC class 1 that could bind to specific peptides of the capsid and attract effector cytotoxic T cells. Other trials demonstrated that CpG motifs within the cassette itself triggered a TLR9 response and an innate immunity that could result in the loss of all factor IX activity. And then both transcriptional silencing and translational silencing has been identified as contributors to the problem. Without a whole lot of human evidence, but some animal evidence that does suggest it. The evidence in animals really comes from a whole series of papers beginning in 2008 from Randy Kaufman here in San Diego. What Randy found was that factor VIII is very difficult for any cell to make, certainly any heterologous cell to make. And in fact, more recently in 2020, published a paper demonstrating reversible amyloid aggregates of the factor VIII within the lumen of the endoplasmic reticulum. That then leads to an ER stress response, which can damage the cell or even kill the cell. This has been demonstrated in animals, has not really been demonstrated in humans as a cause, but is a leading hypothesis for at least one of the causes for the variability as well as loss of factor VIII. And then work done by Sylvia Fong at BioMarin looked at human biopsies from their factor VIII trial with valoctocogene and showed that there were two patients who had about two copies of the vector per diploid genome. So that's a respectable number. These are the copies of the other patients that were biopsied. But as a function of RNA, they had almost no messenger RNA for the factor VIII. These are the two patients shown here in red and blue. And you can see they started off with some reasonable levels, 10 to 20% factor VIII, that dropped down to close to zero at the time of the biopsy. And so this is transcriptional silencing, which was unexpected, and at this point is phenomenology. It's not understood what happens to the episome and the mRNA that would cause the transcriptional silencing. And so I'm going to move on to next generation kinds of gene therapy. And those involve gene editing. And so that can be done directly by using an AAV to transport the factor IX transgene, in this case, with a lipid nanoparticle as a vector. And then it homes to the liver, and then the gene editing occurs within the hepatocytes. That's an approach that both Regeneron and Metagenomi are taking. Regeneron is in early phase 1 clinical trials with this now. Metagenomi is looking to get into the clinic in this next year. And then on the right-hand side would be gene editing ex vivo. And so that involves taking either hematopoietic progenitors or B cells, doing gene editing in vitro, and adding in the factor VIII or the factor IX gene, and then growing them up, expanding them, either expanding the hematopoietic stem cells, or in the case of the B cells, expanding them into differentiated plasma cells, then reinfusing. And that's an approach that both B-Bio is taking for B cells, and then two groups are taking for using lentiviruses and HSCs. And so to summarize all this in some nice diagrams that just got published by Roland Herzog and his colleagues, this is what I've been talking about with straightforward AAV vector containing factor VIII or factor IX genes, homing into the liver in unknown ways, getting into the cell, producing some protein. So that's what we've been talking about that has been in clinical trials. For gene editing, the modification involves continuing to provide the AAV vector to deliver the transgene, but then also administering a lipid nanoparticle that can affect gene editing and insert the transgene into a safe harbor, which in this case is the albumin gene, to take advantage of the albumin promoter, very, very strong promoter, to generate factor IX protein. And that's what is currently in early clinical studies for hemophilia B. And hopefully we'll enter the clinic for hemophilia A in this next year. Now, some other approaches include the work using lentivirus with a platelet-specific promoter, megakaryocyte-specific promoter, so that the factor VIII is only made inside of the platelet. And so it's activated with degranulation at the site of a wound. No factor VIII can be detected in the circulation. So I'll describe that in just a moment. And then a second approach also involves lentivirus, but instead of a megakaryocyte promoter, using a monocyte-specific promoter, so that the factor VIII is made in monocytes, secreted from monocytes, and is able to then circulate. And so that is also occurring with in vitro gene editing with the stem cells, and does require some myeloablation in order to get the cells back into the marrow. And then the third approach involves isolating B cells by leukapheresis, inserting the factor IX padawa gene into an AAV vector, and then transducing the B cells along with a lipid nanoparticle delivering the CRISPR-Cas9, actually proliferating and differentiating those B cells into plasma cells, and then putting them into a safe harbor, putting the gene into a safe harbor locus, the CCR5 gene, which is not functional in B cells. And then the factor IX can be secreted then from the plasma cells. And so that's the approach that B-Bio is taking that now has an open IND for studying this in humans. So if I come back to some specific trials, this is a lentivirus factor VIII phase 1/2 trial conducted by Alok Srivastava, who at that time was at this Christian Medical College, Vellore. And so he's been working at this for a long time. An early process didn't reveal a whole lot of factor VIII activity in using the lentiviral delivery of factor VIII. But nonetheless, these patients are not bleeding anymore, which is what's shown on the graph below. And then these last 3 patients, he had modified the process, and they've got factor VIII levels in the 25 to 60% range. And so this is clearly a significant success. These patients would be expected to really have a permanent essentially cure of their hemophilia at this point. And so you can see the bleed rates in all of these patients have gone from high levels per year because they were on-demand therapy down to very low levels. And then the other trial with lentivirus, platelet targeting, is following a similar approach. They also did use some cytoreduction. Didn't detect any circulating factor VIII. And in their one patient, over the course of, I think, about 9 months, they went from an ABR of 10 to an ABR of 0. So these are preliminary data, but point in an encouraging direction. And then for the factor VIII, these are primate data. And so this is gene editing with factor VIII, delivering the factor VIII in an AAV8 vector, and then moving it along with a lipid nanoparticle into the liver. And so you can see in these 3 primates, we have factor VIII levels ranging from relatively low, 9%, up to 72% of normal. And so while we see a lot of variability here by 16 months, this is encouraging and would point to a permanent effect, given that these are gene edited into the albumin locus. And so all of this gene editing work is encouraging. So as I mentioned, we've got 2 open INDs for factor IX gene editing. And what I want to point out is that for the first time, we can begin to think about children with this approach, given a sufficient evaluation of the benefits and the risk. And so for traditional AAV gene therapy, going into children is considered to be problematic because as the liver continues to grow, it is thought that the transgene will get diluted out. Whether that's true or not remains to be determined, but that has precluded some work in children, along with the fact that there's transaminase elevations, steroid requirements. However, in this case, it does offer more possibility to begin considering how one could potentially treat children on a more permanent basis. And then the other area that is being pursued is really a biobetter factor VIII. So we don't have the factor VIII equivalent of factor IX PADOA with a 6 to 8-fold increase in activity, but there are a number of specific mutations that have been made in the factor VIII gene that can produce increases in specific activity or enhanced secretion from the ER Golgi, less propensity to develop ER stress. And so those need to be evaluated clinically. I showed you this slide yesterday and didn't cover the gene therapy. So we have this multitude of choices ranging from relatively short-acting factor VIII and factor IX to much more extended half-life factor VIII and factor IX. To non-factor therapies that can produce hemostasis and some factor VIII equivalents, as well as be beneficial in the rebalancing agents for factor IX. And then the gene therapy, where with factor VIII, we see gradual loss and then perhaps some stabilization. And for factor IX, we have a consistent result that is within the therapeutic range for most of the patients. And so this is really a tremendous amount of progress over a period of about 11, 12 years now. And we had a terrific talk from Imelda that covered shared decision-making. I won't go into it in any further depth, except to say that with this multitude of therapies, we not only have a lot of choices, but these are really complex therapies. They're complex for lay people to understand. It has to be translated carefully and repetitively to be able to help patients, their family members, to understand that. And that requires healthcare providers who then have a good understanding of these therapies and can help the patients to weigh the benefits and risks and determine what therapy might be the best therapy for them. And I would be remiss if I didn't say everything that I've been talking about applies primarily to about 15% of the world for commercialization of gene therapy, and the rest of the world continues to be ignored by pharma for all of these innovative kinds of products. And so that's most unfortunate that we're in this situation. The health inequity is increasing, not decreasing, given all of these innovative therapies that are benefiting such a minority of the world. I'll thank you for your attention and would be happy to take any questions.
Thank you so much, Dr. Pierce, for the excellent presentation. I don't see any questions, but the hemophiliacs are lucky because there are a lot of advancement and a lot of innovative treatment awaiting them. Not like unlike the patients with sickle cell disease and thalassemia, where the progress is much slower. Thank you so much, Dr. Pierce. Now we move to the next speaker. Our next speaker is Dr. Stacy Creto. Dr. Stacy Creto is a pediatric hematologist and clinical researcher specializing in hemophilia care. She focuses on integrating individualized pharmacokinetics profile to optimize the treatment outcomes. Dr. Creto leads multiple clinical trials and serves as medical director at the Boston Bleeding Disorder Center. She is also an assistant professor of pediatrics at Harvard Medical School and mentors clinician and trainee at Dana-Farber Boston Children Cancer and Blood Disorder Center. Welcome, Dr. Croto.
Good afternoon, everyone. It's such a pleasure to be with you today. Thank you to the organizers for inviting me to present on this very important topic, which is von Willebrand disease, or VWD, practical experience and novel approach. So we've actually come up on the centennial of recognition of von Willebrand disease. So did want to take a moment to recognize where the first individuals with the most severe or type 3 type of von Willebrand disease were first recognized on the small Åland Island archipelago deep in the Baltic Sea. And you can see the home here, the farm of Jordis Sandblom, who was the first individual who unfortunately passed away after several of her first menstrual cycles from heavy menstrual bleeding, and the Finnish physician, Dr. Erik von Willebrand, who treated her and did some investigations in her family. Over the past 100 years or so, a bit in contrast to what you've heard over the last 2 days from Dr. Pierce in terms of the recognition and innovations in treatments for hemophilia, the treatment innovations for von Willebrand disease have been a bit more muted, at least until the past decade or so. So here's a highlight of a timeline from the first recognition of von Willebrand disease in the mid-1920s, as I highlighted, and some of the treatment innovations and therapies that we've had, both for bleed treatment and increasingly for bleed prevention and the recognition of importance of prophylaxis for von Willebrand disease. So you'll recognize the importance of cone fractionation in the first treatment, the code 10 in the 1950s, to be followed by pooled cryoprecipitate plasma-derived concentrates. The use of high-dose desmopressin, or DDAVP, was recognized in the 1980s. And then subsequent to that, we really continued in much of the world to rely on either cryoprecipitate or hopefully at least plasma-derived von Willebrand factor concentrates, with the first recombinant concentrate becoming available in the 2010s in some areas. And really, even to date, recombinant von Willebrand concentrate remains approved, at least in some areas, for adults only. And investigation in the pediatric patients remains ongoing. But what comes next? I mean, with all of the innovations that you've heard about, non-factor therapies in hemophilia, gene therapies in hemophilia, what else do we have to offer our von Willebrand disease patients, especially those with more severe forms of von Willebrand disease, more frequent bleeding symptoms? And we now have emerging treatment options for VWD that are coming into clinical trials or perhaps even being used off-label. So emicizumab, you'll recognize as a bispecific antibody that hopefully is something that is already in your clinical practice for hemophilia. Its potential use in subtypes of von Willebrand disease, including type 3 von Willebrand disease and type 2N von Willebrand disease, remains with some case reports and some early clinical trials. But we'll also touch on a few additional options in terms of aptamers and other antibody technologies, platelet-inspired nanoparticles, et cetera, that may be beneficial in this space. Von Willebrand disease continues to be a marked clinical challenge. So while it is often credited as the most common inherited bleeding disorder, accurate and timely diagnosis of von Willebrand disease remains challenging. And there's a number of barriers that lead to this. It continues to be challenging to help distinguish sometimes the difference between normal and abnormal bleeding symptoms, whether it's epistaxis, nose bleeding, heavy menstrual bleeding, where the tipping point is from the severe end of the normal spectrum into pathologic, sometimes can be obscured. And depending on the type and the location of bleeding, individuals may not feel comfortable highlighting their bleeding symptoms or bringing that to attention of family members or to medical providers. That can compound delay in recognition of the problem. There's also a general lack or limited availability of some of the specialized laboratory testing that's needed to diagnose von Willebrand disease, as well as the expertise to either run those clinical labs or even the expertise to interpret it. Unlike some of our factor levels where there's a more consistent factor level activity, phenotype correlation, there can be some nuances to interpreting von Willebrand disease panels, and having experts who are able to integrate the clinical input along with the laboratory data is very important. All of that said, it's very important, though, to improve our accurate diagnosis because we want to ensure individuals have access to the care that they need, to the medical therapies that we can provide to both prevent and treat bleeding. At the same time, we also want to ensure that we don't over-medicalize individuals or lead individuals to have inappropriate or excessive testing, or label individuals with von Willebrand disease who really don't have a bleeding disorder or an increase in bleeding risk, because there are harms, of course, both to the individual, to what things that they might pursue in life, to potential challenges, depending where you are in the globe with different types of insurance or job opportunities that can come with overdiagnosis as well. And I would say currently there's a wide variability in clinical practice for the treatment of von Willebrand disease. And a lot of this variability in clinical practice, as we've highlighted, has to do with a high uncertainty of evidence to guide decision-making. Everything from some of the challenges around the diagnostic decision-making, but also the management decision-making in terms of bleed prevention and bleed treatment. Fortunately, through a monumentous effort across multiple organizations, including the American Society of Hematology, the International Society of Thrombosis and Hemostasis, what was then NHF, but is now our National Bleeding Disorder Foundation, and the World Federation of Hemophilia, in the early 2020s and 2021, we had a new set of von Willebrand clinical guidelines that really, I think, are going to form the important cornerstone of how we move forward, both with diagnosis. There was one set of diagnostic guidelines that was published, as well as with management. We also had a separate set of management guidelines that were published. And if you haven't yet had an opportunity to review these are absolutely essential articles to keep within your toolkit when you're thinking about individuals with von Willebrand disease. From a diagnostic perspective, the clinical guidelines on diagnosis included 11 recommendations, and I've highlighted just a few of them here. But perhaps not surprisingly, the recommendations led off with the importance of improving education around the value and the use of bleeding assessment tools. I would say both in the setting of primary care physicians to some extent, but also something that can be leveraged by us as specialty providers, especially depending on our clinical environments and the availability of our primary care foundation to access and leverage utilization of these tools. There's also some new recommendations that broaden the classification of von Willebrand disease to be more inclusive. So again, of trying to avoid overdiagnosis, but making sure that individuals with abnormal bleeding symptoms, those that need access to specialty care, to specialty treatment, aren't inadvertently excluded and left without appropriate access to care. They also approach some of our adult patient challenges of changing in the baseline of von Willebrand factor levels over time and the potential for increase in seeming normalization of von Willebrand levels in later decades of life, as well as addressing some of our potential opportunities to use targeted genetic testing to help resolve some of the subtypes of von Willebrand disease. This diagnostic algorithm is taken from the diagnostic algorithm within this guideline, but I've broken it down a bit for us today so that we can go through a few scenarios to highlight common things that we'll see in clinic and common pathways that are important to have within your mind. So if you have an individual coming to you, referred to you with a suspected bleeding disorder, including von Willebrand disease, it's helpful to start with a bleeding assessment tool. And the ISTH, or International Society of Hematology bleeding assessment tool, comes in multiple forms in terms of forms that a patient themselves can complete. There are provided completion forms, but really the focus of the tool is to look at multiple domains, epistaxis, surgical bleeding, bleeding in various locations of the body, to help assess how many different domains where we might see bleeding symptoms. And then with each of those domains has a numerical score to either assess no abnormal bleeding in this domain or increasing numbers to highlight the types of therapies that were needed to address bleeding in that domain, such that higher scores lead to higher bleeding assessment tool findings and the thought of a higher risk of a bleeding disorder. So if you have a negative or normal bleeding assessment tool score, it really excludes, for the most part, von Willebrand disease, or might lead you to have a low suspicion for a bleeding disorder or need to do additional testing to rule out a bleeding disorder. Of course, as a pediatric provider, low or negative BAT scores are not always excessively reassuring to me, because it's important to consider limited prior hemostatic challenges, especially for young children. So as you're dealing with young adults or adults who've had decades now of life, day-to-day hemostatic challenges, dental work, other types of potential surgeries or procedures, the negative scores carry more weight. Certainly if an 18-month-old is brought to you before a tonsillectomy and adenoidectomy, or do a family history of concern, even if that individual has not yet manifested a high bleeding assessment tool score, they may warrant additional consideration just due to their limited prior hemostatic challenge. And here's an example of the bleeding assessment tool as I highlighted. This is a condensed form, and just to show you each of the different categories, as I mentioned, with the numerical scores that increase with the additional treatment needed to manage bleeding in any particular domain. I will highlight for you at the bottom, of course, that the normal range depends both on sex as well as on age. So we have a lower normal set point for the pediatric patients, in part due to limited prior hemostatic challenges, and really driven by heavy menstrual bleeding and the broad differential and causes of heavy menstrual bleeding that tends to drive the normal range for females, XX genotype, higher compared to adult males. Thinking about the bleeding assessment tool now in a positive light, and so I've highlighted the normal ranges. Now, when we're thinking about abnormal bleeding symptoms, certainly for the individual, for our youngest patients, perhaps due to the family abnormal bleeding symptoms as well, then we need to move on to our first tier of testing that should include things like a complete blood count to assess for anemia, to assess for thrombocytopenia, as well as our screening coagulation lab. So prothrombin time, activated partial thromboplastin time, fibrinogen, and the von Willebrand panel. And for the purposes of this lecture, of course, while we can have abnormalities in all of those different laboratories, we're going to focus on the von Willebrand panel, which of course includes three key components: von Willebrand antigen, or the amount of von Willebrand factor, some assessment, generally a platelet-dependent assay that captures von Willebrand functional activity, as well as an assessment of factor VIII concentration. So we continue generally to use a cutoff of 50 and greater. So when your von Willebrand levels are greater than 50%, we typically exclude a diagnosis of von Willebrand, except, of course, it's important to continue to consider the clinical situation in which you draw that von Willebrand panel. Are there concomitant medications? Are there other physiological stressors that could boost the von Willebrand levels above baseline? So in truth, are you getting the individual at a baseline physiologic state where you believe that that von Willebrand panel that you have drawn represents their baseline? Or are you catching them in a stressed situation in the emergency room? Are you testing them just after a significant febrile illness with a lot of inflammation, different physiologic parameters that we know can bolster the von Willebrand levels? And here are two tables that help us remember both some of the normal physiologic reasons that we can see both increased and decreased von Willebrand levels. So things like exercise, aging, high estrogen levels, stress. We also know that from a decreased von Willebrand level perspective, there are some variabilities in expression related to blood type, and individuals with blood type O seem to have a bit of a lower normal set range for von Willebrand. And then certain things like hormonal therapies, cigarette smoking, medications can variably alter von Willebrand as well. We also have a number of pathologic causes that can both bolster and diminish von Willebrand levels. So elements like atherosclerosis, liver disease, inflammation, cancers can bolster von Willebrand levels, where other pathologic causes included hypothyroidism, cardiac disease, autoimmune disease, also cancers, may decrease von Willebrand levels. And you'll recognize that in many of these cases, these mechanisms decrease von Willebrand levels through acquired von Willebrand disease, increased shear stress, or other deterioration of the von Willebrand factor. And then we have our gray zone, our von Willebrand levels of 30 to 50%. So not quite comfortable over the 50% in the normal range, but not less than 30%, the classic diagnostic range for most von Willebrand disease, certainly type 1 von Willebrand disease. And so we have this low von Willebrand category. So for individuals that fall in this gray zone or low von Willebrand zone who have not manifested any bleeding symptoms, they may just be appropriately labeled as normal or low von Willebrand. But again, here, from a no bleeding perspective, we want to consider potentially the young children who haven't yet had hemostatic challenges. We also need to consider some of the assays being used. So it's been well recognized at this point that in particular, the ristocetin cofactor assay as a measure of von Willebrand activity has some downsides in terms of known benign variants within the von Willebrand factor gene, including the variant D1472H, that simply interferes with ristocetin's ability to activate von Willebrand factor. So it causes low levels in vitro when we're doing the coagulation testing, but does not in vivo impact hemostasis. So some of these laboratory artifacts have very much led to individuals being labeled with von Willebrand disease, in particular type 2M von Willebrand disease, even though those individuals never manifested abnormal bleeding symptoms. And again, due to an artifact of the laboratories, not due to actual type 2 von Willebrand disease. Here I've highlighted some of the various assays that we do have available for looking at von Willebrand factor activity. So the two on the right, the von Willebrand by ristocetin cofactor, as well as the GP1BR, are ristocetin dependent, where an assay, the GP1BM, is ristocetin independent and actually takes advantage of microparticles that are coated with an anti-GB1 antibody, and leveraging the increased affinity that results in to help look at agglutination and look at von Willebrand activity in that way. And when you do some comparison of the von Willebrand activity by ristocetin cofactor compared to the newer GP1BM assay, you can see that we have some significant benefits of this newer assay in terms of a much lower limit of detection. So using the standard ristocetin cofactor assays, we often bottom out at about 10%, or in some institutions 20%, where we can actually resolve activity to a much lower value using the GP1BM assay. And also, this newer assay has a much lower variant of coefficient, so much more precise overall in its measurement. So this can be helpful not only in avoiding labeling individuals with some benign variants with a type 1 or type 2 von Willebrand disease diagnosis, but it also actually can help with our type 3 and our more severe type 1 von Willebrand disease patients, because we're able to resolve the levels a bit lower and really make a distinction between a severe type 1 and a type 3. So as we get to the sort of more proper or typically use less than 30% von Willebrand activity for making a diagnosis, also important to look at the von Willebrand activity to von Willebrand antigen ratio. So are we seeing sort of a 1-to-1 decrease in function and in von Willebrand amount? Or are we seeing the function impacted much more significantly than the antigen? And typically, to be as inclusive as possible, and per the guidelines, they're recommending a ratio be drawn at 0.7. So if your ratio is 0.7 or higher, that is essentially an equivalent decrement in your activity and your antigen. And so that puts you more in the category of a type 1 von Willebrand disease patient, for which an individual should go on to have a DDAVP trial to see if they're responsive. The majority of type 1 von Willebrand disease patients are DDAVP responsive, but not all. So determining their response and the magnitude of response is really important for being able to safely leverage that therapy, both peri-procedurally and in the setting of bleed events in the future. Use of the DDAVP challenge can also help us recognize a subtype of type 1 von Willebrand disease, type 1C, or rapid clearance von Willebrand disease. And so this subtype of type 1 leads, as the name suggests, to more rapid clearance. So even when you have a good and sometimes almost seemingly exaggerated, excellent initial response to DDAVP, by the time you hit 3 and 4 hours after use, that has already been cleared and you're back to your baseline. And so depending on the type of bleeding or location of surgery or procedure that's going on, DDAVP is often not ideal for those individuals with a type 1C von Willebrand disease. For individuals with a lower ratio, so a ratio of activity to antigen that is less than 0.7, now we're thinking more about type 2 von Willebrand disease subtype, so more qualitative defects in our von Willebrand protein. And so then we go on to second tier type testing within our von Willebrand testing, looking at things like collagen binding to antigen ratios, looking at von Willebrand multimerization. And these tests will help us further subdivide and categorize individuals into type 2A or B von Willebrand disease, type 2M von Willebrand disease. And certainly in some of these instances, these specific subtypes, if they are hard to resolve based on the functional testing, may be an occasion where genetic testing can be more helpful. It's also very important to remember type 2N or type 2 Normandy von Willebrand disease. This is the subtype of von Willebrand disease where the defect in von Willebrand factor is specifically within the area of von Willebrand factor, the D'-D3 region that binds factor 8. And so for these individuals, the factor 8 level looks much lower compared to the von Willebrand levels. And especially for new patients and new male patients, this often can initially be erroneously diagnosed as a mild hemophilia A. So certainly for females, for XX genotype presenting with low factor 8 levels, it's common for providers to not think of hemophilia A and do a bit more investigation or be thinking von Willebrand disease and make this diagnosis. But a very important thing to remember for both sexes, but certainly for new mild male factor 8 deficiency patients, to not just ascribe a diagnosis of mild hemophilia, and remember to check a von Willebrand panel and ensure that they don't have a type 2N von Willebrand disease, because of course some of the therapies that we leverage for hemophilia, specifically recombinant factor products, will work less well when the real defect is in your von Willebrand factor. So here's just a quick table to help summarize the various classification and major and minor subtypes of von Willebrand disease. So of course, our most common type of von Willebrand disease is our type 1 von Willebrand disease, which is a quantitative defect in our von Willebrand factor. We typically have preserved ratio in activity to antigen and a normal multimer distribution. The subtype of 1C is a rapid clearance of von Willebrand, so still a quantitative issue with von Willebrand factor. Also will have a normal ratio of activity to antigen. But when you look at some of the newer available testing, including von Willebrand propeptide, you'll often see a marked increase in propeptide compared to antigen, again, representing the increased clearance, because your propeptide and your antigen should be secreted in a 1-to-1 ratio. Having a much higher propeptide level tells you that you've lost a bunch of the von Willebrand antigen, that's been cleared too rapidly. And then, of course, the subtypes, type 2A, type 2M, type N and B, that has to do with altered interaction, primarily with platelets, except, of course, for 2N, which is a decrease in binding of factor 8. And then, of course, our most severe form, or type 3 von Willebrand disease, which is an absence of von Willebrand factor. The guidelines have also helped us with a number of challenges with respect to von Willebrand disease management. And again, I've just briefly summarized some of the key recommendation topics here, and would encourage you to, again, go to the guidelines to be able to read more in depth of both the recommendations and the rationale and evidence behind those recommendations. But top of the list is thinking about prophylaxis in von Willebrand disease. Certainly this has become standard of care in children and increasingly in adults for hemophilia over decades, but we're still a bit behind, particularly in type 3 von Willebrand disease, but in all of the more severe types of von Willebrand disease where individuals are experiencing frequent bleeding events. Leveraging the DDAVP trials to help determine therapy, the importance, again, of identifying the magnitude and duration of response to DDAVP, consideration of the use of antiplatelet agents and anticoagulant therapies, particularly in adult patients as they have more morbidities of age, particularly related to cardiac morbidities, as we have various orthopedic comorbidities and need for orthopedic surgery. How do we balance pro and anticoagulant balance in those individuals and meet the appropriate standard of care without increasing their bleeding risk? How to target von Willebrand and factor 8 levels at the time of surgery. Options for treatment of heavy menstrual bleeding. How do we think about the management of von Willebrand disease in the context of epidurals and sort of optimizing the experience for individuals during labor and delivery, as well as in the postpartum setting. So this is a nice schema thinking about hemostatic support very generally in certain management situations. So this again comes from the guidelines. So when we have something in the bucket of a minor surgery, appropriate to target von Willebrand factor activity within the normal range, and also to think about the utilization of tranexamic acid. Of course, tranexamic acid and antifibrinolytics in general are quite beneficial to our broader bleeding disorder patient population and are used even in not the bleeding disorder population in a number of situations. But particularly for mucocutaneous type bleeding or types of surgeries or procedures that are taking place in an area that have a higher proportion of manipulation of those types of tissues, more beneficial perhaps than in some other locations. When we move on to sort of major surgeries, looking at both the von Willebrand factor activity as well as the factor VIII levels, and really maintaining both in the normal range, greater than 50% or 50 units per milliliter for at least 3 days. And it says at least because, of course, it depends a bit on the details of the major surgery that's occurring, whether 3 days would be adequate or whether additional days of replacement may be required to optimize both hemostasis and healing. For things like heavy menstrual bleeding, hormonal therapy, with or without tranexamic acid, may be of benefit. Of course, the management of heavy menstrual bleeding and use of hormonal therapy also depends on the current desires of that individual. Are they trying to start a family, to start a pregnancy? Of course, in those situations, hormonal therapy is not the optimal heavy menstrual bleeding management, but leveraging various techniques to manage both that bleeding and also to support sort of fertility and family planning is important. And then certainly for neuroaxial anesthesia, keeping levels within the normal range. We also want to acknowledge that there's a number of areas of uncertainty and need for research. And so I briefly highlighted this before, particularly with thinking about antithrombotic type management, the use of antiplatelet medications, as well as anticoagulant medications in various disease states. Thinking about post-operative management and what really are the optimum outcomes, the optimum levels and duration of therapies, the optimum utilization of tranexamic acid, either as monotherapy or in combination with replacement therapies. And then again, this emphasis on thinking more about prophylaxis, either situational prophylaxis for some individuals in the setting of anatomic specific persistent bleeding despite aggressive local anatomic interventions versus more general prophylaxis, particularly in our type 3 von Willebrand disease patients, for example. And this is the place where some of our newer therapies will, of course, be helpful to us. So thinking about currently licensed therapies, at least licensed in some areas of the globe, and how we might think about von Willebrand disease as a new indication. So currently licensed, for example, in the United States for hemophilia, we have some molecules like the factor VIII concentrate, efanesoctocog alpha, also known as Altuvio or BIV001. This is a multifaceted engineered and modified factor VIII molecule that provides high sustained factor VIII levels and dissociates the von Willebrand factor VIII binding need. So this factor VIII molecule has embedded within it a stabilizing D' D3 region that you can see highlighted there in the pink, such that our factor VIII levels are able to be sustained without binding endogenous von Willebrand factor. So to bolster factor VIII levels, specifically in our type 3 von Willebrand patients, to bolster factor VIII levels in our individuals with type 2N von Willebrand factor, for example, and the improvement that we may see in hemostatic supports from just bolstering the factor VIII, this molecule may be very helpful. Similarly, looking at the bispecific antibody, there is one licensed around most of the globe, emicizumab. There are additional factor VIIIa mimetics or substitution therapies that are currently under investigation that again does not replace the function of von Willebrand factor, but helps to bolster the effective factor VIII concentrations that are problematic in our more severe type 1, type 3, type 2N von Willebrand disease patients. And certainly as a bispecific antibody that can be administered subcutaneously and once a week or less, may prove to be helpful in terms of bolstering hemostasis for some of our subtypes of von Willebrand disease. And we have additional emerging treatment options, and I've highlighted a few of them here that are currently in a combination of early clinical trials and preclinical trials. So some things like BT200, which is a pegylated aptamer. The goal of this pegylated aptamer is to bind the A1 domain of von Willebrand factor, and by virtue of that, increase von Willebrand factor and factor VIII concentrations by decreasing the clearance of both. It's a molecule that can be administered through subcutaneous injection. They have completed a phase 2 trial in which they studied type 1, type 2B von Willebrand disease, as well as hemophilia A. And in the reported outcomes of the type 2B group, they noted a tripling of the platelet counts from a median of about 60 to 180. So marked improvement in the platelet counts there, as well as an improvement in the von Willebrand antigen from the mid-60s up into the 150 range. For this molecule, the phase 2 looked at a dose escalating schema, as you can see here, with a follow-up period. And this is just to highlight more on a per patient, per participant level. To the far left, the effects on platelet counts. So you can overall see an increase in most of the individuals until they stop the medication, and then you see a decline there. Similar in the middle, you see the von Willebrand antigen levels and then the factor VIII levels with a stable to gentle uptrend for most, and then a decline following removal of the therapy. In terms of sort of generalized hemostatic therapies, we have therapies like the VGA-039 and HEM-002. So VGA-039 is a monoclonal antibody that's directed against protein S. The goal here is to enhance thrombin generation through inhibition of protein S and its cofactor activity on TFPI alpha and activated protein C. It can be administered either IV or subcutaneously, and they're still working on recruiting the phase 1/2. And similarly, HMB-002 is a monovalent antibody. It has a high affinity target selective binding with the goal of preservation of von Willebrand factor and thereby increasing levels of both von Willebrand factor and factor VIII. The anticipation is that it will be administered subcutaneously, and they're very early in their clinical development as well. And then additionally, more in preclinical development, we have other nanotechnologies, including platelet-inspired nanoparticles and KBV1-3A12. So from a platelet-inspired nanoparticles, synthetic platelet nanoparticles, small lysosomal particles with multiple peptides that can facilitate binding to collagen, von Willebrand disease, activated platelets. You can, as you can imagine, dial in is sort of your optimal nanoparticle combination. With the KBV13A12, a bifunctional molecule that binds both albumin and von Willebrand factor, with a goal of being able to be administered subcutaneously in bolstering von Willebrand factor plasma levels. So I'll leave you with this overview slide that hopefully proves to you that while the challenge of diagnosing appropriately von Willebrand disease and managing von Willebrand disease remains for all of us across the globe, there very much is an enriching arsenal of therapies that we will be able to use for von Willebrand disease. And I think importantly, as Dr. Pierce highlighted at the end of his preceding talk, making these therapies available not only to a select number of von Willebrand disease patients, but for our global population of von Willebrand disease patients, particularly those wherever they are in the globe with the more severe elements of disease, more severe bleeding phenotypes, to help improve our access and the quality of care that we're able to deliver. Thank you so much for your attention.
Thank you so much, Dr. Crotio, for the excellent presentation. And I don't see any questions, so we'll move to next speaker. Our next speaker is Dr. Next speaker is Dr. Saad Ahmed. Dr. Saad Ahmed is a consultant hematologist specializing in bleeding disorders at Children's Health Ireland, Dublin. He also serves at the National Coagulation Center, St. James's Hospital, where he leads the transition of bleeding disorder patients from pediatrics to adult care. Dr. Ahmed completed his medical training and higher specialist training in hematology in Ireland and earned his MD from the Royal College of Surgeons in Ireland in 2020. Welcome, Dr. Saad.
Assalamu alaikum, Dr. Najat. Thank you for having me. So I'm going to talk today about thrombosis in children. And I'll start by saying that thrombosis in children is different from thrombosis in adults. We don't have that many clinical trials in children, and many of the recommendations for treatment of thrombosis in children were extrapolated from adult research. The other difference that the epidemiology in pediatric thrombosis is different from adults. While generally in adults, thrombosis risk increase with age, in children, there is 2 peaks of thrombosis high risk. The first is during infancy, and the second is during adolescence. The sites of thrombosis in children is also different. By far, the most common site of thrombosis will be central venous catheter-related thrombosis, followed by renal vein thrombosis, which is not the case in adults. The pharmacokinetic of anticoagulants is also different in pediatrics, and that's why the guidelines for treatment of thrombosis in children will be different from adults, as I will show you. And finally, the duration of anticoagulation to treat thrombosis is also different in adults, like in children compared to adults, because children obviously has many years to live. So to keep a child on lifelong anticoagulation is not an easy decision. So in terms of epidemiology, pediatric VTE is increasingly frequent in the last 20 years. And there is more awareness of the risks of pediatric thrombosis internationally. The incidence is about 0.2 in 10,000 per year, but the incidence in hospitals, especially tertiary hospitals, is much higher. It is estimated to be about 1 in 10,000 admissions. And obviously it is more common in tertiary hospitals because of the high risk after cardiac surgery, spinal surgery, more complicated procedures that are done in tertiary hospitals. And as I mentioned before, pediatric thrombosis has 2 peaks. The first is infants and the second adolescents. What are the risk factors for VTE in children? It's the same as the Shaw triad: endothelial damage, stasis, and hypercoagulable state. The endothelial damage in children, as I said, by far the most common risk factor is central venous catheters. And it is estimated to be 1 to 2/3 of venous thromboembolism in children. Sepsis, antiphospholipid antibodies, trauma, and inflammatory conditions such as inflammatory bowel disease and SLE. The risk factors that cause stasis or disruption of blood flow will include surgery, especially major surgery and cardiothoracic surgery, reduced mobility, and anatomical problems, things like Turner, which is the anomaly where there is pressure on the mainly on the left common iliac vein by the right common iliac artery. And those are the patients that may require intervention by usually stenting. Also, things like Paget-Schroeder syndrome, and that will lead to upper limb DVT, and they may need resection of first rib to treat that. Congenital heart disease is one of the major risks for thrombosis in children, and total parenteral nutrition is another major risk. In terms of hypercoagulable states, inherited thrombophilia, especially major inherited thrombophilia is like antithrombin deficiency, protein C and protein S deficiency, and acquired problems like antiphospholipid syndrome, pregnancy, hormones, nephrotic syndromes, and medications, especially things like asparaginase that is used in treatment of ALL, and infections. And one example is varicella zoster, because varicella zoster lead to acquired deficiency in protein S, one of the natural anticoagulants, and things like inflammatory bowel disease and malignancy. The prognosis of VTE in children can be quite significant. Mortality can be up to 2.2%, like directly attributable to VTE. Recurrence rate is about 8.1%, and post-thrombotic syndrome can happen in up to 12%. And this is from the Canadian Registry published in 2000. How do we diagnose VTE in children? For peripheral DVTs, ultrasound is recommended for initial assessment. This can be compression ultrasound or Doppler ultrasound to see the flow. While for central veins, or if there is suspicion of extension of peripheral DVTs to central veins, then you will need other investigations, imaging techniques like MRI, so MR venography, and if it's not available, CT venography then can be used. For pulmonary embolism, the first line is CT pulmonary angiogram. Isotope scan can also be used. In suspected cerebral venous thrombosis, also the first line will be MRI based, so MRI, MR venogram, and if not available, then to use a CT venogram. Obviously, patient would need baseline blood tests for blood count, coagulation screen, and renal profile before starting anticoagulation. And it is important to note in pediatrics, D-dimers should not be used to exclude VTE in children. It doesn't have the same sensitivity, specificity as in adults. And things like Wells criteria also cannot be used in pediatrics. In neonates and children who present with Perbora fulminans, the present usually will be with hemorrhagic skin necrosis and DIC picture. Those should urgently be tested for protein C and protein S deficiency. And children presenting with unprovoked VTE should be tested for antiphospholipid antibodies. And if antiphospholipid antibodies are persistently positive, then they need to remain on long-term anticoagulation. Children with early onset spontaneous thrombotic events should be re-screened for antithrombin deficiency, and this is as per the British Society of Hematology guidelines from 2011. Thrombophilia obviously is very popular, and as per the British guidelines, and that's also what we do in Ireland, we don't routinely check for thrombophilias in children presenting with serous VTE. But we only test them if they influence the management. So, and we only check for high-risk thrombophilias, so antithrombin, protein C, and protein S. It can be very tricky to test them during the acute event because the livers can be affected, and also very tricky to test them in very young children, less than 6 months, because the coagulation system is not mature. The livers are not similar to adults. In terms of acquired thrombophilias, we test for antiphospholipid antibodies following unprovoked VTE. Obviously, you can't do lupus anticoagulant while the child is on anticoagulation, but you can do anti-beta-2 glycoprotein antibodies and anticardiolipin antibodies. If there are symptoms to suggest hemolysis or unusual, very unusual thrombosis, we check for paroxysmal nocturnal hemoglobinuria. And we do an MBN panel to check for JAK2 V617F and JAK2 exon 12 and color and MBL if the patient presents with thrombosis at unusual site, especially if the full blood count is abnormal, suggestive of MBN. There's evidence that even with a normal FBC, adults and children can develop portal vein thrombosis. So we know that JAK2 mutation increases the risk, especially for abdominal thrombosis. So we check for JAK2 mutation in those children. So I'll go through a case, and then these are cases that we've seen recently in our center. And this is a case of a 4-year-old boy presented with history of itchy rash, and 7 days later developed painful swelling of his right leg. Ultrasound showed extensive DVT involving his right femoral and popliteal veins. Further test showed normal PT, ABTT. His protein C activity was normal, but his protein S activity as well as antigen were very low. So what is the diagnosis and how we treat? So this is presentation and results are in keeping with acquired protein S deficiency, secondary to varicella zoster. So we know that varicella zoster can cause acquired protein S deficiency, which can lead to increase the risk of thrombosis, and they can present with thrombosis. And we obviously treated the thrombosis with anticoagulation, and because it's only acquired anticoagulation for 3 months. These cases can be very severe and can, in that child, we gave a dose of plasma to replace protein S. In some severe cases where there is very strong immune antibodies that's reducing protein S, there might be a need for plasma exchange or immune suppression with IVIG or steroids. In this child, we didn't need to do that. And many of these children will need close observation in the pediatric intensive care unit. So what is the aims of management of DVT in children? Obviously, we want to reduce the risk of death, mortality from thrombosis. We need to reduce the incidence of recurrent thrombosis, the incidence of post-thrombotic syndrome, and maintain the liver patency in children who have the central venous line. In terms of pulmonary embolism, obviously it is rare in children compared to adults. However, it can have severe consequences. So massive BE with hemodynamic instability can lead to about 50% mortality, while submassive BE, and that is when there is no hemodynamic instability, but the right ventricular dysfunction, also has a quite significant risk of mortality. The data on pediatric BE is limited to case reports and case series, but we know that D-dimer is not sensitive or specific in pediatrics, so cannot be used, and also well-score is not validated in pediatrics, so cannot be used. So this is a case that also we've seen recently in our center, and this is an adolescent, like 14-year-old boy, presented to emergency department with shortness of breath and pre-syncope. He had no past medical history of note, and 2 months before that presentation, he had febrile illness associated with dry cough. He didn't seek medical advice, recovered in few days, and he has no family history of venous thromboembolism. His oxygen saturation was low, room air, chest X-ray was unremarkable, and his ECG showed tachycardia and T-wave inversion and ST depression in his test list, we went to 4. He had an urgent echo, and it showed significant right ventricular dysfunction and high pulmonary artery pressure gradient. This is his CTBA, and as you can see here, there was like very large filling defect within the right main pulmonary artery in keeping with pulmonary embolus. And the thrombus was quite large, almost completely filling the vessel with only a thin rim of enhancement along the vessel walls. And on the other side, there was also a second large filling defect in more distal left main pulmonary artery. So the unprovoked submassive BE, we treat him with systemic thrombolysis with TBA, followed by unfractionated heparin infusion. And that child is on long-term anticoagulation. So we switch him to rivaroxaban, so he's on rivaroxaban long-term. We did further investigations. So we had the coag test before we started anticoagulation. So we checked lupus anticoagulant in that, and we took beta-2 microglobulin and anticoagulabin antibodies. And these were all normal. We tested him for COVID, and that was also negative. So we couldn't find, and we did thrombophilia screen. High risk thrombophilia were all normal. So there was no clear cause for his unprovoked submassive BE. Renal vein thrombosis is more common in children compared to adults. It's 10% of venous thrombosis in newborns. And the risk factors, the most common will be nephrotic syndrome and renal transplantation, but many cases will have no risk factor. It is very important to be aware of the clinical presentation because it can be a bit unusual. So if you have a newborn with gross hematuria and thrombocytopenia and palpable abdominal mass, you should highly suspect renal vein thrombosis and do an ultrasound. It can be unilateral in 70% of the cases, but it also can be bilateral, and bilateral can be quite serious with the risk of renal failure and mortality. And if there is life-threatening bilateral renal vein thrombosis, thrombolysis should be considered. And the guidelines we suggest also like anticoagulation. It's bilateral with associated renal insufficiency or extension to the inferior vena cava. But even in unilateral renal vein thrombosis, where there is controversy on anticoagulation or no anticoagulation, the general consensus is that anticoagulation is the better, as you want to also prevent long-term kidney injury. And that is what we do in our center. So even for unilateral renal vein thrombosis, without extension, we treat with anticoagulation for 3 months. In terms of anticoagulation, as I mentioned before, anticoagulation in pediatrics is different from adults. Obviously, unfractionated heparin and low molecular weight heparin can be used in pediatrics because like unfractionated heparin generally or mainly target 10A, while unfractionated heparin targets thrombin. Warfarin also can be used. With warfarin, there's the problem of frequent checking of INR as well as higher risk of bleeding. However, in terms of mechanical valves or triple positive anticoagulation syndrome, the recommendation is to use warfarin. DAWACs were started to be used in pediatrics since approval in 2021. So dabigatran and rivaroxaban were approved in 2021 for the purpose of treatment and prevention of recurrence of VTE in pediatrics. Recently, apixaban, like in November, just done. There was a publication of the trials of apixaban in pediatrics. So we expect to be using it soon. So this is the rivaroxaban dosing in children. So you can notice that it is different from adults. So in adults, for the first 3 weeks, you use 50 milligram BD and then 20 milligram once daily. In pediatrics, you have to give 5 days of parenteral anticoagulation with unfractionated heparin or low molecular weight heparin. Then you can start rivaroxaban, and the child, like in neonates, the child needs to have 10 days of oral feeding before you consider giving rivaroxaban, and the weight needs to be more than 2.6, and you can't give it to prematures less than 6 months when they are less than 6 months. And as you can see here, the dosing is different. So for younger infants, we use 8 hourly, and then 12 hourly, and only on people who are more than 30 kg that you use a dose of once daily. So rivaroxaban. So in our practice, we use rivaroxaban as first line for DVT or BE after 5 days of parenteral anticoagulation with unfractionated heparin or low molecular weight heparin. We use warfarin for triple positive antiphospholipid syndrome as their recommendation from BSH. And we only use IVC filters if we cannot use anticoagulation because of a contraindication. And these will be retrievable filters that we remove maybe about 3 weeks after the event, and when we can use anticoagulation. The other important question in children is, what is the duration of anticoagulation? As we all know, in adults, for acquired or like provoked VTE, the recommendation is to give about 3 months of anticoagulation, and then lifelong if it is not, if it's unprovoked. While in pediatrics, especially in newborns and infants, we can use less than 3 months. So there is a study that looked about 400 children with low-risk VTE, and it found that 6 weeks and 3 months anticoagulation has similar outcomes. So in low-risk VTE, especially in younger children, we recommend 6 weeks of anticoagulation, and then we repeat the scan, and if there is resolution of the VTE, then we can stop anticoagulation. Or if there is still persistent thrombus, then we continue anticoagulation for 3 months. If it is idiopathic, we give anticoagulation for a minimum of 6 months. In terms of recurrent venous thromboembolism or children with antiphospholipid syndrome, we recommend anticoagulation lifelong. In terms of central venous catheters, to remove it or not to remove it, it depends on some factors. The first is it still needed or not? And the second, is it functional or not? So if it is functional and still needed, we will continue anticoagulation and we keep the line. However, if it's not functional, not required, or sometimes if the child has also like symptoms of severe obstruction from it, we will recommend removal of the line after 2 to 4 days of therapeutic anticoagulation. And as I mentioned before, we don't start with oral anticoagulation from day 1. We give 5 days of either unfractionated heparin or low molecular weight heparin, followed by oral anticoagulation for 6 weeks to 3 months in terms of provoked events. As I said, we follow up with a scan, and these are the guidelines that we use for cerebral venous sinus thrombosis, so kind of similar to DVTs. We follow up with scan in 6 weeks in neonates and 3 months in older children. And if there is sinus recanalization, then we'll stop anticoagulation. If the child still has persistent cerebral venous sinus thrombus, then we'll continue for 3 months in neonates and for 6 months in children. If there's an ongoing risk factor, we tend to continue with anticoagulation. If there's absolutely no cause for the cerebral venous sinus thrombosis, we tend to continue anticoagulation for longer, so 6 to 12 months, and then we stop anticoagulation. In children who have recurrent cerebral venous sinus thrombosis, we continue indefinite anticoagulation. What about thromboprophylaxis in children? This is one of the areas that there's still a lot of work need to be done. The American Society of Hematology, as well as the International Society of Thrombosis, has a draft of recommendation that they are consulting experts on, and the consultation will continue until June. So this is still a draft, so it's not published yet, but these are few of the situations that the new guidelines were recommending prophylactic anticoagulation. So infants, children, and adolescents that consider for total parenteral nutrition for long period, more than 60 days, because of the high risk of thrombosis, they recommended using prophylaxis in that context. In pediatric children who has antiphospholipid antibody syndrome, so have persistent antiphospholipid antibodies, and they have previous event, they recommended secondary prophylaxis. So if a child has a previous event, then they recommend that using prophylaxis if they are not on anticoagulation. And in pediatric patients who has leukemia or lymphoma, the benefit just prophylaxis or no prophylaxis, all depend on risk assessment. So it would recommend for children with leukemia to do a risk assessment and decide on prophylaxis depending on the risk assessment. In our center, we have this new guidance that we just started using, and it's just for risk assessment. So we use thromboprophylaxis for children who are 13 years or above, admitted to hospital more than 48 days, if they have 2 or more risk factors. So we use chemical prophylaxis. If it has only 1 additional risk factor, we use mechanical prophylaxis, and no risk factor, we just encourage early mobilization. And that is if there is no bleeding, high bleeding risk. So thank you very much, and happy to take questions.
Thank you so much, Dr. Saad, for this excellent presentation. I don't see any questions, so we'll move to our next speaker. The next speaker is Professor Leonard Valentino. The next speaker is Dr. Leonard Valentino. He's a professor of pediatrics at Rush University Medical Center and president of the World Federation of Hemophilia USA, advancing the organization global mission domestically, and co-leads the Paladin Consortium, focused on accelerating medicine development through patient advocacy and industry collaboration. Dr. Valentino is editor of Expert Review of Hematology and a reviewer of multiple leading scientific journals in hematology and thrombosis. Welcome, Professor Leonard.
Good afternoon, and thank you to the organizers for inviting me to talk about emicizumab and the promise for infants with hemophilia A. On the next slide, we can change to the next slide.
I give you control, doctor. You can move from your side.
Let's see, how do I do that?
You are using a mobile or
iPad. There we go. These are my disclosures. I have nothing to disclose, and the opinions expressed in this presentation are my own. So here's the outline. I'll talk about 6 things. First, cover bleeding in infants with hemophilia A. I'll touch on the guidelines for management of infants with hemophilia A. I want to spend some time talking about a very important clinical trial, the Haven 7 trial. Next, I'll present you with some real-world experience with emicizumab in infants. And then at the end, I'll provide summary and conclusions and end with the recommendations. So next slide. So here you can see a journey slide that goes from the earliest times in the 1930s and 40s, where we had no therapy, to current time, where we're in the advent of cell and gene therapies that you heard from Dr. Pierce and others about this very exciting time. Next slide. For infants, we're not quite there yet. As Dr. Pierce mentioned, we don't have cell and gene therapy for, can you go back to the previous slide? We don't have cell and gene therapy for infants at this point, but we do have a number of treatments, including factor replacement therapies and a number of non-factor therapies, including the monoclonal antibody, the bispecific antibody, emicizumab, which is the topic of today's presentation. Next slide. So, beginning with the importance of bleed prevention in infants. We know that infants with hemophilia A often do not receive prophylaxis. And this is because of a number of reasons. One is they're often not diagnosed with hemophilia when there's no family history of hemophilia, so they may actually present with the diagnosis when they have their first bleeding event. And unfortunately, that can be an intracranial hemorrhage. Also, joint bleeding can occur in infants, and this can lead to devastating lifetime of joint damage. So it's important to think about ways that we can prevent joint bleeding and intracranial hemorrhage. The only way to do that is to begin prophylaxis early. Because of the challenges of venous access, it's difficult to administer factor replacement therapy to infants. Next slide. So the vision of the World Federation of Hemophilia is treatment for all. And this applies to all people with inherited bleeding disorders throughout the entire world. We have to make sure that they have access to care, regardless of the type of bleeding disorder, their gender, or where they live. And I would add another important point, or irrespective of what their age is. So this applies to infants as well. Next slide. On this slide, we see some statistics about the incidence and risk of intracranial hemorrhage. So we know first that people with hemophilia have a higher risk for intracranial hemorrhage, regardless of age. Importantly, neonates have an almost 12 times higher risk of intracranial hemorrhage than other ages of hemophilia. And after the neonatal period, intracranial hemorrhage in people with hemophilia is still increased in infants and toddlers. And in a US-based study, a registry called Community Counts, 8% of infants and toddlers with hemophilia had one or more episodes of intracranial hemorrhage during the first 2 years of life. And in similar data from the United Kingdom, looked at a national cohort. The median age of children with hemophilia presenting with their first intracranial hemorrhage was only 5 months. And only 6% of these children were on prophylaxis. So we know that intracranial hemorrhage risk is higher in neonates with hemophilia A than at any other time in their life. So why don't we do as much as we possibly can to decrease the risk of intracranial hemorrhage? Next slide. So what are the guidelines on the management of infants with hemophilia A? As per guidelines, regular prophylaxis initiated at a young age should be considered the standard of care to treat hemophilia. We have recommendations from the World Federation of Hemophilia, as well as from the National Hemophilia Foundation, now the National Bleeding Disorders Foundation, Medical and Scientific Advisory Council, or MASAC. MASAC says that prophylaxis should be considered as early as feasible. When we're considering giving factor replacement therapy, feasibility is a challenge because of the need to gain venous access. And oftentimes, it's not instituted before the age of 2 or even 3 years of age. And oftentimes, it's predicated on having joint bleeding. And very rarely is prophylaxis initiated in the first 6 months of life. Even though both the WFH and the National Bleeding Disorders Foundation strongly suggest that prophylaxis be administered to infants. On the next slide, we can see the percentage of people with hemophilia that are receiving prophylaxis in various regions. You can see that about a quarter of those with hemophilia in Africa are receiving prophylaxis. Less than 20% in Middle Eastern countries are receiving prophylaxis. And in Southeast Asia, only 3%. But we're not doing that much better in the Americas or in Europe, where you can see there that about 2/3 or under half are receiving prophylaxis. So if the vision of the World Federation of Hemophilia is to prevent bleeding in all people, we're not quite there yet in no regions of the world. Next slide. And this is particularly true in infants. So if we're not doing very well in all people with hemophilia, we're definitely not doing well in infants. So early institution of prophylaxis reduces the risk of intracranial hemorrhage. A recent review by Mancuso and colleagues reported that regular prophylaxis reduced the risk of intracranial hemorrhage by more than 50%. And long-term studies have shown that even a small number of joint bleeds occurring early in life prior to prophylaxis initiation can result in hemophilic arthropathy. And this can be a lifelong problem. So we have two challenges. One is preventing intracranial hemorrhage. The second is preventing joint bleeding and long-term joint complications. Next slide. So what are the challenges and complications of prophylaxis? I mentioned a couple of these. Venous access, of course, is a challenge. If you've tried to start an IV in a 2-month-old, we know how challenging that can be. We also know that by putting a central venous access device into these infants, as the previous talk mentioned, venous access devices can be associated with thrombosis. They can also be associated with infection, and there's a bleeding risk with CVADs. The likelihood of factor VIII inhibitors is also increased when children have venous access. Can we go back, please? Thank you. So the likelihood of inhibitors is also increased when venous access devices or other surgeries are performed because of what are termed peak treatment moments. And it's also very expensive to administer factor concentrates during these intensive treatment periods because of the reduced clearance of factor VIII concentrates in very young children. So prophylaxis with factor VIII replacement in infants is challenging because of the high treatment burden associated with frequent intravenous infusions and the risk of inhibitor development. Next slide, please. So let's move to the Haven 7 clinical trial. This was a phase 3B multi-center, single-arm, open-label trial that sought to evaluate the efficacy, safety, pharmacokinetics, and pharmacodynamics of emicizumab in infants from birth to 12 months of age without inhibitors. Next slide. The efficacy in HAVEN 7 was clearly demonstrated by a low annualized bleeding rate of 0.4, and importantly, a little bit over half of the participants had 0 treated bleeding events. The primary analysis demonstrated a median treatment duration of over 100 weeks with sustained efficacy, both in terms of pharmacokinetics and pharmacodynamics. So to summarize, the efficacy from this trial, which we'll go into on the next slide, was very good. Next slide, please. So in the HAVEN 7 trial, the objectives were to evaluate the annualized bleeding rate for treated bleeds, all bleeds, treated spontaneous bleeds, and treated joint bleeds. It was also a goal to evaluate the safety in terms of adverse events of special interest, immunogenicity, and anti-drug antibodies, and the development of factor VIII inhibitors. As I mentioned, pharmacodynamics and pharmacokinetics was also evaluated. Next slide. About half of the children were under 3 months of age in this trial. The median weight was 7 kilograms, and 3/4 of the infants had a positive family history for hemophilia. 1/3 had prior treatment, and half of those were for bleeding events. The primary analysis and study design is shown on this slide. The key inclusion criteria were that the infants had to be previously untreated or minimally treated, have severe hemophilia A, but not an inhibitor, and no evidence of intracranial hemorrhage. 55 infants met the eligibility criteria and were enrolled in this trial. They received a loading dose of emicizumab, 3 milligrams per kilogram weekly for 4 weeks, followed by a maintenance dose of 3 milligrams per kilogram every 2 weeks. Then the intention is to follow these infants over 7 years. Of course, this is a choice on the part of the family to continue in the study. And we hope that most of the infants will be able to be followed for that 7-year period. As of the data cutoff, which was May 22nd, 2023, 55 of the infants were exposed to emicizumab for a median duration of 100 weeks. Next slide. The primary analysis baseline characteristics are shown here, which I've just summarized for you. It's important to recognize that in the minimally treated as well as in the previously untreated, there were infants less than 3 months of age, as well as infants that were between 3 and 12 months of age. You can see on the left-hand side the age group distribution, where about half of the infants were less than 3 months of age, and half were more than 3 months of age. You can also see there that the historical bleeding episodes prior to the first dose of emicizumab. Most of these episodes were patients who had 1 or more bleeding events, and about 1/3 of them were post-procedural, and only a handful were post-traumatic. Next slide. The primary analysis was bleed-related endpoints. On the left-hand side, we can see the model-based annualized bleeding rate across bleeding categories. The first is the annualized bleeding rate, and you can see there the annualized bleeding rate was 0.4. The second bar on the left is the treated bleeds, and there you can see the treated bleed was 2. The third and fourth are the treated spontaneous bleeds, and the treated joint bleeds, both of which were 0. Patients with 0 bleeds across the bleeding categories are shown on the right-hand side. As I mentioned previously, about 55% of the infants had no bleeding events. You can also see that 16% had no treated bleeds, and 100% and 95% had no treated spontaneous bleeds or no treated joint bleeds. So emicizumab was very effective at preventing bleeding in infants. Next slide. Can we move to the next slide, please? So here you can see a cartoon that shows the bleeding analysis by types and locations. And what is true here is of a total of 195 bleeding events, both treated and untreated, they were reported in 46 of the infants out of 55. And prior to study entry, you can see the bleeding types on the left-hand side versus the bleeding types and locations during emicizumab treatment. It's remarkable in that virtually all the bleeds that occurred during emicizumab treatment were post-traumatic. Next slide. So let's summarize the data from the HAVEN 7 trial. First, there was a significant reduction in bleeding. The number of bleeds decreased from 195 before study entry to only 15 during emicizumab treatment. There was a decrease in joint bleeding, such that joint bleeds were the most common type of bleeding prior to study entry, and dropped to about 2% during treatment with emicizumab. So again, if our goal is to prevent intracranial hemorrhage and prevent joint bleeding, emicizumab was quite effective in doing both of these. So emicizumab was effective in infants, and it maintained a low annualized bleeding rate in infants up to 12 months of age, and the bleeding patterns were similar to bruising and injury in non-hemophilic infants. Next slide. So what's the real-world experience of emicizumab in infants? So let me take you through some of that in the next couple of slides. Next slide, please. The largest amount of data comes from the PEDNET registry in Europe. There were 251 pediatric patients, including infants, that were followed in the PEDNET registry who were receiving emicizumab prophylaxis. Their median age at the start of emicizumab was 6 years. The median follow-up was 1.23 years. And 37% of these individuals had an inhibitor at the start of emicizumab, with a median peak titer of 128. So this data from the registry is quite different than the HAVEN 7 trial data. There was one serious adverse event of retroperitoneal hemorrhage, which resulted in death, and one episode of thrombosis, neither of which were related to emicizumab. Most of the adverse events were local injection site reactions. In the graphs, you can see the bleeding events where both in non-inhibitor and inhibitor patients, the annualized bleeding rate and the joint bleeding rate was significantly decreased, the orange bars, compared to prior to emicizumab, the blue bars. So bleeding was controlled in these in infants and children who had an inhibitor, as well as those without inhibitors who received emicizumab. Next slide. Emicizumab in previously untreated and minimally treated infants. This is data from Hassan and colleagues, 4 infants with severe hemophilia A. They started their emicizumab between 4 and about 16 months of age. All had severe hemophilia A and were receiving emicizumab prophylaxis at a dose of 3 milligrams per kilogram every 2 weeks. No bleeding events, adverse events, or inhibitor development was reported in this small study of 5 infants. The authors concluded that emicizumab was well tolerated and no reported bleeding events, inhibitor development, or other adverse events occurred in these infants with hemophilia A. Next slide. So here's some similar data from Weiland and colleagues. Here's 5 individuals with hemophilia A who received emicizumab. 4 of these infants had severe hemophilia A, and their age ranged from 3 to 12 months, and 3 were minimally treated. The results of the study showed that there were no spontaneous bleeding events during the follow-up period of between 1 and 23 months, and factor VIII prophylaxis was given for bleeding prevention due to head injuries or for factor VIII immune tolerance. But importantly, no infants developed factor VIII inhibitors after 2 to 5 doses of factor replacement therapy. So these authors concluded that infants with severe hemophilia A that were treated with emicizumab received safe and well-tolerated therapy, and there were no occurrences of spontaneous bleeding. Next slide. This study from Bush and colleagues looked at 6 previously untreated patients and minimally treated patients with hemophilia A, including 4 infants with severe hemophilia A. The median age at the start of emicizumab was 8 months, with a range of 1 to 23 months. Their median follow-up was 9 months. What we know, the results here is that 4 of the patients with severe hemophilia A had 0 bleeding events following emicizumab initiation. 2 were diagnosed with high titer inhibitors after emicizumab prophylaxis, and all patients remained on emicizumab with no severe adverse events and no thrombotic microangiopathy, thrombosis, or adverse drug events. The conclusion here was that, again, emicizumab prophylaxis was effective and well tolerated in this cohort of young infants. Next slide. This is another report of 4 cases of emicizumab therapy in infants with severe hemophilia A. The age at the start of emicizumab was between 7 days and 15 months. Factor VIII exposure prior to emicizumab did occur. The duration of follow-up was 6 to 21 months. Here we see that there were neonatal intraventricular hemorrhage or intracranial hemorrhage and challenging venous access were the reasons for initiating emicizumab therapy. The goal was to reduce intracranial hemorrhage risk and avoid venipuncture. The use of emicizumab prophylaxis increased in this study from 2 to 12% in infants during the study period. None of the infants experienced bleeding, and there were no adverse events reported. So again, the use of emicizumab here should be discussed with patients and families. And as we heard from a previous presentation, shared decision-making is so important. But in this population, the benefits of emicizumab is clear that this should be strongly advocated for in that shared decision-making discussion. Next slide. Bargan colleagues reported on 40 individuals receiving emicizumab. The median age at the initiation of therapy in this population was a bit older, 5.5 years. The median follow-up was 45 weeks. And what we see here is that the median treatment duration was about a year. Following emicizumab prophylaxis, There were no thrombotic events. 0 bleeding was reported by 20 of the individuals receiving emicizumab. And all bleeding events that occurred were associated with trauma, very similar to the HAVEN 7 trial. Therefore, bleeding risk could not be totally prevented by emicizumab, as we saw in the HAVEN 7 trial. Injection site reactions, again, were the most common adverse event, occurring in about 10%. No patients experienced thrombotic complications or thrombotic microangiopathy. Next slide. Carpenter and colleagues reviewed the data with emicizumab prophylaxis in 114 individuals with severe hemophilia A. There was data that was available on 14 who received emicizumab. And what we learned from this is, again, that the patients who received emicizumab had very low rates of bleeding, no inhibitor development, and it was a very safe product with no serious adverse events. Next slide. So the real world data that we've seen, next slide, please. The real world data that we've seen continues to demonstrate strong reaffirmment of the HAVEN 7 trial. Next slide, please. We need to move to the next slide. Let's now finish with some summary and conclusions in the last couple of minutes. Next slide. So the experience with emicizumab in infants addresses a significant unmet medical need. Both the World Federation of Hemophilia and the Medical and Scientific Advisory Council of the National Bleeding Disorders Foundation recommend prophylaxis be initiated at a young age in infants with hemophilia A to prevent intracranial hemorrhage and joint bleeding. The results from the HAVEN 7 primary analysis indicate that emicizumab is safe and effective in this population. Effective trough concentrations of emicizumab were achieved and sustained throughout the entire study period of 100 weeks. It's important to also recognize that the primary analysis showed that all treatment adverse events were injection site reactions, and no serious adverse events were considered related to the treatment emicizumab. And importantly, no intracranial hemorrhages were reported. Limitations of the HAVEN 7 trial were that it's a descriptive single-arm study that did not include a comparator group. However, I've showed you real-world data that confirms the observations made in the HAVEN 7 trial. Patients with intracranial hemorrhage were excluded from the HAVEN 7 trial. And of course, this is a very important population that we need some additional data on. The study was not powered to establish evidence of whether emicizumab protects against intracranial hemorrhage. Next slide. The last two summary points are shown here. Subcutaneous emicizumab offers an option of the ability to start early prophylaxis in infants with hemophilia A at the time of birth or shortly thereafter, allowing the infant to grow without experiencing bleeding events. The HAVEN 7 trial aims to collect long-term data as well as the short-term data that's already been shown to you. We hope that we'll have the 7 years of data from these 50 or more infants. Next slide. So what is the recommendation? Next slide. The Medical and Scientific Advisory Council recommends for routine prophylaxis to prevent or reduce the frequency of bleeding episodes in individuals with hemophilia A, including infants, that emicizumab should be used. The recommendation dose regimen includes a loading dose of 3 milligrams per kilogram for 4 weeks, followed by a maintenance dose of either 1.5 milligrams per kilogram given weekly, 3 milligrams per kilogram given every 2 weeks, or 6 milligrams per kilogram given every 4 weeks. Now, the Haven 7 trial only studied the 3 milligrams per kilogram every 2 weeks. Emicizumab has shown significant reduction in annualized bleeding events in all age groups, including infants. The Medical and Scientific Advisory Council emphasizes the importance of monitoring for adverse events, including injection site reactions, but particularly thrombotic microangiopathic complications, as well as venous thrombosis. This is particularly true if and when activated prothrombin complex concentrates are co-administered in the context of emicizumab therapy. And physicians and advanced practice providers should discuss the risks and benefits of emicizumab with patients, their caregivers, and their family members, and consider it as a first-line therapy for those with and without inhibitors to prevent frequent bleeding. Again, the importance of shared decision-making and introducing emicizumab as early as possible in that conversation. Next slide. So with that, I'd like to thank you and offer the opportunity for any questions.
Thank you so much, Professor Valentino, for the excellent presentation. I do agree with you that emicizumab should be started as soon as the diagnosis of hemophilia A is made to prevent intracranial hemorrhages and prevent why make the child experience hemarthrosis and then maybe develop inhibitors, then start emicizumab. So early start of emicizumab is, I think, is really should be the standard care. Thank you so much. There's no questions. We come to the end of today. As we come to the end of the second day of the 6th International Pediatric Hematology Conference, I want to take a moment to reflect on what has been an incredibly enriching and of what we can achieve for children and families impacted by hematological conditions. I would also like to thank you all, all of you, our enthusiastic participants, for staying late till now. As on behalf of the organizing committee, thank you once again for your participation, and I look forward to seeing you tomorrow for day 3. Wishing you all a restful evening. Good evening and bye for now. See you tomorrow, inshallah, at 9 a.m.